his team and all the various companies, Brand Wiley, etc., etc. So many companies have come together to put together this wonderful initiative, Path to Parenthood, which I think is focusing on bringing about a lot of awareness to the public. And I think it's an excellent initiative, and congratulations to you all. Thank you for inviting me here today for presenting my talk on innovating the path to parenthood. Now, how do I change this? It's not working. No. Yeah. Sorry. Yeah. So I'm. Doesn't seem to be working. Where do I point it? Here. No. So we can't go ahead and look at the innovations that have happened in the path to parenthood without actually looking at our past. Where did I okay, so let's go to the past. We will quickly go through how infertility was viewed and how it has been referred to in our mythology, not only in our mythology, but also in various religions in the past. So there have been many references to infertility in the Bible and in Hindu mythology. Sarah, Rebecca, and Rachel were the three matriarchs who were the first three barren women in the Old Testament. So Genesis 16:2 says that Sarah was married to Abraham, and I'm sure all of us know this story, and she had an Egyptian slave called Hagar. And Sarah was married to Abraham for about 50-60 years without any children. And then she sent her Egyptian slave Hagar to Abraham with the hope that he would inseminate her and she would have a baby through Hagar. What happened after that is a whole long story. Hagar did get pregnant. She gave birth to Ishmael. And this may have been the earliest example of surrogacy. Now, what happens in Hindu mythology? Dasharatha, we all know of him, is perhaps the first reported case of infertility in the world. He conducted the Ashwamedha Yagna, and God sent him a porridge, half of which was given to Kaushalya, and Ram was born. 1/4 was given to Sumitra, and Lakshmana was born. 1/8 was Kaikeyi, Bharat was born, and another 1/8 is again given to Sumitra, out of which Shatrughna was born. So there are many instances of this in the world. But from 1920 to 1960s saw a lot of progress in the field of infertility. So 1923, medical researchers identified the female fertility hormone estrogen, which has become a commonplace name for us, and we take it for granted now. In 1929, progesterone was found out. 1943, hormone supplements were developed for infertility. 1950s, IVF testing was done on mice and rabbits. And 1960s, drugs used to boost infertility, especially clomiphene citrate, which is our household name, was developed. 1968, researchers first retrieved and fertilized human eggs, and 1969, medical researchers first fertilized the human egg cell. Again, in 1970s was an era of mega progress. There were initial attempts at IVF on humans. In Monash in Australia, they did have the first human IVF pregnancy, but unfortunately that miscarried within a few days of the patient having conceived. Dr. Patrick Steptoe, who was the gynecologist, and Dr. Robert Edwards, who was the embryologist, performed the IVF procedure in England, resulting in the historic birth of Louis Brown on July 25th, 1978. 1980s, IVF became mainstream. In the 1980s, by the 1990s, more than 1,000 babies were born in the UK itself. So here, I do not know okay. So here this is the baby, the lovely Louise, and it was the result, and that's Louise there, who is now older, and she has got her own 2 children. So Patrick Steptoe and Robert Edwards performed the procedure in England, and she was born in 1978. Dr. Subhash Mukherjee, who was the gynecologist, And Professor Sumit Kumar Mukherjee produced India's first test tube baby and the world's second IVF baby. Unfortunately, this was not very well documented scientifically, and hence he was not given the credit. Her name was Kanupriya Agarwal, also called as Durga, who was born on October 3rd, 1978. Now, this was further by a doctor who went there and who looked at all the documents, and later on, much after Subhash Mukherjee passed away, did claim that this could have been the the world's second IVF baby. In 1986, India's first scientifically documented test tube baby, Harsha, was born in Mumbai. And South India's first IVF baby was born on December 5, 1988 in Gunashila Hospital, Bangalore. So in only 40 years, thank you, a technology miracle has come to be seen as a cure for all fertility problems. So again, we go back to the milestones. 1960, gonadotrophins, which are the mainstay of fertility treatment, were invented. 1970, gonadotrophins and IVF. 1980, cryopreservation came in, which is called as freezing of the eggs, freezing of the embryos. So that was when it started. And 1990, recombinant gonadotrophins, again, which have become the mainstay. Recombinant the FSH and H were made from Chinese hamster cells using recombinant technology, and ICSI was developed. Now, this is how an oocyte looks on the left-hand side. And if you can see, I don't know if I can use this as a pointer, I'm not too sure. But on the right-hand side, you can see the egg, and you can see these sperms. Does this pointer work? I'm not too sure. Okay. So you can see the sperms that are surrounding the egg. Now, this is a example. This is a small video of ICSI, how ICSI is done. So this is the egg. I think we need to play the video. The video is not playing. Yeah. So you can see the needle going there. The needle has the sperm inside it, and it's pushing the oocyte membrane, that is the egg membrane. And if you can see the small rounded structure which goes back and comes back and is deposited inside the egg. So this is intracytoplasmic sperm injection, and this is just a video showing you exactly what happens in the lab. So this was actually initially by accident. It was discovered that this could be done by Palermo in 1990 in the University of Brussels, and the first successful birth took place in 1992. And this was the start of a lot of IVF technology. Now, what are the indications for this? It could be a male factor where a man has sperm which is not satisfactory. It could either be non-motile, or they could have very few sperm, or they could have abnormal sperm. Or you could have surgically retrieved sperms in men who do not have any sperms in the ejaculate, or you could use it in frozen sperm as well. When you talk about non-male factor, it is unexplained infertility, poor quality eggs, poor quality yield, so you don't get enough number of eggs. You need at least 12 to 15 eggs to have a good, successful IVF outcome. So advanced maternal age, prior fertilization failure with conventional IVF. Also, if you want to do pre-implantation genetic testing, IVM, and also for cryopreserved gametes, frozen gametes. So this is just some statistics that we have got. With IVF and ICSI, they do pretty well. The fertilization rate is higher in an ICSI cycle, but finally the number of blastocysts, that is day 5 embryos that are produced, is pretty much the same, and the frozen pregnancy rate is 62% in IVF and 58% in ICSI. Now coming to the present, so where are we? Now here in the present, we have got in vitro maturation of oocytes, we have got long-acting gonadotrophins, fertility preservation in cancer patients, and that could be extended to women who are really not interested in settling down. It is also called social freezing. And then we also looking at single embryo transfers, rapid freezing of the gametes, both eggs and semen, and as well as pre-implantation genetic diagnosis or testing. I can't talk about everything. The topic is too vast, so I've just chosen a few topics So we're going to talk about time-lapse system, genetics and infertility, which includes pre-implantation genetic testing, in vitro maturation, and few others. So EmbryoScope is an incubator which has incorporated a lot of AI in it. It is a special incubator with a built-in camera for looking at real-time imaging of the embryos. So once the egg is inseminated with the sperm, then the embryo is kept inside this incubator, and the incubator takes pictures of the embryos every 20 minutes. So you get a real-time imaging of these embryos. Now embryos are supposed to actually go by a timetable. So within so many hours they should have fertilized, within 4 hours they should have the first division and then the second division, so everything is pretty much time bound. So this not only looks at the time but also looks at the quality of the embryos. So this is actually, we have all read about cell division in our textbooks. You can actually see this happening real time with the EmbryoScope. A lot of AI has been involved over here, and it's a little, it takes a little time. It's a little bit of a long video, but it's beautiful to see. So I don't know if you can actually make out, but you can see that the one cell has divided into two cells, and this is the birth start of life. And again, you'll have the 2 cells dividing into 4 pretty soon. Yeah, you can see that it is divided again. And the cells should be equal, they should be symmetric, they should be equal in volume and size and shape. And this is what would be a day 2 embryo, where you have 4 cell stages. And then as it keeps on, shall we say, dividing, it becomes a ball of cells. And this is something which we got the EmbryoScope in 2011 or 2012, and now it is a day 4 embryo where the cell stages merge and it becomes a ball of cells, and soon after this it becomes what is called as a day 5 embryo, which is called as a blastocyst. So blastocyst is the stage where usually the most robust embryos reach. You can see it is forming a blastocyst here. The middle portion is water, and the water pushes the cells to the side. So you can see that happening. And if you put this into the uterus and this goes and gets stuck inside the uterus, or what is called as implantation, it forms the baby. So this is a beautiful blastocyst, and you can make out at the, shall we say, 4 o'clock or 5 o'clock position that it is hatching. So this is how AI has come in here in a big way, where they are trying to look at whether they can identify the blastocysts or the embryos with the best potential of forming a pregnancy. Now, pre-implantation genetic screening, it is also coming up in a big way. Now, this is basically used to ensure the genetic health of the embryos before they are transferred back into the uterus. So PGTA is used to screen embryos for chromosomal numerical normality. So we all have 46 chromosomes, so we should not have 46 and a half or 47 or 45, in which case the pregnancy doesn't really do well. So it can identify whether an embryo has too few or too many chromosomes, and the first report of genetic testing was published in 1990, but technology has grown by leaps and bounds since then. So PGTM, what is PGTM? We have families where people have married in the family, and they have diseases that can be passed on in generations in these families, like for example thalassemia, sickle cell disease, Duchenne muscular dystrophy. So these PGTM is a technology where you look for these specific genetic problems in the embryo even before it is transferred into the uterus. HLA typing is employed by parents who have, like for example, thalassaemic child, where they have multiple blood transfusions, and these babies could benefit from some sort of tissue transplant like bone marrow transplant. Now, what are the indications when patients come with recurrent miscarriages? Advanced maternal age, 38 years and older, recurrent implantation failure, they have had multiple failed IVF cycles despite putting in good embryos, severe male factor. And what is the advantage? Best embryos can be chosen. Pregnancy rates increase by about 5 to 10%, and the time to get pregnant is much shorter. and hence cuts out the distress and emotional physiological problems that the couple undergoes. And I'm very happy to say that Gunchila Hospital was the first IVF center to start an in-house genetic lab at affordable rates with top quality standards, and it's called as Tatwajin. It was started in 2015. Now, this is how we do an embryo biopsy. So how do you do a PGTA? We have to take some cells from a day 5 embryo, and the number of cells that are taken are about 5 to 8, and we laser every embryo has a shell, so you make an opening in the shell by using the laser shot, which is the green and the red thing that you see, and then you suck out a few cells, and these cells are sent to the genetic lab for further diagnosis. So that is what they're saying. That's what they're doing over here. You can see that the hole has been made in the zona. Zona is the outer shell, and the cells are being sucked out. This does not harm the embryo, and what cells we are sucking out is from the area of cells that is further destined to produce a placenta. This is not the tissue that is going to be the embryo or the baby. So you can see that, and that goes, those cells, that portion of cells goes to the lab. So we have PGTA, where we look for the number of chromosomes, and that is basically in advanced maternal age, repeated implantation failure, recurrent miscarriages, male factor infertility. PGTM is in women or couples who are known carriers of a genetic disease or have had babies who have had genetic problems. And the PGT-SR, there are a small percentage, about 2 to 3% of infertile couples who have a abnormal chromosome genetic makeup, but they are okay, but when they pass it on to their offspring, they end up in abortions. So again, we have now with PGT-A pregnancies, embryos, we have now doing single embryo transfers, and we're getting a pregnancy rate of about 50%. And with double embryo transfers, although I personally don't like twins, because it is very difficult for both the patient as well as the doctor to continue a twin pregnancy, and most of our ladies who get pregnant come back to us. Some of them insist that they want 2 embryos to be transferred, and when we do that, we are getting a pregnancy rate of about 70%. So one of the main advantages of PGT, pre-implantation genetics testing, that is you test the embryos even before you put them for before you transfer them into the uterus for genetic normality, is to decrease the time to pregnancy and also miscarriages. Now, what is in vitro maturation? In vitro maturation is when you take out immature eggs from the ovary and you mature them outside for 24 hours outside the body in the lab, and then inject the sperm into the egg, and then the rest of it continues as a normal IVF. So you would do them in women who are producing too many oocytes, like for example, in polycystic ovarian syndrome, women who are poor responders, oocyte donation program, or in also fertility preservation in cancer patients where there is paucity of time. So I'm not going to go into this because this is a little bit more technical. This is, okay, it's playing anyway. This is an ovary showing number of follicles. It is a very, shall we say, it is a difficult procedure, IVM, because the follicles are very small, and it is very difficult to get into each of the follicles and retrieve the oocytes. Sometimes we get about 60, 70 oocytes, which we don't get in a normal IVF cycle. We don't want to get that many also. It's a difficult procedure, very time consuming, uses a lot of media, very time consuming for both the clinician as well as for the embryologist. Now, going on to TISA and micro-ICSI, I must say something about the sperm. So this is mainly for men who do not produce enough sperm in their ejaculate. They can the sperm can be retrieved by an open surgical biopsy or by a percutaneous procedure. And micro-TISA would be where you actually use an operating microscope and open up the layers of the testis. And the testis has plenty of very, 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 very fine tubules, and you retrieve only those tubules that are slightly swollen, and you hand it over to the lab, from where they will be able to retrieve the sperm. Now, where are we heading to now? Fertility preservation in cancer patients. I want to also let you know that we had our first IVM baby in March 2004, and this was 4 years before UK, actually in Oxford, they had their first IVM baby. So we have, as of now, we have the highest number of patients who have come for IVM. We have about 600 odd patients, and our pregnancy rates with IVM are now touching somewhere between 45 to 48%. Fertility, now where are we heading? We are heading towards fertility preservation in cancer patients. We do this because we have taken it up as a, I was telling Mr. Vijay that we have taken it up as a charity concern, where we are freezing sperm and eggs and ovarian cortical tissue free of charge for 10 years in men and women who have been afflicted with cancer, because once they start their cancer treatment, it could be either chemotherapy or radiotherapy, their ovarian reserve falls, their oocytes or sperms get destroyed. So we currently have the highest data in the country. We have about 600 men who have come and frozen their sperm free, and about 40 women who have frozen either their eggs, their embryos, or their cortical ovarian tissue, all for free. Now, we are heading towards restoring ovarian function, postponing menopause, robotic ICSI. So I do not know whether actually embryologists are going to be necessary in the coming years. Robotic ICSI is pretty much there. Immunology of pregnancy is where they try to prevent miscarriages. That is also, we are heading by leaps and bounds towards that. So all progress is based upon a universal innate desire of every organism to live beyond his means. So the future, what do we have in the future? Future looks very exciting, and according to me, future is going to be genetic based. So genetics in infertility is CRISPR and designer babies, ovarian rejuvenation, which is postponing the menopause, producing artificial ovaries and artificial gametes. And this is gene editing, the CRISPR technology, where actually if they find that somebody has a genetic disorder, they will take out that bit of chromosomes and that bit of the genes where there is a problem, that bit of DNA, and replace it with healthy DNA, or they will reattach the DNA strand. So that is also there. It has been done, but is not commercially available, and it is not in the mainstream. Designer babies, so you want blue eyes, fair skin, tall, intelligent, well-built, Aishwarya Rai types of babies. Yes, you can have them. And a baby whose this is a designer baby, is a baby whose genetic makeup has been artificially selected by genetic engineering to ensure the presence or absence of particular genes or characteristics. Now, this is Dr. Kawamura, who actually helped in ovarian rejuvenation. So this was a lady who had low ovarian reserve or no ovarian reserve, and he actually had a technology where he took the ovary, cut it up into bits, put it into a solution with a lot of growth factors and activating factors with the help of somebody in Stanford, put it back into the patient, and she gave birth to a child. So this is simply amazing. It's happening in Japan. And anti-aging medicine and reproductive health is a new category of preventive medicine that is fast evolving in Japan. And here, when women are unable to have children, they have been given a new hope with scientists trying to create an artificial ovary. So this is all going to come. This is going to come, and not very long. We don't have to wait very long. It's almost there. So artificial ovary, how it works is the 3D printer makes a synthetic ovary from gelatin, egg cells and are inserted into it, and this newly built ovary could be implanted into an infertile woman, allowing her to begin ovulating. Now, they have made a synthetic ovary which allowed female rice which start to function, and they put it into female mice that had been surgically sterilized to reproduce. And this may be one of the things that people are looking at in the future, and it would be amazing, because I find that the trend nowadays is that a lot of young Indian women are losing their fertility, and the reasons for that could be numerous. That's a whole talk by itself. It's called as endocrine disruptors. We won't go into that, but that could be a way in the future. So sperms are being made from human bone marrow, and they have made immature sperm cells from human bone marrow samples, and if these can be grown into fully developed sperm, which researchers hope to do within 5 years, they may be used in fertility treatments, then we may not need men. Men may become obsolete. so really, no, they won't, but then we can still get sperm from men who are azoospermic. Stem cell technology again is coming out in a big way, trying to develop eggs and ovaries, eggs and sperms from stem cells. Also, they're trying to rejuvenate the lining of the womb in the that is called as the endometrium in women who have had tuberculosis, or in women whose lining has been ravaged by infections. Artificial gametes are now being made from adult cells. Men with azoospermia, that means no sperm in their semen sample, and women with ovarian failure may have the hope of getting their own genetic offsprings. Right now, we have to depend upon donor eggs or donor sperm. That may be, hopefully, it will kind of fade away if this technology comes in. And monkeys born with artificial gametes, Roku and Hex. And this is something that I picked up from the internet. It is highly borrowed, and here they have a pod where it's called as, the company is called as Ectolife, and they are saying that babies could be placed in this pod, and it is like a womb. It will simulate the womb. It has the amniotic fluid. It has what shall we say, filters which take out the waste from the baby, the nitrogen, urea, uric acid, ammonia, etc., and then put in the oxygen, amino acids, etc., into the baby. And apparently you can have an app where the parents are looking at the baby, they can sing to the baby, they have sensors attached to the baby's head, so the baby will hear the parent's voice, and all sorts of things like that, which is very futuristic. It's like from a sci-fi novel or a sci-fi movie, Carl Sagan or one of these Steven Spielberg, but we do not know. That seems to be coming, and they have actually developed, put a sheep into an artificial womb and have actually tried to grow it. Do not know exactly what happened to the conclusion, but the future, I want to say, is very exciting, especially with producing artificial ovaries and stem cell coming up to rejuvenate the ovaries as well as the testes. And I think there are exciting times ahead for the public in general. The choices are going to be numerous. Of course, it is ridden with a lot of ethical issues and a lot of ethical problems. So the future holds a lot of exciting possibilities, and looking forward to the same. And I thank you very much for having given me an opportunity to present this talk and give you an insight about what the future holds. Thank you so much again.
Hello. Hi, everyone. We started off from the past, we delved into the present, and we really got to know what the future literally has to unfold. Wow. Can we all give a huge round of applause, ladies and gentlemen? Dr. Devika Gunashila ma'am, that was an insightful presentation, but I want you to kindly stay back, for the team has been working day in and day out to let the world know and create awareness about paths to parenthood. So we want you to join us for the release of the book on the theme Path to Parenthood. So I kindly request Dr. Devika Gunashila to kindly join us here, along with Mr. Ravi Kumar, MD and CEO of NewsFirst. Can we all give a huge round of applause and welcome sir onto the desk, please? I also request Mr. Ashutosh Dwivedi, COO of Wiley Health, to join us here on the stage. I also want Urvi Mehta, Senior Vice President of Brand First, to join us here on the stage. Ladies and gentlemen, this particular event is not just restricted for 2 days, but for all of us to take some memories, some learnings, to share it out to the world. So I want all of you to give a huge round of applause and welcome our beloved dignitaries as we are all set to release the book on the theme 7 Paths to Parenthood. I request team 7 Paths to Parenthood to kindly come forward with the book. Perfect. Wow. The first step taken by NewsFirst on creating awareness on paths to parenthood, it really matters. Thank you so much, team, for doing this. Can we all give a huge round of applause, ladies and gentlemen? Thank you so much, team. I request Dr. Devika Gunashila to kindly stay back to receive a memento, and I request Mr. Ravi Kumar to kindly give away the memento. Yes, absolutely.
I think it's working, right? Yeah, so I actually spoke to Mr. Vijay and Mr. Pradeep about this, from Wiley, about this 7 Paths to Parenthood. I think it's a wonderful initiative. It is to actually bring about a lot of awareness amongst the public, which is the need of the hour. Not everyone requires an IVF, not everyone requires an ICSI. Every patient who walks into the clinic just needs to be counseled, their emotions need to be calmed, their anxieties need to be brought down, and they need to be educated. And I think this is a wonderful job in looking at the various ways that people can approach their fertility problems, and it's a stepwise, logical presentation of the problems that people can have and their solutions. Congratulations, and great, it's a great initiative. Congratulations to you, sir. Thank you.
I request Mr. Ravi Kumar and Ashutosh Dwivedi, both of you, to kindly give away a memento to Dr. Devika Gunashila, and I request all of you to kindly give a huge round of applause. As you all know, we have been discussing about 7 paths to parenthood, which are: the first one, natural conception, assisted natural conception, alternative medicine therapies, medically assisted conception, in vitro fertilization, which is IVF, surrogacy, and adoption. And there are also ways of preserving parenthood, which is called egg freezing. So these are the topics which we are delving into since yesterday. And to all of you who are connected with us virtually, please don't forget to watch the entire episode which we had yesterday, and we are also going to have insightful discussions here at Gate 6 Palace Grounds, the Grand Castle. We also have exhibitors who have set up booths, and you can have interactions and get answers to all your queries. As the team is setting up the stage for the panel discussion, we will take a quick break of a couple of minutes for networking. We're going to get started with the next segment, which is going to be a panel discussion. We want to acknowledge our support system, our sponsors, exhibitors who have made this event, Path to Parenthood 2024, a memorable one for all of us. For the ones who are present in person and the ones who are watching us virtually. Path to Parenthood 2024, an initiative by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, our knowledge partner, Wiley Health. All right. I have a question for all of you, if you are with me. We are talking about fertility treatment outcomes, right? There are several aspects attached to the fertility treatment outcomes. And do you also know that emotional stress also plays a prominent role in the fertility treatment outcomes? Yes, the upcoming discussion that we're going to have is going to be crucial to understand the emotional side of the fertility journey. So let us delve into the panel discussion on navigating the emotional challenges of infertility. We are excited to have a distinguished group of experts with us today. The panel discussion is going to start in the next 2 minutes. So I want all of you to quickly finish your bio break and settle down. For we are going to discuss about the topic, navigating the emotional challenges of infertility. Thank you. Welcome back, everyone. It's time for a panel discussion on navigating the emotional challenges of infertility. We have distinguished group of experts with us today. First and foremost, let me welcome Dr. from Aster CMI Hospital. A warm welcome to you, ma'am, onto the stage. Can we all give a huge round of applause and welcome Dr. Sushma Gopalan, ladies and gentlemen. I also welcome Dr. Archana Karthik from Womb Care Fertility and Research Center onto the stage. Can we all welcome Dr. Archana Karthik? We also have a warm welcome to you, ma'am. We also welcome Dr. Rashmi Yogesh from Kushi Fertility. A warm welcome to you, ma'am, onto the stage. And to moderate this session, we have with us senior journalist Ms. Archana Ravikumar. Let us all put our hands together and welcome Ms. Archana Ravikumar for moderating this session. Over to you, panel and moderator.
Okay, no? Hello. Hello. Good morning, all of you.
Very good morning.
Good morning. To start with, actually, fertility itself is kind of a nightmare. I was just talking to some unmarried people here. They already feel fertility. If they have fertility problems, it can be difficult. So it can be, we can just imagine the plight of couple who already have fertility problems. I'm sure it must be a nightmare through them.
Sure. I feel infertility is like a hidden story. And a lot of times, women don't want to disclose either to their parents or their family what they're actually going through. And when women face problems, it gets very difficult because they start placing themselves too low in their own eyes and in the place of their family. At the same time, when men have problems, I think they also go through equal emotional challenges, but unfortunately, men are not really attended to. So I feel it's a couple problem and both husband and wife go through a lot of emotional challenges. It's a very, very turmoiling journey of emotions, and psychological aspect of dealing with fertility, I think, is the first and foremost thing that has to be addressed.
Yes, true, doctor. Actually, navigating through emotional journey, challenges is the biggest thing for now.
True.
Let's begin with Dr. Archana. So, what are the kind of face as a couple when they come over to you? Or how do you actually go through the treatment with such couple?
See, as soon as they see that they are infertile or they are not able to conceive, we don't say them infertile, but fertility is a problem with them. So when they come to a hospital, before itself they'll be worried about what may be the reason and whether it will be treatable or not treatable. First, as soon as they come from reception till my consultation room, everybody should be very friendly to them, because they are already into kind of anxiety, and some people might have already gone through so many treatments, or they would have come to us. So give a hope from there itself, and once they walk in into your chamber or your consultation room, you should just read their mind. Where are they? Are they into like open up with all the kind of treatment or whatever you're counseling, and where is their situation now? They have gone through, do they have any knowledge about fertility and what is required and all that? Based on that, you should always counsel them that whatever is the issue, we'll tackle. Initially, you should give them little hope and then start with their counseling and history taking. When you take, it's not just a history taking which is related to menstruation or fertility issues. It's about how pressurized they are about their fertility, how many years of infertility they are going through. So based on that, should always plan their fertility treatment, their investigations, and everything should start with counseling them about the normal physiology of menstruation, physiology of fertility, and then make their things clear. Like whatever the fertility issues they have, we have a kind of treatment, or we can help them at each stage. So that's how we start with counseling and the treatment after realizing their mental status.
Dr. Rashmi, yours is Kushi fertility treatment.
Yeah.
So, ಈಗ emotional baggage ಇಟ್ಕೊಂಡು ಬರ್ತಾರೆ, ಖುಷಿಯಾಗಿ ಹೇಗೆ ಹೋಗ್ತಾರೆ ನಿಮ್ಮ fertility center?
See,
ಹೇಗೆ address ಮಾಡ್ತೀರಾ?
what I feel is it's a journey from pain to happiness. And that's why I think it's all about that word khushi and happiness in their lives for which they strive. And I've heard some people telling me, I've interacted with men who have told, Doctor, I've achieved so much in my life, I've grown so much in my career, but then if I don't have a child, it's like my life is zero. When a man tells like that, it really hurts. And women, their tears are most of the times not attended to by family members, unfortunately, despite education being so high in certain families. And that is something that really pinches me. And the most important thing when it comes to fertility is that fertility treatment, or the journey of fertility, is that there has to be a lot of understanding between the lady and the man in her life. And I see the wrinkles around her eyes, the happiness that she shows, all these things are related to the kind of man she has in her life. In case she doesn't get that kind of support from her husband, then she starts feeling very lonely, and that's the most difficult journey for a lady. If her husband is somebody who can understand what pain she's going through and says, don't worry, even if you don't have a child, let's be a child to each other, that sentence will make her really strong. So I feel despite all the support we give, it is the husband who plays a very important role in the entire journey, and the lady should be made to feel that what is more important is companionship between husband and wife, and not just having a child. So I feel the most important thing is to understand the kind of relationship you are dealing with. If you have a couple who has come to you for the treatment of fertility, the first thing I do in Kushi is try to understand what is the kind of relationship the husband and wife are sharing. And if I feel there is a trouble there, I try to address that before starting the fertility treatment. And I feel that's the most important, the crucial crux point in the treatment.
Dr. Sushma, as a psychologist, how does infertility affect mental health?
For example, if I tell right now, ladies and gentlemen, for the next half an hour, don't think about an elephant. Trust me, for the next half an hour, the only thing that you will try your best is you will be thinking about an elephant. The word don't will not be registered in the mind, only elephant will be registered. So the same thing happens when we tell them, don't worry, don't do this. What happens is the don't is taken away and the worry takes over, because they feel that's the most important thing. Like you mentioned sometime back, even unmarried women, girls and men, boys are thinking, okay, do I have an issue? So it's already set in that, okay, there is going to be a problem. So what is supposed to be a normal journey, what is supposed to be a part of the journey becomes an entire journey in itself. And that focus is what leads to a lot of emotional turmoil. For example, marriage and the life of a husband and wife is a huge journey. It's a huge thing, where parenthood is also a very important part of it. So when there's so much focus on this, right from the time they get married, what happens is, for example, the natural mode gets hampered. So what is supposed to be a very, a divine process, a very smooth process becomes so stressful, and emotionally there's so much of baggage attached that it becomes a goal-oriented process. Every month, yes, every month there is like lot of, they check, and it removes the essence from the entire this thing. So that negative emotion is something that we should not be fostering. So that is what happens when they come to the gynecologist also. I think most of the gynecologists also tell them, and then they are also sent to us so that we can also consult them and talk to them and understand what is the mental frame that they are in currently.
Yeah, as soon as they come to us, they'll ask us, Nana, lane problem illa alva. After you explain so many things, they'll say, problem illa alva, doctor, 100% agatte alva. This 100% scares a doctor also. And we should counsel them that everything is just a try. We can't assure 100% that even at IVF, even in IVF where the embryos are beautiful, lining is very good, we can't assure 100% results there. So we should prepare them mentally for positive, negative, both the things. And even the treatment line also we should plan based on their emotions also. We can't directly say an IVF for a person who is totally stressed. We have to give some simple treatments and prepare them mentally. But even though we know they are not the candidates for IUI or simple treatments, but still we should read their mind and plan their treatment.
Yeah, completely agreed. I'm sorry. Because energy matters a lot. See, when you come in thinking that, do I have a problem? The only thing they want to hear is, no, there's no problem with you, it will happen the next month. Which is not going to happen. So they need to come with an energy that, okay, let me see, what next? So that patience is something that is required at that time, and that's the hardest to have at that moment, because you want an instant gratification, which is not going to happen. So very, very important for couples who are into the fertility treatment is to have a mental framework which is strong. I'm not saying full positive where you know things are going to work out. What I'm saying is to have the strength and stamina to know that whatever happens, I'm sure there is a next step to it. It is not the be all and end all of everything.
Correct. Dr. Archana, many people like infertility, fertility actually treatments. How do you address such couple? Repeated failure adaga, how do you address them?
See, my counseling starts even before the treatment starts. So I prepare them mentally when I start the treatment itself. When take it for an IUI or IVF, I'll tell them what is the success rate in each. If it is IUI, I'll say maximum based on individualized success rate. 15 to maximum is 20% in an IUI. So I'll tell them, for you I can give this much of success rate. And what is the drawback in IUI? It's a semi-natural procedure. We can't see the egg quality. We don't know what is the egg quality. What we see is only the fluid around the egg. So I can't comment 100% your egg quality is very good. Some people think, oh, egg release ಆಯಿತು, ನನ್ನ egg ತುಂಬ ಚೆನ್ನಾಗಿತ್ತು ಡಾಕ್ಟರ್, ಎಲ್ಲ ಚೆನ್ನಾಗಿತ್ತು, ಬಟ್ ಯಾಕೋ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲಿಲ್ಲ. ಡಾಕ್ಟರ್ ಹೇಳಿದರು ಎಲ್ಲ ಚೆನ್ನಾಗಿದೆ, egg ಅಂತೂ ತುಂಬ ಚೆನ್ನಾಗಿದೆ. Then I'll counsel them from there itself. And even when they do an HSG or tubal patency test, we don't know the function of the tube as such. We know that it's blocked or unblocked. We can make out grossly whether it is healthy or unhealthy, but really whether it is functioning well, we don't know. Even the unblocked tubes in given ectopic pregnancy, or they may not even function well. Avaga, our counseling makes an effort there that they should not have too much of hopes for positive results also, and that doesn't mean that they should not have hopes at all. So I'll counsel them in such a way that they'll be able to take negatives also. As you said, repeated negatives is very difficult to treat. There we need Sushma, because that counseling is little on a higher side of counseling, where their emotions are taken care of. And as madam said, husband should be very supportive. First thing is husband, then comes the in-laws. If they repeatedly ask them, oh, hereditary negative, ninde no problem, though it is male or female, we should not point out whose problem it is. Then they can take the results in a positive way. Whether it is negative or positive, we have to try. It's only the try from their side and our side. Nobody can give 100% results. That they should be mentally prepared, which we start even before their treatment. Once it is negative, I tell them, okay, it is negative. You want to take a break for a month, you take it, relax, but don't leave the try. In that month also, naturally you try. In that break, so many people conceive because they don't have the pressure of treatment and to come for a scan or timed intercourse. When you say timed intercourse, it's very difficult for them because emotions are involved there. That becomes a more stressful act rather than the treatment itself. So their patients will relax. So in between, always give a break for them once it is negative. Don't do a back-to-back treatment. And counseling from beginning is very important. That's how we tackle patients. And I always ask husband, this is the place where you have to support, and your in-laws also to support her, because she is taking so many treatments. It's only a sperm which is given to the patient, but pregnancy or the injections or whatever the medicine she is taking already. So she's already under emotions. So you have to support. Family and friends are very much important there.
So basically, family is a support tank. Dr. Rashmi, a long-term on the couple, how do you address them emotionally?
See, long-term procedures in the sense, I think you're talking about segmental IVF, where most of the times we do an ovum pickup and we are not able to do the embryo transfer immediately. A lot of people come with the concept that the moment they come for treatment, then within a month IVF will be done and they'll get pregnant the same month. So it takes a lot to make them understand that not every woman who goes to an IVF will have her embryo transfer done in the same month. So we'll have to do ovum pickup, then wait for the endometrial lining of the uterus to come up properly, and only then we do the embryo transfer. Some of them do have challenges with the lining of the uterus coming up, and they take about 2 months, 3 months, even more, and they'll have to go through procedures.
Sorry to interrupt, but generally what is the time frame?
Usually, suppose the ovum pickup is done in the month of Jan, then either Feb or March they can go through the transfer if everything goes on well, and if you're planning for a frozen transfer or not a fresh. And depending on the situations, we decide whether we do a fresh or a frozen transfer. And as you said, sometimes the treatment goes on prolonged. Now the burning issue in today's generation is women who have reduced ovarian reserve. For instance, today morning I did ovum pickup on a lady who had absolutely no follicles in her ovaries, and then after some medications and of course after doing the intra-ovarian platelet-rich plasma therapy, she had a follicle propping up. And today when I did her ovum pickup, the moment she woke up and I told her we retrieved one oocyte, she started almost jumping on the bed, and she was so much excited that she's got one oocyte. Just imagine the kind of anticipation with which they come, and they're just waiting for that one oocyte to come out of them. So this reduced ovarian reserve has become a very big thing, and with women not trying for pregnancy early, it's a very difficult thing for us when we see patients. They delay their pregnancy so much. I see some couples married for 6 years, 7 years, and they would have started trying, say, past 6 months, 7 months. When I ask them, why is that you waited for 5 years to start trying for pregnancy, and that too when you're married beyond 30 years? Surprisingly, 50% of them answer, we wanted to be sure that we're going to stay together. And that is something that is valid, isn't it? So that is the trend now. They want to be sure that they're going to stay together, only then start trying for pregnancy. And when they start trying for pregnancy, the worst part is some of them actually tell us, we wanted to be well settled in life before we start trying for pregnancy. And you know what is the definition of settled for these couples? Getting a house and buying a vehicle or a four-wheeler is what is called settled.
So that they can take their baby
I
back.
tell them, see, you were waiting for your bank balance to go up. And what happened eventually? Your bank balance went up, but your ovarian reserve and your egg balance came down. So you'll have to strike a balance and decide when to start trying for pregnancy. I think in the yesteryears, the moment you get married, it was that, oh, I'm got married, now the next thing is I should have a child. But that's not the thing now. Women are focused, they want to be financially independent, and they want to be sure that they have the right partner in their life, and only then they want to start trying for pregnancy. With all of these, trying for pregnancy is something that is happening after a few years of marriage, and the ovarian reserve is drastically coming down, and there are a lot of autoimmune problems, and post-COVID, a lot of autoimmune problems are propping up, because of which the ovarian reserve is actually coming down, and that's adding to the infertility rates. You know, the incidence of CA breast all over the world is 1 in 9, but the incidence of infertility or subfertility, what we should say, is about 1 in 6. So I think everywhere, in every house, in every family, there will be somebody who is either an inmate of the family or somebody whom they closely know who is dealing with this problem and is not exposed. So I really feel addressing infertility despite the population explosion is a very, very important aspect.
Dr. Sushma, actually grief and loss is quite common in infertility. How do you address such people?
Any emotion, generally when they come out of a gynecologist's office, talking to them at that moment will not help, because the emotions are so high that they will not be in a position to listen or talk. So we have to give them that space to settle down. So generally what happens is they need to be directed to come back after some time to talk, because in most of the cases what happens is the need to talk to someone is so high, but they don't have someone whom they can share. For example, the spouse also might be under a lot of emotional turmoil, so they don't know who to talk to. Sometimes the family will not be capable of handling such situations due to so many challenges even they are facing. Probably they are not able to support in the way that they can. So what we always tell them is, once they go through this phase where there is loss, there is trauma, there is grief, there's always a chance for them to come back and talk to us. We always counsel them. Generally what happens is a clinical assessment can be done, but it will show up a high amount of depression and grief. So what happens is we enter into therapy where we talk to them, counsel them, and the most important thing that is most underrated nowadays is communication with comprehension. They need someone they can talk to who is there to listen with no judgment, not giving them solution or advice. They just want someone to talk to and tell them that it's okay, it's fine, let's go to the next step. Not that yes, it's going to happen or it's not going to happen. Just that I'm here for you, I'm here to listen. Download all your negatives to us so that you go back empty, so that you can fill it in with something positive. And in many cases what happens is we come from a culture where there's a lot of family involvement. So it is not just the husband and wife's journey. I have had cases where the in-laws have come for separate counseling because they are not able to take it. They don't know what to do. So the emotion is always cascaded to somebody else. So I'm not happy, I'll give it to you. You're not happy, you give it to somebody else. The pattern keeps rotating until someone is able to hold it and say, you know what, we'll just keep it down. That's where we come into picture. So talk therapy and various kind of therapies are given so that couples find that space to download their emotions, and also the family. In many cases there are family therapies involved where we connect to everybody in the family and we talk to all of them so that there is a balance and emotional settlement that happens over there, because all of us come with different baggages and each family is not the same. Whatever the wife is going through, husband is going through, it differs from case to case. So we have to give them the time and patience.
Patients, they think as soon as you reveal what is the cause for infertility, you should be very careful. It's a sensitive thing. See, whether you say it is oligospermia or something to do with the sperm quality, then maybe the female start blaming husband because of you have to go through so much. So even if it is a small issue with a female, we should always point out that also, though you not highlight it, but you should always say both the problems. Whatever the small issue with the other partner also should be highlighted, and once it is revealed, you should say that they start thinking, why me? Nanige yaak bantu doctor, nam family yargu illa, nanige enak aagtide idu. Then you should tell them it's not that you have to think about, you should just think what to do next. That is where is the solution. It's not that thinking, ayo nanige hinga agoytu, nanige enakaitu, nanige ilva problem, yargu ilde irod nanige banta, avrige agoytu 30 years ige pregnancy aitu, nam 40 adru agtilla, avrige 42 aitu, nanige 40 adru agtilla. These comparisons should not be there. We should always tell them each individual is different. Counseling is too much. I spend almost 30-35 minutes, ma'am knows. We spend so much on counseling rather than on treatment. Treatment is hardly for 5 minutes, but what we talk to them is very important to take the results. As we know, results are not 100%.
Yeah, that's why I think emotionally they should be very well prepared before the treatments actually. And how do you actually address people who are like, for instance, how do you address stress first thing when the couple come to you? If they're really stressful, how does it actually hinder your process in fertility treatments?
Of course, stress has a lot of effect on a fertility treatment. It may, as we say, adrenals and the hormones, the stress hormones have a negative effect on implantation also. That's why we always say don't ever think about the results, and I usually tell them don't quit your job. When they quit their job, their only stress is pregnancy and its results. When they are into job or some other things, if they engage into, their stress is divided. It's not concentrated on one thing. so that they'll not think about too much about the results. So that stress about the results, especially after an IVF, 2 days prior to their blood test, there's so much stress that they can't sleep also. That effect is on a negative side. Even if it is going to implant, it may not allow it to implant because of those hormones. Sushma always says happy hormones. That should be inculcated by counseling, and we should tell them always engage into some music or anything that which diverts their attention towards. And even the couple should be, even husband should be counseling her each and every day that it's okay, whatever the results is, we'll see what to do next. That's how the stress should be managed about the results, when I say.
Dr. Rashmi, as you rightly pointed, fertility, people want to be well settled before they actually go into fertility treatments. Despite that, it is still expensive. Fertility treatments are expensive, as we know. And that is also adds to the stress already. Like all the financial stresses adds up more. How do you address such couple?
Yeah, we see that not everybody conceives in the first IVF cycle, and people will have to go through repeated cycles sometimes. That is something which is very difficult on their pockets, especially you see people who are in that age range where they are between the age of 25 to 35 or 40, and that is the time during which they are actually building up their career, trying to pile up some money. Despite having in-laws and parents, they really don't want to be financially dependent on them. So it gets very difficult for them. However, we in the field of fertility have different ways to help them out. Nowadays, insurance also covers for fertility. I think we should push more our insurance companies to try and realize that infertility is not an inborn problem, and it is something which is lifestyle related. When you can cover for surgeries, when you can cover for things that come up in life later, why not for fertility and infertility? Right. They should be covering. I think that is something that will bring down the financial burden and the emotional aspect of the financial burden to a very great extent. At the same time, what we also see is that apart from the financial aspect, there are a lot of other aspects women actually face. They start feeling, I've spoken to women who have told me that sometimes, doctor, when I'm unable to conceive despite repeated embryo transfers, when I look at myself in the mirror, despite being the most beautiful woman in my surroundings and also in my family, I feel I'm not a woman anymore because I'm not able to conceive and give birth to a child. When we hear such statements from women, it really hurts us. And I've also heard some women who have opened up and told me, doctor, when the entire world can conceive with pleasure, why should I conceive with pain? These are certain statements which actually make us feel that they are the people who have to be taken care of, and we as fertility specialists, though the psychologists play a very important role, and sometimes with our kind of work we may not be able to give them that time. When we hear people are in real distress, taking them close to the psychologist is the most crucial task we have to do. So I think it's between the embryologist, fertility specialist, the husband and the psychologist that a lady's circle for this journey is completed. And I think the right panel of people are here.
Yes. Dr. Sushma, actually it is more like parental pressure, societal pressure that the couple undergo. How do you advise such people?
Actually, I would like to add to what Dr. Rashmi made a very important point, because what happens is we take it very personally. See, we all have certain characteristics for a man and a woman. For a man, it's the number of children he sires. For a woman also, her womanly in the femininity is basically in the number of children she has. So we all keep allocated time also nowadays. They say, okay, after I'm settled, I'll do this. When that doesn't happen, it's a very big question mark in their entire identity. So they feel there's a loss of identity. And when there's a question mark on identity, the self-esteem, the confidence, self-worth, everything comes crashing down. And the entire soul and whole focus is only on getting the child. Now it's more than the child, it's more like a this thing for oneself, where I know I want to prove that yes, I am worthy of it. So when that sets in, that becomes the entire goal, whole, everything. And some of them come with a lot of trauma in life. They have gone through a very difficult childhood and they feel, okay, now it's time for me to enjoy life. And when this also doesn't happen, they take it very personally. I have done something wrong. God is punishing me, or okay, I'm not worthy of it. So there's so many things that is connecting. So psychologically what we do is we go through their entire lifespan to see where they have come now and exactly why, what are they feeling now. That takes quite some time for us. It doesn't happen in one session. So the gynecologists play a very huge role because they pick up these red flags. The way the mother or the father, the wife or the husband is taking this news, the minute they feel something is not right, then they let us know so that they come and talk to us. In many cases, even if everything seems fine, just to have a check if everything is going on okay or not also, then sometimes the reference comes. And when once we start, we come from the childhood thinking what happened through the marriage, everything, and then we look at them as an individual, the husband individually, the wife individually, and then them as a couple, and then we take them through the journey. And no matter what is said and done, the unit in this journey is the husband and wife. That is the first circle. The second circle is all the other family members, and the last is the society. So that's how the counseling goes.
But I think society becomes more important these days.
A lot. When they become the first circle, that's where all the problems start. See, we always wonder, what will people think? People will get to know we are struggling. People will feel that we are not doing good. There's so many things associated with what people will think. I don't know who those 4 people are, but we're always worried about the 4 people who are going to talk about us. So somewhere the husband and wife have to know that it is only them both.
That's
And
what
then-
I always tell them. Don't answer anybody. If they
Yes.
ask you, just say, yes, I'm under treatment or we are
It's
trying.
going
That's
on.
enough. Don't
Yes.
discuss anything in detail.
Exactly.
They start discussing, the depth is more.
Depth is more, and you never know what's happening behind you. What is the
Correct.
conversation? What's happening? So keep it.
Society mindset has to change, because once they're married, everybody asks them when is the good news
Yes,
coming
They
in.
stop going to marriages and functions. They
Exactly.
think everybody
Right.
will ask, will not. I say, you go, you attend, you have to mingle with people, but don't answer too much of questions. You just say, yes, we are trying, we'll see when it happens. That's how we should answer. We should not
Yeah.
take everything to our head.
And
And
it's
that
just not
answer-
talking to each other when they meet in social occasions. Now you see any social media, you see Facebook, Instagram, everything is announced. Your wedding, the pregnancy test getting positive, the first scan, the first heartbeat scan, everything is shared. And just imagine when your close friend gets pregnant, they would have done everything at the same time, and when you see your close friend getting pregnant and when she's still trying, that adds to the trauma. I think this peer pressure has come in. The
Social media pressure has to be added up to
peer
the
pressure
list
to
now.
get pregnant. I think there are a lot of social issues because of the social media also.
True, doctor.
Agreed. And just to add, if you want to answer someone also, first you need to be grounded. If you need to answer somebody and give them that, okay, you know what, everything's going fine, you need to believe in it. And that's where, you know, that mental strength becomes so important, where you know that, you know what, right now I'm okay, we'll look at the next step, we'll see what happens next. Let's not think too much beyond, and you know, and then answer them. So that grounding becomes very important.
Dr. Archana, for couple who are actually exhausted completely with these treatments and all, what are the strategies you offer emotionally and physically to them?
I usually counsel myself first, and I connect them to a patient who is positive, so that they'll know what is their journey. That positive may not be immediate. They might have struggled for 2 years of negatives, and then so many things, so many treatment strategies have been implemented on them, and then last will be positive result. So there are a couple who have tried for 3 years, 3 cycles. I have seen a couple who is a dentist. She did her IVF for 9 times. I stopped her. I told her enough now. 5th cycle is enough. But she went to somebody else. Now 9th cycle she has conceived. That means imagine her mental stability. So basically they should prepare themselves, and our counseling definitely. And when they speak to other couple who is negative, who is positive, they should be connected to both of them, so that they'll know how to take a negative also, and the positive is not very easy. They'll know both, so that they'll not stop there. They may try, and even if they want to stop, they'll be determined to stop there. So that counseling is very important, and connecting to people is the strategy what I use usually.
Dr. Rashmi, how do you help the couple navigate through the ups and downs of fertility?
See, when it is up and down, dealing with up is very easy because it is all about celebration, and then you all feel happy that there's pregnancy. The downside of IVF treatment is what happens to them after it is negative. The day they are waiting for the beta HCG report is probably the most difficult day in any lady's life. The moment she gets the beta HCG report, and if it is negative, there is such a gloom in her life that she cannot even explain in words. And what happens to her at that point is the most important thing. The counselors have to play a very important role by talking to them one day prior to the beta HCG report and prep her up to face both the ups and downs. At the same time, I would suggest her to be very positive in her approach, and how much ever we tell, it could be positive or negative, but there's so much of anticipation that builds up with the treatment. Even when they try naturally, there is anticipation. Then just imagine when they go through an IVF, the kind of anticipation that is there in their minds. A beta HCG negative, the downside of IVF, difficult day in a lady's life, and it has to be dealt with very, very sensitively, and the husband has to be there with her when she gets the report is something that I specify every lady, that the day the beta HCG report comes, ensure that she's not alone and there's somebody next to her to hold her hands and say, it's okay. That makes a lot of difference. And what I also see is that when women are going through repeated IVF cycles and it is failure, and then ultimately when we have to talk to them something like, if we have to suggest something like a donor egg or a surrogacy, that's the most sensitive part for a lady, to be able to accept somebody else's egg and then have a child. So these are things that are the downside of IVF, and having an IVF child is not abnormal, is something that has to be posed to the entire society. There's nothing wrong in telling the world that I have had a child with an IVF. There's nothing wrong. And now the generation has changed so much. People don't mind wearing Western dresses. People don't mind going to a place where they can have both vegetarian, non-vegetarian food, a place where they can wine and dine. When everything is accepted, why not have a child through an IVF when it is possible? So I think hiding the fact that the child is born through an IVF is something that has to go out of people's mind, and people have to understand that an IVF child is not different from a child who is born naturally, and that is something which I feel all fertility specialists should come out and tell, and also make people realize that they should understand where they stand when they get married, to understand if they can really postpone their pregnancy. That's why we've been propagating, please check your fertility score, check your AMH, and then decide whether it is conception or contraception.
I think it's better said, IVF, they think it is something, a big thing they have done. It's like cancer treatment. Though it's not like that. For some couple, we have to give IVF as a first line of treatment, and that will give more success for them if we do it at an earlier stage instead of trying a smaller ones which will not help them much. So they should be prepared mentally, and they're so hesitant to say they are going through an IVF. That's why they don't even walk into an IVF center. They go to a general gynecologist. They think IVF they won't do. They won't try an IVF. It's not like that. They should be educated that sometimes that is a first line of treatment for you.
I think when they register the wedding, they should have a fertility test. That should become mandatory. It's a better possibility. Dr. Sushma, when is it the right time to seek help for a psychologist?
Generally, usually we start with marital counseling itself. So before marriage itself,
with the registration psychologist.
Yes, we need to tell them, because sometimes, like ma'am said, it takes a long time. They want to settle down, and also get your priorities set. Okay, so sometimes that marital counseling helps, and after that when they come to
Sorry to interrupt, I think we should make a psychological counseling as a package with pre-wedding shoot.
Yes, that goes.
Wedding
that
package.
Helps because
we spend so much for pre-wedding shoot. I think a psychological counseling should be added,
I think
as a compliment.
Psychological consultation makes some, yes, completely agree. And also when they come to the gynecologist visit for the first time, probably if there are any issues, anything like that, it makes a lot of difference if they can come talk to us, and at least let them know that we are available to help them. We are there to listen to them, and they can reach out. And the one thing about the counseling is it's going to be confidential, so they can rest assured that trust can be built in this, and they don't have to worry about things going out. So that is one thing that can be, so it has to be part of the entire treatment.
In brief, Dr. Archana, what is your advice to the people who are watching this?
Don't get scared whatever it is. Walk to your doctor. Initially, get the knowledge from Google, but Google is not everything. You have to speak to your doctor, open up whatever is the emotional problem with you, and couples should come together whenever there is a treatment. That's how we can support each other.
Dr. Rashmi, your piece of advice?
My piece of advice would be, yes, as I told you earlier, check your fertility score, understand where you stand in your fertility score, check your AMH, and then decide. Don't ever think of discontinuing the first pregnancy. My advice to every married couple would be, welcome the first pregnancy, and think whether you can actually take contraception before you actually start doing it. And first trimester abortion for an unwanted pregnancy, when it is the first one, is something that I would say a total no-no, and would always advise them to welcome the first pregnancy. Apart from that, another very important piece of advice to every couple who is going through the entire fertility journey is three important things. One is confidence in yourself. Second is trust in the doctor who is treating you. And third, and the most, faith in God. I think these three things are the most important factors that will let any lady fight through anything that she is going through in life.
Yes, Doctor, right. Dr. Sushma, your last piece of advice.
Only one thing, it's not a lonely journey. It needn't be a lonely journey. There are people to help, there are people to hold your hand, there are people to just sit with you if you don't want to talk also. It is just that you need to find the right people. So please don't travel in this journey all alone. Please reach out to people who are there to help you so that at least the path becomes a bit bearable.
So I think it's when we've accepted all lifestyle diseases, fertility is also a lifestyle disease and all of us have to accept it. I think people should accept it that way. Thank you so much for being on the panel.
Thank you.
Thank you so much.
Thank you.
Wow. Thank you so much, doctors. I think folks who are dealing with challenges in infertility, the way they should seek help and how people around them should be a support system. Very well explained. Thank you so much to the panel and the moderators. Can we all give a huge round of applause? I request Mr. Maruti SH, Editor-in-Chief, NewsFirst, to kindly come forward to give away the mementos. I want all of you to give a huge round of applause, for this was an insightful topic, really, really insightful. And parallelly, I'll give you a quick exercise and explain it to you what is it. I want all of you to fake a smile. Can everybody smile like this for 20 seconds, everyone? Yeah. All right. Thank you so much, Dr. Sushma Gopalan from Aster CMI Hospital. Thank you so much. Can we all give a huge round of applause? Dr. Archana Karthik from Womb Care Fertility and Research Center. Dr. Rashmi Yogesh from Kushi Fertility. Ms. Archana Ravikumar, Senior Journalist, thank you so much for moderating this session so well. I request all of you to give a huge round of applause. Thank you so much, team. Well, let me get back to the exercise that we were just talking about. Are you with me, everybody? Are you all with me? Perfect. So all of you, just smile for 20 seconds. I'm asking you all to fake a smile, and then I'll explain why. All right? 1, 2, 3, smile. The ones who are watching us virtually on YouTube, please do this exercise with me. Go. All right. Now you can relax. Now just look at your state of mind. There's something called the facial feedback hypothesis, which says that the act of smiling, even when forced, it can actually send signals to the brains and it releases endorphins, which actually changes your state of mind to a certain extent. Please give a huge round of applause if you could feel a small difference in your mood. Yes or no? Perfect. Thank you so much. Well, it's time for us to move on to our next segment, which is going to be a panel discussion on the essential diagnostics for the parenthood journey. Joining with us are Dr. Prakrita and Dr. Giriraja Velayudham, from both experts are from Aster CMI Hospital. Can we all give a huge round of applause and welcome our panelists onto the dais. A warm welcome to you, doctors. Ladies and gentlemen, a huge round of applause for Dr. Prakrita and Dr. Giriraja Velayudham, both experts from Aster CMI Hospital. Warm welcome. We also welcome Dr. Sushma onto the stage. Please welcome Dr. Sushma Gopalan from Aster CMI Hospital. And to moderate this session, we have Dr. Soumya Lakshmi, consultant in obstetrics and gynecology. Can we all give a huge round of applause and welcome the panel and the moderator? Over to you, team.
Good morning. Are we audible?
Not much, ma'am.
Yes, I think, yeah, are we audible is what she's asking. Yes?
Good morning, everyone. So we are here for a panel discussion on essential diagnostics for a successful parental journey. I think we've had a very comprehensive panel discussion earlier, which makes our job actually very easy. So that was like a big YouTube video, and we'll do this like a shorts. This will be short and crispy. So my first question, Prakrita, to you. What do you think are the essential steps that you would recommend for an infertile couple who comes in?
So it's very important to understand that when a couple is going through their fertility journey, what infertility means or what subfertility means. So a couple starts planning for a pregnancy and they say, okay, let's start trying for a pregnancy. I think it's in common sense that everybody knows that it's not that the very first cycle they go through a successful pregnancy, right, or a successful conception. So it's very important to understand that when a couple starts trying, every month the success is around 10 to 15%, considering that all other parameters are normal. So this is something that holds good to people who have had evaluation, also for those who have not had evaluation. Of course, if there are some issues with some parameters, if there's a problem with the gametes like the egg or the sperm or any other issues, the success rates naturally come down, right? So this understanding is very important. So here we tell the couple that, okay, since every month it's hardly about 10%, hence you try for at least a couple of months, maybe 6 months, depending upon their age, or 12 months or 18 months, after which, of course, if it's not working out, then you reach out to us, right? But it is very important in today's world because of the lot of lifestyle issues, and there are a lot of stress factors being played around, and the burden of infertility is increasing day by day. So very basic things like maybe getting your ovarian reserve testing, that would be probably getting just to know how many follicles are there on your baseline scan. So that is something we call it as a antral follicular scan. It's an imaging test. It's an ultrasound scan which we do on second or third day of the menstrual cycle, just to roughly get an idea as to how good the egg reserve is. Apart from that, there are other blood tests. Again, this is the AMH which has been previously discussed as well. So AMH also indirectly tells us about the quality and directly tells us about the quantity of the eggs. Now this is one of the very important tests which gives us a timeline to work on. So if the AMH is normal, the reserve is good, that means we have a good timeline where we can try with a couple of few cycles where they can probably try naturally, considering that the other factors are good. For the man, of course, it's very important about his gametes as well, the sperm evaluation or the semen analysis. So the semen analysis is a very basic routine testing that is done. So many of the couples just take a step back here because the woman is ready to get tested, all the blood tests, all the imaging, but then ma'am, you get all this done, then we'll see. So it is not that we get all the tests for the women done and then we go ahead with the men, it is always combined testing. So combined testing is very important. It's the couple who has to be evaluated. It's both the man and the woman. It's the husband and the wife. Because if there's any issue in one of either of these which have been overlooked, there is no point of any number of treatments or any number of cycles going ahead. So basic semen analysis and an ovarian reserve testing gives us a lot of information about it. Apart from this, there are supportive blood tests, like probably your hormones like thyroid, prolactin. So these are all going to indirectly affect your fertility potential. If this is corrected, again your fertility potential may increase. So these are supportive blood tests which have to be done for both the husband and the wife.
So in our OPD also, we see a lot of young couples come in, 21 years, 23 years, married 3-4 months back, already they're under pressure to have a baby. And also like sometimes what happens is they're 35 but they're still not ready for a pregnancy. So does age really, do you think age is a factor?
Yes. Age is a very important factor. So of course everybody is aware of something called as a biological clock, and the clock starts ticking after the age of 30 and all these things, right? But age is very important in terms of the quality of your gametes. Age is the most single independent important factor in determining the quality of the egg and the quality of the sperm.
Just to excuse you, age of both partners are important? Or?
Age of both partners are important. Of course, the cutoff is much higher for men. So in men, after the age of 45, the quality is evidently decreasing. Of course, the DNA integrity does get hampered, right? So for the sperm to get selected in a natural way, when the couple is seeking out for a natural conception, it is very important that for a natural selection, the sperm quality has to be a top-notch one. If the sperm is good, only then it's going to get selected, because the survival is the one which is going to be the fittest that is going to survive, right? So what is the best, that is going to be chosen. So age is a very important factor. And I want to make a point here, because most of our literature, right, medical literature, everything states it as 40. Right? So if you see in Western countries, in UK or US, they start evaluating a woman at the age of 40, or after the age of 40, they see that they're still trying to conceive naturally. But in our country, everybody pounces upon an IVF. No, it's not like that. So it is evident, there is evidence that women, especially the Asian ethnicity, the Southeast Asian ethnicity, us, we age prematurely. We age 6 years prematurely. There are multiple papers on this in journals as well. So what is 40 for them is something at 35 or 36 for us. So we need to, our bell rings early. So we need to be more proactive. You don't have to undergo multiple treatments for it, but just evaluate yourself and know what the timeline is. That is very important. So if something is recommended at the age of 40 or 42, that may be as well recommended here in our country at the age of 34 or 33. That is very important in understanding that why you are undergoing these many tests. So many people have this thing in their mind that, okay, the moment we reach a fertility center, they'll give a huge list of tests and we are just going through all of it. So it is not that there's a huge list or something. So this is just the basic things that we get to know, and based on this, the further plan is made. So it is also important to understand that this doesn't happen just in one night or one day. It sometimes takes 2-3 cycles to evaluate a couple. It's not that, okay, first cycle they came and we did the testing and the next cycle they get pregnant. It takes a lot of time. Sometimes the first test we do only the imaging and the blood test, then the second cycle we may probably do a patency test. It depends upon what time of their cycle they come to us. So the time to pregnancy also varies from couple to couple, and it's not that today I met the doctor and the next day I'm going to get pregnant. So it takes time. So the couple have to be patient, and they need to understand that why they are going through these tests and how it is going to help them and impact their treatment plan.
Just to complete this, we also have people walking into our OPD at any day of their menstrual cycle.
Yes.
They don't even understand that for us, the day one is the start of the cycle. So does the test that you told, both for the male and the female, have a specific timeline?
So in females, in the wives, what we do is basically to know the AFC or the follicular count, antral, that is a baseline scan. So that is something that is done usually on the second or the third day of the menstrual cycle. So that is why we ask the patients to come back or report back to us on day 2 or day 3. There are a few hormones also which are specific to the menstrual cycle. So there are some reproductive hormones that are done specifically on these particular days, which is going to guide us in our treatment plan. And for men, the semen analysis, it is very important to maintain an abstinence period. So this, in relation to the woman's cycle, it may not matter, but an abstinence period of at least somewhere between 3 to 5 days is important, because if the abstinence or the gap is too long, again there will be a problem with the motility, and if the abstinence period is too short, again there may be a problem with the counts. So to get a apt semen analysis report, it is very important that they at least maintain an abstinence period of 3 to 5 days and then come to us so that we can evaluate them.
Dr. Giriraj.
Good afternoon.
It's nice to have a male perspective on fertility. How prevalent is male infertility, do you think? And what are your primary diagnostics to identify male pattern, of subfertility?
So I'm coming for the male prevalence of male fertility. I'd like to explain about some definitions of fertility and male infertility. So what is infertility? Infertility is inability to conceive by couple, even after trying for more than a year, in spite of having frequent unprotected sex. That is called infertility, and is tried for more than a year. That is called infertility. What do you mean by male infertility? So inability to conceive, inability for the male to make a fertile woman pregnant in spite of having frequent unprotected sex for more than a year is called male infertility. So primary infertility is the couple have never conceived before, and the secondary infertility is the couple have conceived earlier and now they're trying for the second or the third child. So this is the basic definitions for the fertility and male infertilities. So coming to male infertility prevalence, so there is no exact values of these numbers, what is the prevalence of the male infertilities. So to be rough, the male infertility prevalence varies from the region to region and places to places. In US it is different, in European countries it is different. Coming to India, there are 10 to 15% of population are infertile. In the total of, in the 10 to 15% of population, around 20% is mainly due to male infertility causes, solely due to male infertility causes. Around 30 to 40% is both combined male and female factors. So overall, we can add it to 50% male factors. And coming to the evolution of a male infertility or male patients, when the patient comes to the clinic, is, as madam already told you, it should be a combined approach. Male and female should be evaluated together. And coming to the male things, 3 basic things we do mainly. One is history taking and physical examination, and semen analysis. It has to be done on at least 2 separate occasions. So this is the basic 3 things we concentrate on: history taking, physical examination, and semen analysis. There are some other special tests we do for special couples, like an ultrasound of the scrotum and hormonal evaluation like FSH, testosterone levels, and sometimes we do go for genetic testings like karyotyping and chromosome abnormality test. These are some of the special tests.
Are those done only if the semen analysis is abnormal?
Only special conditions, like maybe suspecting there is a primary testicular failure and there is an azoospermic patients, then we can have to do for the further test. Otherwise, routinely it is not required.
We have a lot of couples coming, and one pattern that we've always observed is they're lucky if they get they go to a doctor and they conceive immediately. But you know that infertility or subfertility sometimes takes time. So we've seen a lot of patients who've gone to one doctor, seen her for a couple of months, not had success, go to another doctor, go to a third doctor sometimes, and then they treat again from the same point. So they've really not reached anywhere. They've spent a lot of money, they've spent a lot of time. And in a couple, when somebody wants something and they don't get it, then that small little amount of friction starts. So how do you, deal with couples who actually started on this journey happily, but at some point have kind of started to start to feel a little bit of derisive about each other?
So generally, whenever I see parents, they see, the thing is, when the reason why they change the gynecologist or they change the doctor is because they feel that, okay, might be there's not much of a problem, but they're not able to identify. Let me see if this person is able to do it. Let me see if I get lucky with this person. It comes out of a need or a desire or a want to actually get what they want. So this could also be because of lack of where they're not getting a comprehensive understanding of what exactly is happening. No one can give them 100% assurance and say, you know what, this is going to happen at that time. But they are trying to see if there is somebody who can give it to them, because we all want some control. The minute we know things are not in our control, we are not okay to accept it. So whenever they come for counseling, the first thing that I do is psycho-educate them on the entire process. Not on the medical basis, but completely on the emotional and the plus and minus of what is going to happen. It is a completely uncertain process. So that acceptance is something they need to know. Yes, there is a problem, there is a solution, yes, but how the solution is going to turn out is something they don't know. So they have to trust the system. So they have to do a complete background, they have to talk to the gynecologist, understand the pros and cons, and the first thing they need not do is Google. So whatever questions and doubts they have, they need to talk to the gynecologist. So basically in my session, after psychoeducating, I ask them to write down whatever doubts they have. They take it back to the gynecologist, they ask all those doubts, so that the doubt doesn't remain in them, which makes them go from one person to another.
So when do you propose, should the couple see a psychologist at the start of their journey when they start getting treated, or?
It is better. It is always better. See, just because they come see a psychologist doesn't mean that there is some issue with them. Many of them don't come to a psychologist because the first thing they say is, we are completely fine, we are okay, there's no problem. It is not that you have a problem that you're coming to us. We can anticipate some difficulties in the journey. If you don't have the difficulties, we're very happy. But if you are going to have some difficulties, let us get the coping strategies in place so that you are well equipped to handle the journey. So it is better they see us before they start all this, so that clarity is there in their mind.
Dr. Prakrita, we've also seen, talking about young couples not having children, but we also know how couples who've had one child sometimes have had 2 or 3 children, sometimes also got a family planning surgery done, and then during the tsunami we had patients who had lost 2-3 of their children and they had come back. And we also now, for whatever reasons, people do lose their first child, or sometimes for no reason at all, they've had one child and then they find it difficult to conceive again. So what would your advice be for, what is your line of approach for those kind of couples?
So such couples we label them under the term of secondary infertility, where they've already had one child or even had a pregnancy, but that didn't end up in a live birth. So they might have had abortions, or they might have had live births, and they might have had, like you said, they have lost one of their child, or they have had a child who's having autism or various other issues because of which they want to have another child. So here again, counseling is very important because couples with secondary infertility who have taken treatment for their first pregnancy are more open to undergo a same set of diagnostic whatever tests or the treatments. But couples who have had previous spontaneous conceptions and then they come. So here the most important reason why they come to us is because of the time constraint, because they have a belief that they have been able to conceive normally previously, and that is something that they could do even now. But then there is a time constraint that, okay, in 6 months I need to get pregnant, in this given timeline I need to get pregnant because I'll be flying to some other nation or something else, there is some other plan. So here it's very important that we again go through all their routine evaluation as well. So it's not that they have conceived normally, it is a definitive proof of their equality. That is what I give them credit for, that you have conceived normally previously. That means nature has trust in your eggs. That means your egg quality is good, your sperm quality has been good at that point of time, and that is the reason you have conceived naturally. But down the line, if the pregnancy has been way long back, say some couples come with a gap of almost 10 years, 12 years, first child at the age of 12 or 13, and they come for a pregnancy because the firstborn wants a sibling. Right? So here the parents are, it's a very tricky situation for the couple as well, because it's not easy for them to navigate through this, because they are, for them the family is completed, but then the firstborn keeps asking for a sibling. I want a younger one. So here again, it depends upon what your condition is. Don't force yourself into a pregnancy because your child is asking for it. See how well you are put up with it. Are you emotionally good enough to carry another pregnancy is important. Are you stable in all aspects to carry another pregnancy? That is important. Are you physically fit? Right? That is very important. For example, there are couples who come at the age of 39 or 40 or 42 as well, and they don't want to try any alternative treatments. They only want to try naturally or some supportive treatments, maybe with medications. But of course, it should be a natural conception at the age of 42. But their AMH is very poor. The egg reserve is almost declined. So in these cases, a natural conception is more of a miraculous thing, rather than where we see that, okay, we can try and help them with some follicular scans or try to see them, but the selection has to be natural. So here, making them, trying to reach out to them in a realistic way is very important. Giving them realistic expectations is very important. Telling them this is what it is. It is not something that, okay, because it was all green the first time, it's not going to be a cakewalk the second time. At the same time, support them and help them to where they want. So there are couples who are very clear that they do not, no matter what, they are okay with a child if they have to go for an IVF or for the treatments, higher treatments. They are okay with one child. So give them what they want. It's not what the science advocates or what it is. It's basically more of what the couple wants and what they are seeking. So if somebody who's not open for that kind of a treatment, there is no point in pushing them towards that. At the same time, if there is a history of abortions, now this is even more desperate, right? You are able to conceive, but then you are not able to carry the pregnancy till 9 months, or you are not able to get a healthy child out of it. So this here, the frustration builds up. There's a lot of stress that adds up. Many a times there are couples who have not been able to conceive only because of stress factor. So there are couples who undergo cycles of IVF, and everything is beautiful because they've had a previous conception post tubectomy, like you said. They didn't want to go through the laparoscopic route or the tubal recanalization route, and then they want to end up with an IVF. But then there is extreme stress because they've had a loss of a child, or there are so many other things that is built up in their mind. No matter what, the best of the best endometrial linings, the best of the best embryos is not going to give us a conception. It is the state of the mind that is going to be very important in these conditions. So it is all the more important that we go in depth and analyze what the state of the mind is, and then accordingly tell them this is what realistically you are going to have. Like if your AMH is low and you don't want to go for higher treatments like IVF or anything, then this is what we are going to be dealing with. And if it happens, it's good. But if it doesn't happen, this is something that you need to understand and you need to accept it, right? That is very important.
You know, even a natural conception, when you have one baby, it's a little bit of an adjustment for the first one. And for couples who are having a secondary infertility, the treatment process itself takes a lot of their time, you know, emotional and economical. So how do you think then that couple or that unit should also deal with the baby that they already have, their first child?
Generally, parents, whenever I broach this topic, they say we don't discuss anything in front of the children. But one thing they forget is children pick up on energies. So if the father and mother are not okay, they're unhappy, every time they go to the hospital and come back, there is murmuring, there is small talks. After a point, from the relatives, everybody, the child will get to know that, okay, there is one more baby, and the parents want one more baby. Many a times when I have spoken to the child has said, my parents are not happy. My parents are not happy with me. So the child does not understand why the parents are not happy. The child feels that because he or she is not okay, or something that the child has not done. So the parents have to be extremely mindful of the fact that the child who is watching them doesn't understand what's happening but is taking everything on oneself. So this journey is something they have to take it as part of their life, not the complete life. The focus should be equally divided with the first child and also concentrate on the treatment. If the complete focus goes on the treatment, the negative energy not just impacts them, it impacts the child, and it becomes a cyclic loop, because the worry now is, why is my child behaving like this? I'm already going through so much. On top of that, he or she is also troubling me. So it becomes a completely vicious cycle. So when they come for counseling also, the psychoeducation is given and counseling is given. We also talk to the older sibling to understand what is their understanding, so that the parents form a stronger unit with the child and they do this journey together.
Dr. Giriraj, can you explain how surgical options such as varicocelectomy can help men in their fertility?
So before knowing the treatment option for the male infertility, maybe conservative management or the surgical options, you have to know the three basic pathophysiology behind the male infertility. So the three basic pathophysiology is, first one is low or altered sperm production. It may be oligospermia, it may be teratospermia, it may be asthenospermia, maybe combined. So second one is complete absence of complete failure in the production of the sperm, the azospermia. The third one is obstruction to the passage of the sperm, obstructive azospermia. So these are the three basic pathophysiology behind the male infertility. The reasons are etiology are many, like genetic factors or hormonal factors or an infective factors or a traumatic factors, endocrinology factors, all the etiology. The basic physiology is the three basic pathophysiology behind the male infertility. So male infertility can be divided into three groups depending on the treatment options. One is treatable, one is uncorrectable, one is untreatable. The treatable options include around 12% of the male fertility groups. They are like mainly surgical options like varicocele or obstructive azospermia, where we do a vasovasostomy or vasoepidermostomy. For varicocele, we do a varicocele repair, and sometimes ejaculatory duct obstructions will be there. We have to do a resection of the ejaculatory duct. These are the surgical options for the male infertility. So uncorrectable causes include some severe oligospermia or teratospermia, where they are not able to be managed or treated, but then be corrected with the ART options, other options like ART. So there is some group called untreatable male infertility groups. This is around 10 to 12%. They are like primary testicular failure, serotolin self syndromes, and there is absence of both the testes, like post-orchidectomy status. So there is no complete treatment there. So they are, even ART also is not possible in these cases. Then we go for other alternative options like donor inseminations or adoptions.
Can you walk us through the essential tests and screening couples must undergo before the IVF process starts?
So IVF is a different ball game, right? So of course the basic tests which we do when a couple come to us when they are seeking for fertility, those are some of the routine tests like we discussed first. Maybe it may be the thyroid profile or your routine sugars, your hemoglobin, and your other few hormones like prolactin. In an IVF, added to these tests, so IVF entails at the end of those 12 to 14 days that you take everyday injections and where we stimulate the ovaries. So at the end of the day, we are going to retrieve those eggs, right? So this is something that is done under anesthesia. It may be a just IV sedation, or it may be general anesthesia itself. So to undergo an anesthetic procedure, you need to be fit. Of course, there will be a thorough pre-operative checkup which is done by our anesthetist as well, to make sure what kind of anesthesia has to be given and what is the nature of the drugs that needs to be given, and is there any constraints in giving any anesthetic, in anesthesia. For example, there might be some other comorbidities for patients like some cardiac disorder, hypertension or uncontrolled sugars, because of which again the nature of the anesthesia may change. So based on this, there are multiple associated tests, like if the comorbidities increase, there may be an advocated 2D echo as well. Apart from that, there are routine testing, pre-operative checkup like your sugars, your hemoglobin, the serology part, all the serology. Many patients question, why are we doing serology here? So this is to protect yourself, to protect your doctor, the support staff, everybody. So serology is very important here as well. And the other, your thyroid hormones, everything that is going to have an impact on you when you undergo the anesthesia. That's the whole point.
So could you just throw some light on treatment of patients with azoospermia?
I didn't get you. Azoospermia. So as I told, the azoospermia can be divided into obstructive azoospermia and non-obstructive azoospermia. As I already told, obstructive azoospermia it can be managed with the surgical options like vasovasostomy, depending on the cause, vasovasostomy, vasoepidermostomy, ejaculate duct resections. Coming to non-obstructive azoospermia, which majority of times is managed with the ART techniques. Very difficult to manage with the conservative management, so it's managed with the ART techniques. And ART techniques, majority of the task is taken by the gynecologist or the IVF specialist. The andrology role in the ART comes very little role. So the three roles of the andrologist in the ART techniques. So first one is counseling the male. Getting the male to the OPD infertility clinic and making him undergo the investigations and convincing him the male factor behind the cause of the male infertility, and convincing for male to undergo a ART is very, very serious process. It's mainly done by the partner and the family members and by the gynecologist and IVF specialist. Andrologist doesn't do much in this thing. Only small counseling has been done by an andrologist. And coming to the harvesting of the sperm. So there are many techniques to harvest the sperm. We do a PISA, it's called percutaneous aspiration of the sperm from the epidermis, or we do a microscopic aspiration of the epidermis for the sperm aspiration. Sometimes we go for testicular biopsy, sometimes we do a micro TISA. These are the techniques of harvesting the sperms. Last comes the sperm cryopreservation or the sperm banking. We counsel male partner for undergoing a cryopreservation for the future purposes. That is the role of andrologist in the ART.
Sushma, we'll sum it up with you. So how do you propose that, couples undergoing, they keep up their resilient spirit, and most of them are also anxious about the results. So how do you kind of, tell them that it's a long journey, but they have to be resilient?
Most of the problems have a solution, and if there is no solution, then there has to be acceptance. And we also have to know that there are some things which are under our control, there are some things which are not under our control. That point is something every single individual, not just in aspect of fertility, but in general, they have to understand. The second most important thing that I suggest to all couples is, let them keep an open mind and not get bogged down by one or two negatives that has happened in their life. So when they come to a gynecologist, when they come to a fertility specialist also, let them come with an open mind and also know that there are some things which is not under their control. So we will do the best we can and we'll hope the best we can, and we will see what next. More so if there's already a child back home, so that mindfulness has to be even much more. And if this is going to be the first child, then that mindfulness has to be even more so, because it is a part of their life. So let them take control of what they have under this thing. For example, the physical activity, management of their emotions, these are things that's in their control. So if they are able to take charge of all this, this is something, I'm not saying it's going to get solved, but they will be better equipped to handle it. And please reach out if you are not okay. That is one thing that every individual has to do.
Thank you very much. I think that brings us to the end of our discussion.
Thank you.
Thank you. Thank you.
Thank you so much, doctors. Thank you so much to our panelists for providing us such detailed insights into the diagnostic tools available today. May I request Mr. Ashutosh Dwivedi, CEO of Wiley Health, to kindly come onto the stage to give away the mementos for our panelists. Can we all give a huge round of applause, ladies and gentlemen? First and foremost, Dr. Prakrita from Aster CMI Hospital. Thank you so much, Doctor. Go fast. Giving the one in lasers. Dr. Giriraja Velayudam. Thank you so much, Doctor. Dr. Sushma Gopalan from Aster CMI Hospital as well. Thank you so much, ma'am. Thank you so much, Dr. Soumya Lakshmi, for moderating the session so well. Let's all join together for a group picture. Thank you so much. Team, we are at the Path to Parenthood 2024. What an interesting initiative where we are talking about taboo topics for others, but we are actually taking that first step of creating awareness to people, to couples who actually are seeking to embrace parenthood. And this initiative is by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, our knowledge partner Wiley Health. Let me tell you all an interesting thing. The most neglected part when it comes to the topic of fertility is the male fertility. And we should all know that male fertility matters, definitely matters. It is an often overlooked but critical part of the equation. To speak about this important topic, we have with us Dr. Santosh Gupta, Clinical Director and Infertility Specialist at Nova IVF, Bengaluru. Let us all put our hands together and welcome Dr. Santosh Gupta onto the stage. A warm welcome to you, ma'am.
Good afternoon, you all. I thank Path to Parenthood to invite me here and have an opportunity to address all the august audience here. So, from morning we are talking about fertility and always we talk about female, but male fertility matters as an individual, and otherwise also why it matters is infertility is a couple problem. It cannot be an individual problem, and it impacts us socially, at a religious point of view, mentally, self-identity and self-confidence. So let us understand why male factor fertility it matters. See, 15% of couple in this world are suffering from infertility. It is a huge population. Almost 50% of them either have associated or isolated male factor issues. Infertility is listed as a disease by WHO, so every person has a right to have a cure for disease. Till today, this problem was women-centric. Either it is a blame game or treatment. So when it comes to blame, when we say women are sufferer, but treatment part, always men are neglected. Men are also equally affected socially and mentally when they do not have children. And most of the men, unfortunately, what I have seen in my practice, they take it very, sperm count is low, they feel it will affect their sexuality, their manhood and personal identity and self-esteem, which is totally a myth. So we need to address this factor, and to bring down the worldwide statistics, why it is more important is, this is a temporal trend in the sperm count. The average sperm count in 1940s was above 100 million per ml, which in 1990 became 66 million per ml. And from 2000 onwards, because of the change in lifestyle, there is a global decline in 2.64% of fertility in men. If this trend continues, by 2060, probably the natural fertility in men will disappear. So this is something we need to address and discuss what we have to do with the men and their fertility. It is really a matter of debate, and all developed countries, because of various issues and male factor also, they are seeing a total fertility decline. Their fecundity has reduced beyond the replaceable population. So that is also, as a country, as a population, as a world, we should be worried about where our future generations are. So today what I am going to talk about is, first and foremost issue is the awareness about the problem and what we can do. Last week also, it's a general thing. I watched a movie. In that, one man went for a semen analysis, and the report, it was shown as a oligoacinospermia. That man has hidden his report, and wife by chance has seen the report, and she thinks my husband cannot conceive, and men also think same. That's why he's not sharing the report. And wife goes and seeks a donor semen without his consent. Luckily in India it is not possible, but that's how the story spins us. It tells about the lack of awareness. If men knew that oligoacinospermia can be corrected or it can be handled through IVF or fertility treatment, he can still be a father. Probably he would have not done. And if wife was aware that these things can be handled, she would have not gone for the donor sperm and other issues. So awareness is the key, and the men should understand that sperm count is not related to their sexuality and manhood. A person can have zero sperm, still can be a completely sexually active male. Then what are the investigation needed? Counseling, we have discussed enough from the morning, and treatment option, how to improve the parameters. If parameters are not improvable, then what is the role of ART procedure like IUI, IVF and ICSI procedures? So it's not that today Path to Parenthood has taken this initiative. There are many, many websites and forums on the internet which talks about him fertility. We always talk about her, madam, or women, or mother. They are talking about him fertility, and they are worried, and they are discussing it is time to tackle the men problem. So it is not we. So I appreciate that initiative for that. And before understanding any problem, a basic thing we have to understand how the male reproductive system works. Spermatogenesis happens in the testicles. From testicles, sperms get collected. They come out through a duct called vas deferens, and it is come out through penile urethra during the sexual process. And it's stuck. And the spermatogenesis happens in the fine tubules in the testis, and the adjacent stromal tissue, the testosterone being produced. Although testosterone influences the spermatogenesis, but in absence of testosterone also, in absence of spermatogenesis, there is enough testosterone in most of the men that we have to understand it well. So whenever we talk about evaluation of male, Apart from making him comfortable, we have to take a detailed medical history like any other disease. There has to be a physical examination, because most of the clinics, either it is a fertility clinic or a general OBG clinic, we skip men from history taking and we don't examine the men, and then only we have to subject them to the laboratory investigation. I would put a word here that always talk to couple in a private consultation room. Your consultation room cannot be surrounded by 10 people, lot of staff, lot of your assistant, and 1 or 2 patients walking around, because when we talk about the history, mainly it is the sexual history which you have to ask, their time of intercourse, frequency, whether they are able to be together during fertile period. So unless and until you offer them privacy, they will not open up. You have to ask leading questions in a private and comfortable environment. The sexual dysfunction, there could be a ejaculatory and erectile dysfunction. Again, they need privacy and some kind of comfort to tell you. Use of lubricant jelly, which could be spermicidal. They may be doing everything correctly. Maybe this could be the cause of their fertility problem. Intake of some kind of drugs, like nowadays going to gym is a trend. And the bodybuilders usually do have a very low sperm count or a 0 sperm count, but in a way, because they over-exercise and they take steroids and anabolic steroids, which may reduce their sperm count, and surgery of private parts, hernia, cancer treatment, all these you have to take in the detail, which can provide you some clues towards the treatment. Then the general examination and examination of private parts. So undescended testes, shrunken testes, hydrocele, hernia, you can see examining the scrotal, and the penis, the urethral meatus, hypospadiasis, phimosis, these are the few things which you can rule out by doing a general physical examination. And obviously you have to rule out varicocele. A word of caution, the varicocele is the most abused diagnosis. A clinically palpable varicocele is only varicocele which is clinically significant. Then is the laboratory investigation. For men, otherwise things are easy. If everything is fine, the semen analysis is the foundation of the laboratory investigation. And what we see in that is the volume, liquefaction, mainly sperm count, sperm motility, and morphology. So when we do a semen analysis, again few things are very, very important. How to collect the semen sample and where. If you have asked from home collection, the semen sample should be collected in an appropriate container, and should reach the center within 30 to 60 minutes. It should be kept at body temperature. Otherwise, best is to do a semen analysis in your clinic and examine there. And your clinic should be well equipped with all kind of equipments. They need a stage warmer also to give a proper motility. So as the sperm counts are falling, I think WHO is doing the task. It is reducing the sperm count and motility as a normal marker. So in today, 2021, where we stand, sample has a 1.4 ml of volume, 16 million per ml concentration, 42% of motility, and 4% of morphology. That is, out of every 100 sperm, only 4 should be normal. Then it is considered as a normal semen sample. But there is a trick in that. See, WHO, although it's a vast organization and globally we are too many, they have taken sample of around 2,000 men, not across all the continent or all geography, and who has recently been father, and they have given us a normal and abnormal range. Just 2,000 with a restricted geography, I think it is an injustice. Suppose if we believe in these semen parameters also, you can see from 5th to 95th percentile, it is considered as a normal semen parameter, but you can see the differences in 5th percentile and 50th percentile. A 5th percentile has 15 million count and 73 million count is the 50th percentile. These are the men who are maximally fertile. So there is a lot of difference. So what we say normal, is it normal or not, we don't know. It's something we have to include more and more men and do further research about it. Just 2,000 men cannot represent a worldwide fertility. Then another interesting point is sperm is a very highly differentiated cell. Its job is to carry a DNA forward to the next generation. To do that job, a normal cell gets specialized. It's a compact nucleus which carries the DNA for the future generation. There is a cap which allows them to penetrate into the egg, and there is a tail which gives lot of motility so that sperm can reach its destination. It's a highly differentiated cell. That's why majority of them are abnormal, and up to 4% also we consider is normal. Again, a word of caution: in today's urban lifestyle and stressful lifestyle, in fact, it is difficult to find men with 4% normal morphology. What semen analysis and parameters we are seeing every day is roughly 2%, 1% of the sperm morphology. So definitely fertility is on decline. Then another important thing is to look for infection. See, when we do a semen analysis, small round cells which otherwise we consider as pus cells can be seen, but this could be immature spermatid or immature sperm. So to confirm that, leukocytes should be confirmed with a peroxidase staining. We do get semen sample and reports from outside where 5 to 6 pus cell, without checking they will write. For a semen sample, if it is more than 1 pus cell per high power field, it is a leukocytospermia. So we have to be mindful about our reports we are generating. And if there is a leukocytospermia, then empirical antibiotic therapy as a first line of treatment we can give, and repeat semen analysis can be performed. And if a person has repeated semen infection, then probably semen culture is required. Otherwise, in general, semen culture is not required. Then come to the blood test. If semen analysis is normal and history and sexual functions are normal, for men in general blood tests are not required. If there are abnormal semen parameters, then endocrine evaluation of the men is required. Like in women, FSH, LH, our pituitary hypothalamus control our ovaries. Like that in men, pituitary hypothalamus control testicular function. So FSH, LH and testosterone and prolactin, these are the 4 hormones. If FSH, LH is high, that means there is a primary testicular failure and pituitary is trying to stimulate the testis. The testis is at fault, there is no spermatogenesis. If FSH, LH is normal, then probably it is it could be abnormal spermatogenesis. We should look into further detail. If FSH, LH is very low, and then probably it is a hypogonadism, hypopituitary hypogonadism. That means our pituitary is at fault. If prolactin is high, we have to look for prolactin secreting tumor. These are the specialized tests. Then further advanced tests are not required in everyone, but there are very few specific people where we need further specialized tests. One is the DNA fragmentation index. If there is unexplained infertility, that means all sperm parameters are fine, still couple are not able to conceive, probably you can do a DNA fragmentation index, DFI, or there is a person is smoker, or there is a recurrent semen infection, still we can do. If there is a bilateral obstruction, it's an obstructive azoospermia, and there is vas deferens is absent, probably then we can ask for genetic test, CFTR. Some men are curious to know why their semen parameters are so low or why they have 0 sperm. Then you can ask for karyotyping and Y chromosome microdeletion if sperm count is less than 5 million per ml and if motility is very much compromised. Some men, there is something called retrograde ejaculation. Means they are, instead of ejaculating outside, they are ejaculating, the semen sample is going in urine. If you take a careful history, you can find out these patients, and post ejaculation, if you check their urine sample, probably you will find the sperm. And transrectal ultrasound to check for any prostatic pathology, ejaculatory duct obstructions. So these are the few specialized tests which are not required in all men. Then again, let us begin. If we get a 0 sperm count, should that man should be hopeless that I cannot be a father? First, he should know he is not the only one. 1% of all men in this world could be azoospermic, which is a very, very high number, because it's such a personal thing, nobody discuss with each other, and we think that he's the only one who has a zero sperm count. 10 to 15% of infertile male can be azoospermic. One semen sample cannot judge a man. You have to do 3 semen sample before labeling him as azoospermic. You have to spin that semen sample and you get a pellet in that. We have to check that pellet. Then only we can label it in a, as a azoospermia. So the crux point is the man is not only one, and one semen sample cannot, sometimes if they have fever, there's a poor collection, it could come as a azoospermia and very next sample could be normal. So when there is a azoospermia, it could be obstructive, it could be non-obstructive. So obstructive azoospermia, usually the testicular volume is normal, hormonal profile will be normal, and when we do a surgical extraction, which is very, very simple, it's just a needle prick, it's a very simple procedure, you could do under anesthesia or a local anesthesia. If we retrieve those sperm, a person can father a child using surgically retrieved sperm by means of IVF and ICSI procedure. So again, in today's time of technology, if technology is available, we should be thankful to our stars that we are born in an era, because before 2000 the ICSI was not available. We are born in that era where male factor fertility, even if it is not treatable, can be dealt with advanced technology. Like we all were walking, then cycle came, then car came. When we drive car, we don't feel that we are smaller or we can't walk, we have incapacity. But when we opt for IVF, that feeling is still there among patients that I am lacking something, that's why I have to go through a IVF ICSI. So probably more forums like that create more awareness, and acceptability of these kind of treatment will increase. Then these obstructive azoospermias, we can manage very well with the surgical retrieval of the sperm and doing IVF ICSI procedure. If there is a normal ejaculate, but then FSH is very high, testes could be normal or a shrunken testes. These are the one you have to counsel them. They may have spermatogenesis or no spermatogenesis. Sometimes they have a patchy areas of sperm production. So we have to do TISA or micro TISA. We have to tell them that we may retrieve sperm, we may not retrieve sperm. If we retrieve sperm, we have to freeze them. So these kind of procedures should be done in IVF clinics where you can freeze those retrieved sperm and use them later. If we do not retrieve sperm, then adoption or the donor sperms are the other procedure. But we shall not decide only on the basis of high FSH or low normal FSH. Any number of FSH, whether it is normal or high, cannot say that we will not get sperm or we will definitely get the sperm. So we have to do the procedure and then take a call about it. Then any person, if they want to prognosticate whether I will get sperm in my TISA when we do surgical retrieval, so this is the advanced genetic test which is known as Y chromosome microdeletion. If there is a deletion in A and B, we will not get the sperm, and if there is a microdeletion in the C, 50 to 60%, we will chances that we will retrieve the sperm. So these are the sperm retrieval techniques which our doctor in previous panel have discussed, and what I come today is the most correctable part and where we are lacking about is lifestyle. Although we are all following the modern lifestyle, we are adopting a very unhealthy lifestyle. So biggest problem in urban men is obesity. Obesity does not cause only blood pressure and diabetes, it reduces your sperm count and motility as well. So obesity, sedentary lifestyle, your occupation, you may be working in a factory, chemicals and furnace, or sitting always on laptop, wearing the clothes which are too tight. Mind you, nowadays even in clothes lot of plastic is there. Even in the jeans they put plastic. So your cloth, what you are wearing, you have to see. Smoking and alcohol, which has become like a normal lifestyle today, can cause male factor infertility. Drugs and substance abuse, few medical drugs, otherwise recreational drugs, also causes infertility. Steroid and anabolic steroid, we see lot of patients in urban and semi-urban area. There are a lot of gyms cropping up. Everybody wants to have muscles because our movie stars have now all six packs and everything. And these men are the one who have zero sperm count. If they stop taking these steroids and the supplements what they get from gym, it can recover. It can recover. And environmental toxin, we should be aware, minimize use of plastics, synthetic chemicals, perfumes, whatever we can do. We cannot change the earth which we are living, but what is in our hand we should do. So these lifestyles are very, very much important. I had a patient, he had a low sperm count. Then he said, I am taking hair fall medicine. Hair fall medicine has androgens. So when he stopped it, in 3 months his sperm count recover. So these are the lifestyle problem. And whether we believe or not, stress is a modern life phenomena, and today's man is a caged man in his life. It's like a caged animal. And long back I have attended one seminar where a zoologist have spoken. They have compared semen parameters of a chimpanzee and lion in the forest and chimpanzee and lion in the zoo. And there was a chalk and cheese difference, whereas zoo animals were fed nicely, but because they were stressed and they were caged, their semen parameters were very low, including DFI. So we try to liberate ourselves from the stress of our modern life. Then obesity is a known risk factor, 1 to 2 times higher infertility. The sperm count will be lower in the obese men. Why? Because this extra estrogen is produced in our tummy fat, and which increase the estrogen in our body, and this abnormal estrogen and testosterone ratio will reduce the spermatogenesis and sperm motility. So these obese men, after proper counseling, are asked to lose weight, and aromatase inhibitors are the drug which can play some role for these men. But style. Then a word about varicocele. Varicocele is nothing. It is a dilated veins around the scrotum, around the testicle in the scrotum. Most of the men will have varicocele, especially left-sided. So only grade 3 varicocele is important. Don't get influenced by a Doppler finding. Every man will have grade 1 varicocele. So varicocele which is detected only in Doppler has no meaning. When a varicocele surgery has to be done, when it is grade 3 varicocele associated with abnormal semen parameter, there is a normal and treatable female factor infertility. After surgery, it takes long time. If the female partner is old or her AMH is lower or any which way they need IVF, then probably varicocele surgery has no meaning. Then comes the most important part, oligoasthenospermia, what we see every day. That means men has a sperm report, count is less, motility is less, and morphology is less. In general, what we go for is the empirical treatment. Lifestyle matters, but probably empirical treatment has no role. As the doctor in previous panel has said, only 12% of male factors could be treatable. 70 to 80% will remain as such, and another 10 to 12% are untreatable. That means even IVF cannot help them. So these 70 to 80%, we have to counsel them well. We have to evaluate them as a couple. If time do not allow us, we should not waste our time in the empirical treatments. But again, if they are taking testosterone from some doctor that testosterone will increase their sperm production, I think they should stop it. It will reduce the sperm production. Anabolic steroid, again muscle building they take, again it will reduce the sperm production. These are very common drugs which people take. Then clomiphene citrate or if we take these anti-estrogen for a very long time, they also reduce the sperm production. They work in a short period. For long term, they will reduce the sperm production. So for medical management, we can give antioxidant, we can advise some kind of motility enhancing drug, but do not waste the couple's time for that. Another very important where really medical treatment works is the hypogonadism. That means their pituitary is not working, FSLH is not releasing from pituitary. It takes a very long time, but such patients are given on injectables, HCG and LH and FSH, and they will slowly start showing sperm production. But again, there's a lot of counseling required. Then the key message is empirical treatment for idiopathic oligospermia is not recommended. Infertile men with hypogonadism, their treatment work. In that, HCG is the treatment of choice. Then comes the unexplained infertility, where everything is normal, still the couple is not conceiving. Always we blame women, but probably we should do a DNA fragmentation index for the men if it is high. If it is high, it says in a trying naturally and probably in IUI pregnancy rates are less, but ICSI is able to bypass the impact of DNA fragmentation. And for the sperm sorting nowadays, some advanced kind of sorters are available, which I will talk about. So sperm DNA fragmentation index could be high because of high ROS or high oxygen free radical. So putting them on antioxidant therapy, lifestyle modification, if there is a varicocele, if there is an infection, treat them and consider ICSI as a treatment. And when we are giving treatment, handle that sperm sample well. If you keep it for very long time, probably DFI will increase. Short abstinence, ask that man to ejaculate at shorter period, process the semen sample as appropriate as soon as possible, provide them appropriate temperature. Incubation should not exceed for more than 4 hours. And when you are using them for treatment, these are certain kind of equipments, kits available, MACS and PIXI. These are the techniques for sorting sperm which have lesser DNA fragmentation index, and we can use this sperm for further treatment. ROS also, there are tests available you can detect. Otherwise, put them on antioxidant, and putting antioxidant blindly may not solve the purpose. Probably you have to look for the causes of reactive oxygen species, which could be stress, varicocele, infection, smoking, drug abuse, pollution, or obesity also. So my thing is, if sperm count and motility is less, you try for a short while. If it is not improving, then ART is the answer. We should not shy away from accepting the ART. IVF ICSI has changed the way male factor infertility is looked upon. Before late 90s, even severe oligoacinospermia, because ICSI was not there, IVF was all about pouring an egg around lot of motile sperm. So even IVF couldn't solve that problem. So we should be blessed that today we are dealing with the patient with the technique of ICSI. And this is something for male factor. Our doctor has tried to divide them into 5 groups, and these groups just to address male factor infertility in a more precise manner, so that we should not blindly treat them. It is beyond to discuss them in detail. I think it is not on this forum, but just for the awareness, the 5 groups are there, and you can treat your patient in a more precise way. So I end up in my talk with this kind of take-home message. I think awareness is the key. Treatment comes later. Awareness is the key. That's why these forums play a very important role. Treatable male factor is only 18-20%. Uncorrectable subfertility, it is not absolute infertility. Subfertility is 70-80%, where timely intervention of ART is the best option. Appropriate counseling of the couple to choose right treatment, right time is important, and it is not blame game. Always welcome a couple in your counseling chamber and is your consultation chamber as well. Thank you very much. Thank you very much.
Thank you so much, Dr. Santosh Gupta, for highlighting the significance of male fertility in the parenthood journey. Yes, awareness is the key. I request Urvi Mehta, Senior Vice President, Brand First, to give the token of gratitude to Dr. Santosh Gupta. I request Urvi Mehta to kindly come forward to give a token of appreciation to Dr. Santosh Gupta. I request Ravi Kumar sir to kindly come forward to give away the token of appreciation to Dr. Santosh Gupta. Can we all give a huge round of applause, ladies and gentlemen? I request Urvi Mehta to kindly join us here on stage. Can we all give a huge round of applause? Urvi Mehta, Senior Vice President, Brand First. Now, we are keen to hear more about how Ayurveda integrates with modern IVF techniques, enhancing IVF success rates with Ayurveda's support. Please welcome Dr. Shweta Suvarna, Ayurveda gynecologist and medical superintendent at Apollo Ayurved. A warm welcome to Dr. Shweta Suvarna. Over to you, ma'am.
Thank you, Mr. Gokul. Good afternoon, everybody. Since morning, we have been hearing the experts from IVF. We had experts on male infertility. We had experts speaking on psychological counseling. So here I am, right, standing in front of you to talk about the contribution of Ayurveda in improving the success rate of IVF. I come from Apollo Ayurved, which, it's not moving. I come from Apollo Ayurved. We've been here in the healthcare system for the last 2 decades, being the pioneers in integrative medicine as well as the leaders in precision Ayurveda. We are proud to say that we have a patient satisfaction rate of 98.6%. That's because the way we deal with our patients, we empower our patients, which is the major role played in infertility management as well. We are the most awarded chain of hospitals. We were the first one to be awarded DL Shah National Quality Award, and the first Ayurveda hospital to be NABH accredited in India. We have a 20 years of heritage in Ayurveda Chikitsa excellence, having 15 centers across India. Now, coming to the topic where I am speaking on how Ayurveda can enhance the success rate of IVF. Before me, there was a lot of discussion happening around the IVF, the success rate, and how psychology, how male factor, all contribute to the success of IVF. Here, we know that IVF has been a boon to the infertile couple in terms of getting the better outcomes. Though there are certain areas where there are IVF failures. We've seen that through the Society of Assisted Reproductive Techniques says that the IVF success rate is 55.6 for the couples under the age of 35, and it is 40.8 for the couples between 35 and 37 years, and only 4.1% for the couples above 42 years of age. So we can see that the success rate is not 100% anywhere. And also it takes at an average, the National Institute of Health says it takes at an average of 3.6 IVFs to have a successful pregnancy outcome in most of the patients. So this gives us a scope to see how we can improve this success rate through Ayurveda. Majorly, if we see the reasons or the causes why there is IVF failure, the first and the foremost would be the poor ovarian reserve. The second being the egg and the sperm quality. Third being the endometrial receptivity and implantation issues. And fourth, majorly, which was discussed in the previous sessions as well, is the stress and the lifestyle issues. So, major failure revolves around these 4 factors as the key causes for failure of IVF. So, in Apollo Ayurveda, we have taken up a task of, I'm sure most of the IVF specialists and the gynecologists who presented here before me would agree that some percentage of their patients are already under Ayurveda treatment. But the difference here when we say integrative management at Apollo Ayurveda is, we have a dialogue with the consultant, that is the IVF consultant or the gynecologist themselves. The doctors are aligned. The doctors discuss what is the outcome that we are looking at and what are the areas where each one of us can contribute. So this gives a better outcome to the patient rather than the patient themselves going and opting for different systems of medicine. In Ayurveda, we say there are 4 factors. It is called as Dhruvam Chaturnam. That means 4 factors that are responsible for healthy conception is Rutu, Kshetra, Ambu and Bija. Along with this, our acharyas have mentioned that to have a healthy pregnancy, it's also important to have a Saumanasyam Garbhadharanam. That is a pleasant mind which contributes to most of our hormonal variation and unexplained quality is the pleasant mind, or the Saumanasyam is a key factor for healthy conception. So we saw in the previous slide that there are 4 reasons which Ayurveda states for a healthy conception, and here we are talking about the 4 factors which we saw for the IVF failure. So all this factor nothing but boils down to the 4 factors which Ayurveda mentions. That is Rutu, Kshetra, Ambu and Bija. So when we are talking about Rutu means nothing but the appropriate time for conception or the ovulation period, and also about the reserve, ovarian reserve that is there. So Ayurveda gives specialized techniques how we can improve the Rutu factors. Next is the Kshetra. Kshetra is nothing but the uterine factors, how healthy uterus can contribute to a healthy conception. So these are the factors. The third factor is Ambu, which talks about the hormonal alignment and the circulation within the uterus, which are again the factors which are very, very important during the IVF. The triple lining that is important during the IVF. All of this comes under these 4 major factors. Next is the Bija. Bija is nothing but the male and the female gametes, that is the sperm and the ovum. A healthy sperm and the ovum can contribute to a successful IVF. So these are the 4 factors which Ayurveda has mentioned as how it can be improved through some of the Ayurveda techniques, and how we can achieve a healthy conception even if the patient is going through IVF or through a natural conception. How do we bring about these 4 factor improvement or enhance these 4 factors for the patient? So at Apollo Ayurveda, we have a personalized care that is designed for the patient, where there will be a diet planning, there will be a lifestyle planning for the patient, individualized plan for the diet and lifestyle changes through their ahar they take, the lifestyle that they live, and the medicines, which are purely herbal medicines that is particularly selected for their condition, and through some of the Panchkarma therapies. So these is, and the major part, we saw in our previous discussion, most of the discussion revolved around the psychological well-being and the counseling that is required. So in Ayurveda, we have a special way of understanding the body type of the person, which is called as Prakriti. Based on this, they will have certain nature for their physical as well as the mental attributes. So that is that can be corrected through their diet, through some of their lifestyles, and through the counseling and the medications. So when we are talking about the people who are going through IVF, there's a lot of apprehension because IVF is physical, mental, and a financial drain to the patients, and there's a lot of societal pressure that they go through when they are going through the IVF procedure. In Ayurveda, not only the Panchakarma procedures, but we also help them through different other procedures like yoga, meditation, and music therapy to overcome such psychological apprehensions. So now talking about the Panchakarma procedures in detail, majorly when a patient is going through the IVF procedures, there are chances of improving certain factors of fertility in them through the Panchakarma procedures. When I say Panchakarma, it is 5 procedures that will help to take care of the body as a whole. It is not just looking at the fertility factor, because we know that certain times even metabolic factors like obesity and all this can contribute to the low fertility score in both the couples. So going through a Panchakarma, a person can have benefits even if it is due to some of the metabolic disorders or due to some of the not only the hormonal correction but also metabolic correction can happen through the Panchakarma procedures. Majorly the Panchakarma procedures that will be employed for an IVF, for a couple who are looking for IVF or success through IVF would be Vamana, which means using a therapy to cleanse the body through a process of inducing vomiting. The Virechana, a process of inducing purgation, which does the total detox of the body. And Nasya means instillation of medication through the nasal route, majorly helping in bringing in the HPO axis alignment, which is the hypothalamus, pituitary and the ovarian axis alignment, which majorly is the hormonal play in fertility. Next is the Basti. Basti is a rectal enema which is designed to bring about the improvement in the sperm as well as the ovum quality. And a specialized technique in Ayurveda called as Uttara Basti, which is equally employed for male and female infertility, where a medicated substance is introduced into the uterus or into the penis in male. So through our last 2 decades of work, where we have worked closely with the infertility experts, we have seen gynecologists and the infertility experts, we have seen that Ayurveda can contribute great in terms of improving the low AMH, in improving the poor ovarian response, in inadequate endometrial lining, where the patient is going through IVF but there are these concerns. Ayurveda can definitely help in these stages. In epigenetic factors, we see that there's a lot of health conditions that we see in the newborns or the kids of late. That is because of the epigenetic changes that happens. Epigenetics means it can be altered because of our diet, because of the environment around us, and because of the stress that we undergo. So Ayurveda can definitely bring about a major change in the epigenetic factors, also improve the quality of the sperm and the ovum, and also in conditions like oligospermia, azoospermia, there can be a great contribution through the Panchakarma, the Ahara, that is the diet, and the Vihara, that is the lifestyle changes that can be advised through the Ayurvedic principles. Not only disease specific or the condition specific infertility, but also as a whole person care, Ayurveda can contribute in management of stress levels, weight management, diet and lifestyle corrections, which are the major contribution for most of the infertility. That was the contribution what Ayurveda can do in enhancing the IVF success. Now I am talking about the preconception care, Preconception care is a concept where both the couples who are in the path of parenthood looking out for a total detox for their body, because to improve the sperm and the ovum quality. That is, everybody desires to have a happy and a healthy child. When anyone is looking for a happy and a healthy child, we know that because of our lifestyle, maybe because of the work stress or the lifestyle that we are leading, there's a lot of factors which has been derailed in our body. To align those, Ayurveda has a concept of preconception care that the couples undergo even before they plan their pregnancy, which brings in a major change in the quality of the sperm and ovum and can prevent a lot of disease condition that can be passed through the next generation through the sperm and ovum. So this is a boon to the couples if they want to see that the next generation is not carried on because of the lifestyle what the parents have had. So I would say Ayurveda can contribute not only for natural conception or improving the quality of sperm and ovum, that also improving the preconceptional chances of couples having a healthy pregnancy, but also improve the IVF success rates through the proper implementation of the Ayurvedic principles of Ahara, Vihara, Aushadha and the Panchakarma therapies. Thank you.
Thank you so much, Dr. Shweta, for giving us an insightful look into how traditional and modern medicine can work hand in hand. Can we all give a huge round of applause to Dr. Shweta? I request Maruti SH, Editor-in-Chief, NewsFirst, to kindly come forward to give away a memento to Dr. Shweta. Thank you so much, ma'am. Thank you so much. Well, I want all of you to be seated. Please don't leave the venue because this is going to be a very, very interesting segment for all of us. In times, in times where people don't come forward and share their stories about IVF, I think this is that segment where we have someone who's going to share his personal story amongst us. So I want to introduce, first of all, Hoopsters, a first of its kind hybrid non-academic educational platform. The goal is to create a community of change catalysts who are well informed, aware, empathetic and proactive. They provide the right resources, curated programs and continued engagement to help achieve these goals. Hoopsters integrates multiple domains and subject matters with a special focus on mental health, parenting, life skills and sustainability. This platform is designed for individuals of all age groups from toddlers to senior citizens. To know more about Hoopsters and to learn about their special programs, go and log on to www.hoopsters.in. As a part of creating awareness, we have with us Mr. Sachin, who will share his personal experiences with fertility treatments. Can we all give a huge round of applause and welcome Mr. Sachin.
Good afternoon, everyone. I hope I'm audible, and it's a wonderful afternoon that we have here. But more wonderful than the afternoon is the event that's happening here. Who am I and why am I here? Okay, I won't say me, but I will say we. We are Sachin and Radhika. My better half is not here today with us, but she's busy with something else. But I am here, and we've been married for 19 years now. Yeah, 19 years is a big time. Though it feels like 50, but at least 19 is there. Yeah. We are blessed with a daughter and a son. They are twins. Okay. Radhika is a banker who's earned a professor and still teaching banking is still teaching banking. I've been in sales and marketing for the last close to 30 years now. I worked in the pharma, in the FMCG, and for the last 24 years I've been in the building industry in sales and marketing. But that's not what brings me here. What brings me here is, you know, that we are talking on something which is never spoken about. Matter of fact, when I was called upon and said that you can come here and speak about this, even I was hesitant. The only reason I was hesitant is because what I find is most communities speak inwards. You know, you find doctors speaking to doctors, counselors speaking to counselors, but the people who are affected, are they speaking to each other? And when they speak, there are only whispers. There are no bold talks. There is nobody who speaks aloud about it. And why don't they speak about it? Because they carry sort of a stigma. I hope what I share with you today, my journey, our journey, Radhika and my journey, it helps people who are looking out for that ray of hope, and they catch on that and they are able to improve themselves. Okay. With that, let me start. I'm actually going to say that there is hope in art. When you say art, it means ART. ART stands for artificial reproductive techniques. Okay, and it engulfs everything. It engulfs something where you just counsel to going in for some high-end treatments too. Okay, but I'll not be talking more about ART. I'm talking about our journey. Radhika and me got married in 2005, and when we got married, you know, our priorities were very different. Our priority was not to expand our family at that time, but our priority at that time was probably to set our lives well, set the stage well for the life to be better. It took us 3-4 years before we could even think of conceiving. In 2008, okay, that's when we first thought that we should start conceiving. We started trying. Believe me, 2008, 2009, 2010, 2011, it took us 3-4 years to realize that it is not just about us, but we might need some assistance. And in those times, assistance, was it available? Yes. But as I said, it was all undercovers, not something that was very open, not something that I could go and speak to my friend who is sitting next to me, but I had to keep it very, very quiet, you know, and that's where we started. Is there something wrong about looking at assistance? I don't think so. But the problem is that we cannot speak about it. And that's what I would say to people who are actually looking out for assistance, that the first thing that you need to do is accept that you need this assistance. This assistance is not bad. It only helps you to live better, to become better. When we started going to doctors, we went to many doctors. Believe me, we went to many doctors. Some doctors pointed us in a certain direction, some others pointed in a different direction, but it took us some time to settle out and meet with a doctor who also became our friend over a period of time. And this is when we were in Pune. I'm talking of about 2011-12, and that's when the doctors started speaking to us. They shown us that, you know, it is possible, you can go through it, and you all will be successful, you all can conceive. With that hope, we started. We went through many things. We went through IUIs, multiple IUIs. We went through, I don't even know the name of the treatment, but we went through one more treatment, and then we also went through IVF. And when all these things failed, then the doctor said there is something else. We need to delve a little deeper. A deeper study showed us that, you know, there was a small medical condition which needed some treatment. And once that treatment is done, then we could probably look at IUI again. And that's exactly the time when my job got transferred from Pune to Bangalore, and we had to shift to Bangalore. We came to Bangalore, but we still continued consultation with the doctor. We took a reference back in Bangalore over here. She gave a very good reference, and we met up with that gynec as well. That gynec said, okay, you go out, finish this small treatment and come back. We went That treatment takes 6 months. That was a 6 months treatment. We shifted here in September of 2013. We started the treatment somewhere, I think, in the Jan of 2014. And in the June of, towards the end of June or July, towards the end of June, I think, yes, we finished that treatment of 6 months. And after that, we went in for another round of IUI. And believe me, this time it was very, very difficult. It was difficult not only from the perspective of what we went through, but also what my wife went through at that point in time. And that's where I would say that this is something that I would share to all husbands, to all partners who want to conceive together. You have to be with your partner. There was not one IUI, not one IVF, not one treatment where Radhika has gone alone. I was always there with her. Was it easy? Absolutely not. You manage your profession, you manage your family, you manage your priorities. You have to manage this part of your partnership also. Is it easy? Easy? Absolutely not. But you still need to do it. And I think that is where the commitment comes. You need to be persistent about this. You know, you cannot say, "Ke aaj hua, kal nahi hua," and then, you know, so you just leave it at somewhere in between. The moment you lose that persistence, you will lose hope. And the moment you lose hope, you find a dead end. But you continue doing what the doctors are guiding you to do, somewhere you will find that spark coming through. You know, it took us 3-4 years to do this. You know, at a point when, as I was saying, you know, the last treatment that the IUI we went through, at that point, Radhika and me were at our wits' end, and we were at a point that if it doesn't happen this time, we will move from this and probably look at options of probably adoption. That is a time when we had got so worked up that we said we need a trip. So we went out for a trip. We went off to Coorg. We went off on a off-roading trip over there. We did all those things. We came back, and Radhika was in a lot of pain. And that is when we went to the doctor, and we got a earful from the doctor, because the doctor said, "You all don't have brains, you all have conceived, and you all have been going around on off-roading trips." Believe me, what we didn't know was that all the hope that we carried had borne fruit, but it is just that we were about to give up hope. So all I'm saying is, when you look at ART, when you look at artificial reproductive techniques, there are so many which are available. But the one thing which you need to have inside of you is something called as hope, and keep that hope alive. And that hope is not only about the wife holding it or the husband holding it. It's about both holding it together. Sometimes the husband goes down, the wife holds him together. Sometimes the wife goes down, the husband holds her together. But isn't that called a family? Isn't that a partnership? And I think that's what I wanted to share with you all. That keep your hope alive. And I'm very sure that many people can benefit from this. I worked in the pharma industry. I know how the pharma industry is developing more and more techniques with which this can become even more easier. But at the same time, with nature and with the type of lifestyles we live. I was hearing the doctor just before my speech, and she was talking about lifestyles, she was talking about diets, she was talking about so many things over here. And I'm very sure that today couples are wanting to conceive, but they are not wanting to look at the other aspects of it. And we had to look at all these aspects to just reach a point where we conceive. And beyond conception is another journey. But I think that's left for another time to speak about. But today my speech is all about hope, and hope in ART. I hope I have given some inspiration to somebody who's been looking out, and with that I'm done. Back to the host. Thank you so much.
Thank you so much, Sachin. I think in times where we have to openly speak about such topics, normalize such things, people who have actually got benefits from IVF and other fertility techniques, they literally don't want to share it out of the world. But thank you so much, Mr. Sachin, for taking time out and for coming forward and sharing with us, so that many other Sachins can come forward and share their story, and everybody can avail the benefits of artificial techniques as well. Perfect. Thank you so much. I now request Archana Ravikumar ma'am to kindly come forward to give away a memento to Mr. Sachin. Can we all give a huge round of applause? This testimonial was very, very important, ladies and gentlemen. This was Very much important, and thank you so much, Sachin, for coming forward. Thank you so much, ma'am. Ladies and gentlemen, and the ones who've been watching us virtually, you all have been an excellent audience. I'm going to tell you the second half of the day before we break for lunch is going to be amazing. I want all of you to stay back. As responsible citizens of the country, we also need to know about donors, surrogacy, legal frameworks, child adoption. All these things will be discussed post-lunch. We are also going to discuss about optimal weight management for better and natural assisted pregnancy success. And the most important segment, which is child adoption, that will also be covered post-lunch. So I request all of you to kindly stay back. The lunch is served, so you all can break for lunch now. We are at the Path to Parenthood by NewsFirst Prime, an initiative by NewsFirst Prime, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Wiley Health. Thank you so much, everyone. Let's all break for lunch now.
Well, life is natural, but not anymore, because life can also be produced in an artificial way, and that is what Dr. Devika Gunashila just described on stage in Path to Parenthood program. And I have with me here today Dr. Devika Gunashila, MD of Gunashila Maternity Hospitals, Gunashila Surgical and Maternity Hospitals. Hello, ma'am.
Hi.
Ma'am, I think the concept which you just unfolded in front of the audience was mind-blowing, because life is natural, but now we have seen so much of advancements in the field of science and technology and medical sciences, and artificial ovary could be produced, artificial sperm can be produced, and artificial womb also can be produced. So could you please throw some light about that?
Yeah, science has been progressing in an extremely fast pace. So from 1990s, after ICSI, the first baby was born in the 1970s, after which, the IVF, the infertility scene just exploded. And from then on, technology has grown by leaps and bounds. And what you're talking about, artificial ovary, artificial sperm, artificial womb, those are still futuristic. It's not there as yet. But I don't think there'll be a problem getting there, because scientists and researchers are working day and night trying to get to that point, which will be a real boon. If it happens, it will be a real boon to women who are struggling with trying to get eggs. And we are seeing a lot of women who are unable to produce eggs. Their ovarian reserve, that is the stock of eggs in the ovary, is coming down very quickly. And this we are seeing is a phenomenon that is happening a lot in India. So that will be a boon to these people, as well as to men who cannot father a child. So it's fantastic the way technology is going, and we should also adapt to technology, and we should kind of try to bring it into our practice as and when things happen, and as and when there is enough evidence. Every technology cannot be adopted. It has to be evidence-based, and otherwise we are the ones who are going to be left out. And I think the world is heading towards genetics. Genetics is the way forward.
Definitely. And I was just mind blown by the concept that you could produce a sperm from bone marrow, and an artificial womb for the zygote, and all that. That was mind blowing. And there is one question among the people, that even though there are advancement in the field of sciences, and babies are born through IVF, and as we also saw on the stage, that in the future also, babies can be produced artificially, but will the same babies have the same natural qualities or the kind of naturality which can be produced naturally through intercourse?
If we don't go into the futuristic part of it, which is still futuristic, it is not there at this point of time. Well, with ICSI was actually an accident where the sperm was just injected into the egg, and then they said, "Oh, that's happened," and then they let it, grow in the incubator, and it grew. It grew into a good zygote, grew into a good embryo, and that's how ICSI started off. So there have been millions of babies that have been born to this technology, and they're all kind of okay. The abnormalities, people are always worried: are they abnormal? Are they going to be the same like what you said? They're pretty much the same. The chance of abnormality in a natural conception in the general population is 1 to 2%, whereas in an ICSI it may be 2 to 3%. That's all. There's nothing great, nothing greatly different from the general population. So we're okay. And also with the advent of screening these embryos before we put them in, so we're genetically screening them. An embryo that looks normal by its growth may not be genetically normal. So we can screen them before we put them in. So that is another step forward to producing a genetically normal baby, which is good.
I think that is definitely a great ray of hope for people who are still looking to conceive and to father a child. And thank you so much, ma'am. Thank you so much for talking to News First Prime. With camera person Manju Hoskote, this is Rahul Dayan for News First Prime, Bengaluru.
ನ್ಯೂಸ್ ಫಸ್ಟ್ ನಿರ್ಭೀತಿಯಿಂದ ನಿಮ್ಮ ಪರವಾಗಿ.
Well, life is natural, but not anymore, because life can also be produced in an artificial way, and that is what Dr. Devika Gunashila just described on stage in Path to Parenthood program. And I have with me here today Dr. Devika Gunashila, MD of Gunashila Maternity Hospitals, Gunashila Surgical and Maternity Hospitals. Hello, ma'am.
Hi.
Ma'am, I think the concept which you just unfolded in front of the audience was mind-blowing, because life is natural, but now we have seen so much of advancements in the field of science and technology and medical sciences, and artificial ovary could be produced, artificial sperm can be produced, and artificial womb also can be produced. So could you please throw some light about that?
Yeah, science has been progressing in an extremely fast pace. So from 1990s, after ICSI, the first baby was born in the 1970s, after which, the IVF, the infertility scene just exploded. And from then on, technology has grown by leaps and bounds. And what you're talking about, artificial ovary, artificial sperm, artificial womb, those are still futuristic. It's not there as yet. But I don't think there'll be a problem getting there, because scientists and researchers are working day and night trying to get to that point, which will be a real boon. If it happens, it will be a real boon to women who are struggling with trying to get eggs. And we are seeing a lot of women who are unable to produce eggs. Their ovarian reserve, that is the stock of eggs in the ovary, is coming down very quickly. And this we are seeing, it's a phenomenon that is happening a lot in India. So that will be a boon to these people as well as to men who cannot father a child. So it's fantastic the way technology is going, and we should also adapt to technology. And we should try to bring it into our practice as and when things happen, and as and when there is enough evidence. Every technology cannot be adopted. It has to be evidence based, and otherwise we are the ones who are going to be left out. And I think the world is heading towards genetics. Genetics is the way forward.
Definitely. And I was just mind blown by the concept that you could produce a sperm from bone marrow and an artificial womb for the zygote and all that. That was mind blowing. And there is one question among the people that even though there are advancement in the field of sciences and babies are born through IVF, and as we also saw on the stage that in the future also babies can be produced artificially, but will the same babies have the same natural qualities or the kind of naturality which can be produced naturally through intercourse?
If we don't go into the futuristic part of it, which is still futuristic, it is not there at this point of time. Well, with ICSI was actually an accident where the sperm was just injected into the egg, and then they said, "Oh, that's happened," and then they let it, grow in the incubator, and it grew. It grew into a good zygote, grew into a good embryo, and that's how ICSI started off. So there have been millions of babies that have been born to this technology, and they're all kind of okay. The abnormalities, people are always worried, are they abnormal? Are they going to be the same like what you said? They're pretty much the same. The chance of abnormality in a natural conception in the general population is 1 to 2%, whereas in an ICSI it may be 2 to 3%. That's all. There's nothing greatly different from the general population. So we're okay. And also with the advent of screening these embryos before we put them in, so we're genetically screening them. An embryo that looks normal by its growth may not be genetically normal. So we can screen them before we put them in. So that is another step forward to producing a genetically normal baby, which is good.
I think that is definitely a great ray of hope for people who are still looking to conceive and to father a child. And thank you so much, ma'am. Thank you so much for talking to News First Prime. With camera person Manju Hoskote, this is Rahul Dayan for News First Prime, Bengaluru.
ನ್ಯೂಸ್ ಫಸ್ಟ್ ನಿರ್ಭೀತಿಯಿಂದ ನಿಮ್ಮ ಪರವಾಗಿ.
Well, life is natural, but not anymore, because life can also be produced in an artificial way, and that is what Dr. Devika Gunashila just described on stage in Path to Parenthood program. And I have with me here today Dr. Devika Gunashila, MD of Gunashila Maternity Hospitals, Gunashila Surgical and Maternity Hospitals. Hello, ma'am.
Hi.
Ma'am, I think the concept which you just unfolded in front of the audience was mind-blowing, because life is natural, but now we have seen so much of advancements in the field of science and technology and medical sciences, and artificial ovary could be produced, artificial sperm can be produced, and artificial womb also can be produced. So could you please throw some light about that?
Science has been progressing in an extremely fast pace. So from 1990s, after ICSI, the first baby was born in the 1970s, after which, the IVF, the infertility scene just exploded. And from then on, technology has grown by leaps and bounds. And what you're talking about, artificial ovary, artificial sperm, artificial womb, those are still futuristic. It's not there as yet. But I don't think there'll be a problem getting there, because scientists and researchers are working day and night trying to get to that point, which will be a real boon. If it happens, it will be a real boon to women who are struggling with trying to get eggs. And we are seeing a lot of women who are unable to produce eggs. Their ovarian reserve, that is the stock of eggs in the ovary, is coming down very quickly. And this we are seeing, it's a phenomenon that is happening a lot in India. So that will be a boon to these people as well as to men who cannot father a child. So it's fantastic the way technology is going, and we should also adapt to technology, and we should try to bring it into our practice as and when things happen, and as and when there is enough evidence. Every technology cannot be adopted. It has to be evidence based, and otherwise we are the ones who are going to be left out. And I think the world is heading towards genetics. Genetics is the way forward.
Definitely. And I was just mind blown by the concept that you could produce a sperm from bone marrow and an artificial womb for the zygote and all that. That was mind blowing. And there is one question among the people that even though there are advancements. Hello, watching News First Prime. I'm Rahul Dayan. You're here at the Path to Parenthood event today in Bengaluru Palace grounds, Grand Castle. And right now I have here with me Dr. Asha Vijay, Medical Director and Fertility Expert, Garbhagudi IVF. Ma'am, welcome. I think a wonderful piece of information was shared by you on stage today, and which is like a wake-up call for the youngsters and of course people who are facing infertility problems. Right now, if you could analyze the kind of patients who come to you now, because you've got decades of experience in this field. So before 10 years or after 10 years, what is the kind of difference or the different kind of patients whom you attend at this point of time?
Yeah, very, very pertinent question. Huh? Actually, a few years back when we were treating infertility, if 10 people walk into our clinic, 1 or 2 were infertile. But nowadays, out of 10, almost 5 to 6 are infertile. Either the man is having problems with the semen or the lady is having problems in conception. And one very, very disturbing fact to our doctors is all the ladies who walk into the clinic with telling about infertility, their egg reserve is coming down very, very fast. So we are doing lot of researches on why this is happening, why the semen sample has so less count, so less motility, why the lady is having so much of less of egg count. For everything, we are coming to a conclusion that we are getting exposed to lot of chemicals. From head to toe, we are using hundreds of chemicals. All these chemicals are causing lot of problems with our hormonal regulation. So what we call it as endocrine disruptors. And you can see today's youth, they're always exposed to electromagnetic radiation. We don't know what are the side effects, adverse effects of this EMF. So morning to night, even their sleep pattern is disturbed, food pattern is disturbed, their entire profession starts at 12 o'clock, ends at early morning 6 o'clock. The whole lifestyle has been changed completely. And you know, everybody, even the small baby is having severe stress, either mental, emotional or physical. So all these factors are becoming too much increase in the fertility issues in our world.
You just mentioned about 3 keywords, that is ahara, vihara and treatment. So that is food, treatment and of course recreational movement or the activeness which they have to follow in their life. So how important is that at this present age, because everybody is stressed, nobody is like stress free. So could you please stress on the information or the importance of ahara, vihara and chikitsa?
Actually, tumba important idu. Now we are becoming so much obsessed with creating wealth and creating name and fame. We have almost forgotten how to eat food properly. So I see people grab a food on their journey to their office or sitting in the car, just having it so in a very, very fast way without even spending enough time. Now, in our ancient medicine, they used to say, sit relaxedly, pray to God, with a gratitude, eat your food. The entire thing has vanished into thin air now. Nobody thinks of their health, nobody thinks of their physical well being. Everybody is going behind some success, which is a very unknown thing. So it's very, very important that you pay very much importance to your nutrition, your sleep patterns, your food patterns. All of these are very important. So many people, I ask them, what is the sort of physical activity they do? They say we leave by 6 a.m., come by 12 in the night. Where do we have time for physical health? It's very, very important that you follow a certain physical routine in your daily life.
And I'm very sure you have treated lot many of patients in your entire experience till now. And could you please share any case studies anonymously, of course, so that the viewers are beneficial by that. After seeing that, even they might come out in the open and say, yes, I need to address this issue.
Actually, when you're telling about the case experiences, I'm remembering one very, very interesting case where the man had 0 sperms. So they have gone to a local doctor. and she has said that you can never conceive on your own. He's so depressed, they have kept the report with themselves and they have never returned. When we did a camp in Kanakpura, somebody brought them forcibly. And then we saw the report, got his hormone analysis done. All his hormones were perfect. And his scrotal scan, testicular scan was normal. Then we came to a conclusion, it is just obstruction. His semen production is happening very well and he can be easily father a child. Came back to Garbhagudi IVF center, had a IVF, we retrieved the sperms from his testes. Now he has twin, one boy, one girl. That was a beautiful story.
I think it's not just a case story, it's a successful story by Garbhagudi IVF. And one last question, ma'am. So people do think that I eat properly, I exercise properly, I have no habits of smoking or alcohol consumption or anything. But still some people do need such treatments. Why is that?
See, if I see externally, I may look perfect. So many couples tell we both are very healthy. But internally, how the organs will be functioning, you cannot see it. For example, how your heart is, how your liver is, has to be done by few tests or few scans or MRI. Similarly, fertility, uterus, ovaries, testes, or your tubes, you will not know from the outside. You have to undergo some tests. For example, a 22-year-old lady had come with problem in conception. When we tested her ovaries, it was completely failed. It was a 45-year-old ovaries. So how can you make out from external? You have to test it to know it more. That's the importance of testing.
And I think all such tests and of course all such treatments are available in Garbhagudi IVF and of course any other IVF center, and that is what is being focused in Path to Parenthood today, which is happening, the summit which is happening in Grand Castle. Thank you so much, and yes.
Hearty congratulations for this enormous platform, Path to Parenthood, both Wiley and NewsFirst. It's really phenomenal.
Thank you so much for talking to us, and we are pleasure to have you here today. Thank you so much, ma'am. So with camera person Chandresh, this is Rahul Dayan for News First Prime, Bengaluru. Hello, watching News First Prime. I'm Rahul Dayan. You're here at the Path to Parenthood event today in Bengaluru Palace grounds, Grand Castle. And right now I have here with me Dr. Asha Vijay, Medical Director and Fertility Expert, Garbhagudi IVF. Ma'am, welcome. I think a wonderful piece of information was shared by you on stage today, and which is like a wake-up call for the youngsters and of course people who are facing infertility problems. Right now, if you could analyze the kind of patients who come to you now, because you've got decades of experience in this field. So before 10 years or after 10 years, what is the kind of difference or the different kind of patients who you attend at this point of time?
Yeah, very pertinent question. Huh? Actually, a few years back when we were treating infertility, if 10 people walk into our clinic, 1 or 2 were infertile. But nowadays, out of 10, almost 5 to 6 are infertile. Either the man is having problems with the semen or the lady is having problems in conception. And one very disturbing fact to our doctors is all the ladies who walk into the clinic with telling about infertility, their egg reserve is coming down very fast. So we are doing lot of researches on why this is happening, why the semen sample has so less count, so less motility, why the lady is having so much of less of egg count. For everything, we are coming to a conclusion that we are getting exposed to lot of chemicals. From head to toe, we are using hundreds of chemicals. All these chemicals are causing lot of problems with our hormonal regulation. So what we call it as endocrine disruptors. And you can see today's youth, they're always exposed to electromagnetic radiation. We don't know what are the side effects, adverse effects of this EMF. So morning to night, even their sleep pattern is disturbed, food pattern is disturbed, their entire profession starts at 12 o'clock, ends at early morning 6 o'clock. The whole lifestyle has been changed completely. And you know, everybody, even the small baby is having severe stress, either mental, emotional or physical. So all these factors are becoming too much increase in the fertility issues in our world.
You just mentioned about 3 keywords, that is ahara, vihara and treatment. So that is food, treatment and of course recreational movement or the activeness which they have to follow in their life. So how important is that at this present age, because everybody is stressed, nobody is like stress free. So could you please stress on the information or the importance of ahara, vihara and chikitse?
Actually, ತುಂಬಾ important ಇದು. ನಾವು we are becoming so much obsessed with creating wealth and creating name and fame. We have almost forgotten how to eat food properly. So I see people grab a food on their journey to their office or sitting in the car, just having it so in a very, very fast way without even spending enough time. Now, in our ancient medicine, they used to say, sit relaxedly, pray to God, with a gratitude, eat your food. The entire thing has vanished into thin air now. Nobody thinks of their health, nobody thinks of their physical well being. Everybody is going behind some success, which is a very unknown thing. So it's very, very important that you pay very much importance to your nutrition, your sleep patterns, your food patterns. All of these are very important. So many people, I ask them, what is the sort of physical activity they do? They say we leave by 6 a.m., come by 12 in the night. Where do we have time for physical health? It's very, very important that you follow a certain physical routine in your daily life.
And I'm very sure you have treated lot many of patients in your entire experience till now. And could you please share any case studies anonymously, of course, so that the viewers are beneficial by that. After seeing that, even they might come out in the open and say, yes, I need to address this issue.
Actually, when you're telling about the case experiences, I'm remembering one very, very interesting case where the man had zero sperms. So they have gone to a local doctor, and she has said that you can never conceive on your own. He's so depressed, they have kept the report with themselves and they have never returned. When we did a camp in Kanakpura, somebody brought them forcibly. And then we saw the report, got his hormone analysis done. All his hormones were perfect. And his scrotal scan, testicular scan was normal. Then we came to a conclusion, it is just obstruction. His semen production is happening very well and he can be easily father a child. Came back to Garbhagudi IVF center, had a IVF, we retrieved the sperms from his testes. Now he has twin, one boy, one girl. That was a beautiful story.
I think it's not just a case story, it's a successful story by Garbhagudi IVF. And one last question, ma'am. So people do think that I eat properly, I exercise properly, I have no habits of smoking or alcohol consumption or anything. But still some people do need such treatments. Why is that?
See, if I see externally, I may look perfect. So many couples tell we both are very healthy. But internally, how the organs will be functioning, you cannot see it. For example, how your heart is, how your liver is, has to be done by few tests or few scans or MRI. Similarly, fertility, uterus, ovaries, testes, or your tubes, you will not know from the outside. You have to undergo some tests. For example, a 22-year-old lady had come with problem in conception. When we tested her ovaries, it was completely failed. It was a 45-year-old ovaries. So how can you make out from external? You have to test it to know it more. That's the importance of testing.
And I think all such tests and of course all such treatments are available in Garbhagudi IVF and of course any other IVF center, and that is what is being focused in Path to Parenthood today, which is happening, the summit which is happening in Grand Castle. Thank you so much, and yes.
Hearty congratulations for this enormous platform, Path to Parenthood, both Wiley and NewsFirst. It's really phenomenal.
Thank you so much for talking to us, and we are pleasure to have you here today. Thank you so much, ma'am. So with camera person Chandresh, this is Rahul Dayan for NewsFirst Prime, Bengaluru. Hello, watching NewsFirst Prime. I'm Rahul Dayan. You're here at the Path to Parenthood event today in Bengaluru Palace grounds, Grand Castle, and right now I have here with me Dr. Asha Vijay, Medical Director and Fertility Expert, Garbhagudi IVF. Ma'am, welcome. I think a wonderful piece of information was shared by you on stage today, and which is like a wake-up call for the youngsters and of course people who are facing infertility problems. Right now, if you could analyze the kind of patients who come to you now, because you've got decades of experience in this field. So before 10 years or after 10 years, what is the kind of difference or the different kind of patients whom you attend at this point of time?
Yeah, very, very pertinent question. Huh? Actually, a few years back when we were treating infertility, if 10 people walk into our clinic, one or two were infertile. But nowadays, out of 10, almost 5 to 6 are infertile. Either the man is having problems with the semen or the lady is having problems in conception. And one very, very disturbing fact to our doctors is all the ladies who walk into the clinic with telling about infertility, their egg reserve is coming down very, very fast. So we are doing lot of researches on why this is happening, why the semen sample has so less count, so less motility, why the lady is having so much of less of egg count. For everything, we are coming to a conclusion that we are getting exposed to lot of chemicals. From head to toe, we are using hundreds of chemicals. All these chemicals are causing lot of problems with our hormonal regulation. So what we call it as endocrine disruptors. And you can see today's youth, they're always exposed to electromagnetic radiation. We don't know what are the side effects, adverse effects of this EMF. So morning to night, even their sleep pattern is disturbed, food pattern is disturbed, their entire profession starts at 12 o'clock, ends at early morning 6 o'clock. The whole lifestyle has been changed completely. And you know, everybody, even the small baby, is having severe stress, either mental, emotional, or physical. So all these factors are becoming too much increase in the fertility issues in our world.
You just mentioned about three keywords, that is ahara, vihara, and treatment. So that is food, treatment, and of course recreational movement or the activeness which they have to follow in their life. So how important is that at this present age, because everybody is stressed, nobody is like stress free. So could you please stress on the information or the importance of ahara, vihara, and chikitsa?
Actually, tumba important idu. Now we are becoming so much obsessed with creating wealth and creating name and fame. We have almost forgotten how to eat food properly. So I see people grab a food on their journey to their office or sitting in the car, just having it so in a very, very fast way without even spending enough time. Now, in our ancient medicine, they used to say, sit relaxedly, pray to God, with a gratitude, eat your food. The entire thing has vanished into thin air now. Nobody thinks of their health, nobody thinks of their physical well being. Everybody is going behind some success, which is a very unknown thing. So it's very, very important that you pay very much importance to your nutrition, your sleep patterns, your food patterns. All of these are very important. So many people, I ask them, what is the sort of physical activity they do? They say we leave by 6 a.m., come by 12 in the night. Where do we have time for physical health? It's very, very important that you follow a certain physical routine in your daily life.
And I'm very sure you have treated lot many of patients in your entire experience till now. And could you please share any case studies anonymously, of course, so that the viewers are beneficial by that. After seeing that, even they might come out in the open and say, yes, I need to address this issue.
Actually, when you're telling about the case experiences, I'm remembering one very, very interesting case where the man had zero sperms. So they have gone to a local doctor, and she has said that you can never conceive on your own. He's so depressed, they have kept the report with themselves and they have never returned. When we did a camp in Kanakpura, somebody brought them forcibly. And then we saw the report, got his hormone analysis done. All his hormones were perfect. And his scrotal scan, testicular scan was normal. Then we came to a conclusion, it is just obstruction. His semen production is happening very well and he can be easily father a child. Came back to Garbhagudi IVF center, had a IVF, we retrieved the sperms from his testes. Now he has twin, one boy, one girl. That was a beautiful story.
I think it's not just a case story, it's a successful story by Garbhagudi IVF. And one last question, ma'am. So people do think that I eat properly, I exercise properly, I have no habits of smoking or alcohol consumption or anything. But still some people do need such treatments. Why is that?
See, if I see externally, I may look perfect. So many couples tell we both are very healthy. But internally, how the organs will be functioning, you cannot see it. For example, how your heart is, how your liver is, has to be done for few tests or few scans or MRI. Similarly, fertility,
uterus, ovaries, testis, or your tubes, you will not know from the outside. You have to undergo some tests. For example, a 22-year-old lady had come with problem in conception. When we tested her ovaries, it was completely failed. It was a 45-year-old ovaries. So how can you make out from external? You have to test it to know it more. That's the importance of testing.
And I think all such tests and of course all such treatments are available in Garbhagudi IVF and of course any other IVF center, and that is what is being focused in Path to Parenthood today, which is happening, the summit which is happening in Grand Castle. Thank you so much, and yes.
Hearty congratulations for this enormous platform, Path to Parenthood, both Wiley and NewsFirst. It's really phenomenal.
Thank you so much for talking to us, and we are pleasure to have you here today. Thank you so much, ma'am. So with camera person Chandresh, this is Rahul Dayan for News First Prime, Bengaluru. Hello, watching News First Prime. I'm Rahul Dayan. You're here at the Path to Parenthood event today in Bengaluru Palace grounds, Grand Castle. And right now I have here with me Dr. Asha Vijay, Medical Director and Fertility Expert, Garbhagudi IVF. Ma'am, welcome. I think a wonderful piece of information was shared by you on stage today, and which is like a wake-up call for the youngsters and of course people who are facing infertility problems. Right now, if you could analyze the kind of patients who come to you now, because you've got decades of experience in this field. So before 10 years or after 10 years, what is the kind of difference or the different kind of patients who you attend at this point of time?
Yeah, very pertinent question. Huh? Actually, a few years back when we were treating infertility, if 10 people walk into our clinic, 1 or 2 were infertile. But nowadays, out of 10, almost 5 to 6 are infertile. Either the man is having problems with the semen or the lady is having problems in conception. And one very disturbing fact to our doctors is all the ladies who walk into the clinic with telling about infertility, their egg reserve is coming down very fast. So we are doing lot of researches on why this is happening, why the semen sample has so less count, so less motility, why the lady is having so much of less of egg count. For everything, we are coming to a conclusion that we are getting exposed to lot of chemicals. From head to toe, we are using hundreds of chemicals. All these chemicals are causing lot of problems with our hormonal regulation. So what we call it as endocrine disruptors. And you can see today's youth, they're always exposed to electromagnetic radiation. We don't know what are the side effects, adverse effects of this EMF. So morning to night, even their sleep pattern is disturbed, food pattern is disturbed, their entire profession starts at 12 o'clock, ends at early morning 6 o'clock. The whole lifestyle has been changed completely. And you know, everybody, even the small baby, is having severe stress, either mental, emotional, or physical. So all these factors are becoming too much increase in the fertility issues in our world.
You just mentioned about 3 keywords, that is ahara, vihara, and treatment. So that is food, treatment, and of course recreational movement or the activeness which they have to follow in their life. So how important is that at this present age, because everybody is stressed, nobody is like stress free. So could you please stress on the information or the importance of ahara, vihara, and chikitsa?
Actually, tumba important idu. Now we are becoming so much obsessed with creating wealth and creating name and fame. We have almost forgotten how to eat food properly. So I see people grab a food on their journey to their office or sitting in the car, just having it so in a very fast way without even spending enough time. Now, in our ancient medicine, they used to say, sit relaxedly, pray to God, with a gratitude, eat your food. The entire thing has vanished into thin air now. Nobody thinks of their health. Nobody thinks of their physical well-being. Everybody is going behind some success, which is a very unknown thing. So it's very important that you pay very much importance to your nutrition, your sleep patterns, your food patterns. All of these are very important. So many people, I ask them, what is the sort of physical activity they do? They say we leave by 6 a.m., come by 12 in the night. Where do we have time for physical health? It's very important that you follow a certain physical routine in your daily life.
And I'm very sure you have treated many of patients in your entire experience till now. And could you please share any case studies anonymously, of course, so that the viewers are beneficial by that. After seeing that, even they might come out in the open and say, yes, I need to address this issue.
Actually, when you're telling about the case experiences, I'm remembering one very, very interesting case where the man had zero sperms. So they have gone to a local doctor, and she has said that you can never conceive on your own. He's so depressed, they have kept the report with themselves and they have never returned. When we did a camp in Kanakpura, somebody brought them forcibly. And then we saw the report, got his hormone analysis done. All his hormones were perfect. And his scrotal scan, testicular scan was normal. Then we came to a conclusion, it is just obstruction. His semen production is happening very well and he can be easily father a child. Came back to Garbhagudi IVF center, had a IVF, we retrieved the sperms from his testes. Now he has twin, one boy, one girl. That was a beautiful story.
I think it's not just a case story, it's a successful story by Garbhagudi IVF. And one last question, ma'am. So people do think that I eat properly, I exercise properly, I have no habits of smoking or alcohol consumption or anything. But still some people do need such treatments. Why is that?
See, if I see externally, I may look perfect. So many couples tell we both are very healthy. But internally, how the organs will be functioning, you cannot see it. For example, how your heart is, how your liver is, has to be done by few tests or few scans or MRI. Similarly, fertility, uterus, ovaries, testes, or your tubes, you will not know from the outside. You have to undergo some tests. For example, a 22-year-old lady had come with problem in conception. When we tested her ovaries, it was completely failed. It was a 45-year-old ovaries. So how can you make out from external? You have to test it to know it more. That's the importance of testing.
And I think all such tests and of course all such treatments are available in Garbhagudi IVF and of course any other IVF center, and that is what is being focused in Path to Parenthood today, which is happening. Being blamed, but no, it is not the case. Even the male infertility rate in the country and of course in the world is rising day by day. So to talk more about that, I have with me here today Dr. Santosh Gupta from Nova Fertility Center. Hello, ma'am. Ma'am, you just spoke about male infertility rate and of course the causes and the concern. So could you please highlight the main things so that people need to focus and be aware so that their fertility rate improves and of course infertility rate comes down?
See, there is a definitely decline in male infertility, and I would say mainly it is a lifestyle problem. So what we have to do is, one is sedentary lifestyle, and people are becoming more and more obese. That means they are gaining weight. So we have to be active. We should not put on unnecessary weight. Then eating junk food, unhealthy food. So food rich in antioxidants like sprouts, colorful fruits, vegetable, curd, whatever is easily available, healthy food. Then there is lot of things like hormone disruptors. These hormone disruptors are nothing the things we buy. We only bring them home. They are like toxins. Like you drink water in a plastic bottle. We eat in plastic. We heat up our food in plastic. We buy synthetic perfumes. Some kind of perfumes which are not natural. Colors. These are normal toxic materials which can impair our hormones. So they can also cause infertility. So a healthy lifestyle is the key for these problems.
And also, people don't focus about males' infertility when it comes to a couple. It's always the woman who's blamed and she undergoes all the necessary tests and all that. So talking about infertility rate in the country and of course male also I'm talking about. So what is the social impact on the relationship when it comes to this?
See, nowadays what is happening is male parameters, semen parameters are decreasing. Okay, women are getting married late, then they want to settle. women either financially or professionally want to settle. Even the lookout towards life has changed. People want to settle completely, buy a house and then get pregnant. So women fertility is very, very sensitive to the time. So if your female partner is older, definitely your fertility will reduce. Along with that, male semen parameters are also reducing. So as a doctor, what we do whenever a infertile couple comes, we don't call alone men or alone women. We always call husbands also. In every counseling, if they are able to present, we welcome men and involve them in the treatment. And I never start any treatment without a men investigation. For men, it is very easy. They have to do a semen analysis. So we do not start any kind of treatment without men doing a basic test on them. So that part we do it.
I think it is not just a single problem. I think if it's a problem, it's a combination. It's a couple problem. So whenever it is the fertility or any kind of a problem which the couple is facing, I think both of them should actually, like emotionally and physically, be together and stay together and face the problem together. And thank you so much, doctor, for talking to us. So with camera person Manju Hoskote, this is Rahul Dayan for NewsFirst Prime, Bengaluru. When it comes to infertility, it is always the woman who's been blamed. But no, it is not the case. Even the male infertility rate in the country and of course in the world is rising day by day. So to talk more about that, I have with me here today Dr. Santosh Gupta from Nova Fertility Center. Hello, ma'am. Ma'am, you just spoke about male infertility rate and of course the causes and the concern. So could you please highlight the main things so that people need to focus and be aware so that their fertility rate improves and of course infertility rate comes down?
See, there is a definitely decline in male infertility, and I would say mainly it is a lifestyle problem. So what we have to do is, one is sedentary lifestyle, and people are becoming more and more obese. That means they are gaining weight. So we have to be active. We should not put on unnecessary weight. Then eating junk food, unhealthy food. So food rich in antioxidants like sprouts, colorful fruits, vegetable, curd, whatever is easily available, healthy food. Then there is lot of things like hormone disruptors. These hormone disruptors are nothing the things we buy. We only bring them home. They are like toxins. Like you drink water in a plastic bottle. We eat in plastic. We heat up our food in plastic. We buy synthetic perfumes. Some kind of perfumes which are not natural. Colors. These are normal toxic materials which can impair our hormones. So they can also cause infertility. So a healthy lifestyle is the key for these problems.
And also, people don't focus about males' infertility when it comes to a couple. It's always the woman who's blamed and she undergoes all the necessary tests and all that. So talking about infertility rate in the country and of course male also I'm talking about. So what is the social impact on the relationship when it comes to this?
See, nowadays what is happening is male parameters, semen parameters are decreasing. Okay, women are getting married late, then they want to settle. Women either financially or professionally want to settle. Even the lookout towards life has changed. People want to settle completely, buy a house and then get pregnant. So women fertility is very, very sensitive to the time. So if your female partner is older, definitely your fertility will reduce. Along with that, male semen parameters are also reducing. So as a doctor, what we do whenever a infertile couple comes, we don't call alone men or alone women. We always call husbands also. In every counseling, if they are able to present, we welcome men and involve them in the treatment. And I never start any treatment without a men investigation. For men, it is very easy. They have to do a semen analysis. So we do not start any kind of treatment without men doing a basic test on them. So that part we do it.
I think it is not just a single problem. I think if it's a problem, it's a combination. It's a couple problem. So whenever it is the fertility or any kind of a problem which the couple is facing, I think both of them should actually, like emotionally and physically, be together and stay together and face the problem together. And thank you so much, doctor, for talking to us. So with camera person Manju Hoskote, this is Rahul Dayan for NewsFirst Prime, Bengaluru. When it comes to infertility, it is always the woman who's been blamed. But no, it is not the case. Even the male infertility rate in the country and of course in the world is rising day by day. So to talk more about that, I have with me here today Dr. Santosh Gupta from Nova Fertility Center. Hello, ma'am. Ma'am, you just spoke about male infertility rate and of course the causes and the concern. So could you please highlight the main things so that people need to focus and be aware so that their fertility rate improves and of course infertility rate comes down?
See, there is a definitely a decline in male infertility, and I would say mainly it is a lifestyle problem. So, what we have to do is one is sedentary lifestyle, and people are becoming more and more obese. That means they are gaining weight. So, we have to be active. We should not put on unnecessary weight. Then, eating junk food, unhealthy food. So, food rich in antioxidants like sprouts, colorful fruits, vegetable, curd, whatever is easily available, healthy food. Then there is lot of things like hormone disruptors. These hormone disruptors are nothing the things we buy. We only bring them home. They are like toxins. Like you drink water in a plastic bottle. We eat in plastic. We heat up our food in plastic. We buy synthetic perfumes. Some kind of perfumes which are not natural. Colors. These are normal toxic materials which can impair our hormones. So they can also cause infertility. So a healthy lifestyle is the key for these problems.
And also, people don't focus about males' infertility when it comes to a couple. It's always the woman who's blamed and she undergoes all the necessary tests and all that. So talking about infertility rate in the country and of course male also I'm talking about. So what is the social impact on the relationship when it comes to this?
See, nowadays what is happening is male parameters, semen parameters are decreasing. Okay, women are getting married late, then they want to settle. Women either financially or professionally want to settle. Even the lookout towards life has changed. People want to settle completely, buy a house and then get pregnant. So women fertility is very, very sensitive to the time. So if your female partner is older, definitely your fertility will reduce. Along with that, male semen parameters are also reducing. So as a doctor, what we do whenever a infertile couple comes, we don't call alone men or alone women. We always call husbands also. In every counseling, if they are able to present, we welcome men and involve them in the treatment. And I never start any treatment without a men investigation. For men, it is very easy. They have to do a semen analysis. So we do not start any kind of treatment without men doing a basic test on them. So that part we do it.
I think it is not just a single problem. I think if it's a problem, it's a combination. It's a couple problem. So whenever it is the fertility or any kind of a problem which the couple is facing, I think both of them should actually, like emotionally and physically, be together and stay together and face the problem together. And thank you so much, doctor, for talking to us. So with camera person Manju Hoskote, this is Rahul Dayan for NewsFirst Prime, Bengaluru. When it comes to infertility, it is always the woman who's been blamed. But no, it is not the case. Even the male infertility rate in the country and of course in the world is rising day by day. So to talk more about that, I have with me here today Dr. Santosh Gupta from Nova Fertility Center. Hello, ma'am. Ma'am, you just spoke about male infertility rate and of course the causes and the concern. So could you please highlight the main things so that people need to focus and be aware so that their fertility rate improves and of course infertility rate comes down?
See, there is a definite...
Over to you, team.
Hello? Hello?
Hello?
Good afternoon, everyone. Good afternoon, everyone. Now we'll be talking about beyond fertility regarding donors and surrogacy. From yesterday, we've been hearing about egg and sperm. So this is more about that. So today I'll start my question with Dr. Bharti Rajanna. So what is the role of egg and sperm donor in fertility treatments, doctor?
Hello, good afternoon, everyone.
I think.
Hello. Good afternoon, everyone. After a lunch, I suppose you won't have a nap now. Okay? She asked me, what is the role of egg and sperms? Before that, I will just, of donors that too. Before that, just I will brief you regarding the ICMR guidelines. ICMR, that is the Indian Council of Medical Association, Apex in Delhi, okay, where they formulate the guidelines. So we all follow these guidelines, okay, that is the art clinic. Please can you repeat the question?
The role of egg and sperm donors.
Yeah. Now I will be telling you what are the roles. The role of a donor is to donate the eggs and the sperm too. But when do we select is very important. That has been formulated by ICMR, sorry. Okay, a girl below 21 years cannot take any donor eggs or the sperms, and a married couple are eligible to take, and that too a married couple staying together for 2 years can take these donor sperms and donor eggs. Okay, and this is it is not a commodity, right? So it has to be approved by the medical personnel, and the idea behind that is they cannot produce egg, quality one or a quantity one, and that is the reason where we go for the donor eggs and for the donor sperms. So the main guidelines which we follow is, if a woman is at the end of the reproductive age, that is round about 40, 42, where they cannot produce healthy and quality sperms, then they are offered this. Or if they have a premature ovarian failure, that is if they attain menopause before the age of 40. Apart from this, if a woman is suffering from any of the health conditions, like any genetic conditions, the sexual chromosome conditions which are transferred in the family, and she won't be having any live baby, they are recommended. And also we have to remember, nowadays cancer are booming so much and the young girls are having cancers. So a cancer treatment patient or who have undergone chemotherapy, radiotherapy, they are all offered the donor eggs. And coming to the males, okay, and I want to tell you here one thing, even if a woman, a single woman can take a donor sperm and have a baby, okay. And coming to the men, it is the quality which is important. Quality, that is the quality or the quantity, it is not a concern. Only the morphology and motility of the sperm, if it is too low and if there are failed IVF cycles, then they can opt for the donor sperms. And even the males who have undergone any radiation, chemotherapy, not suitable sperms, azoospermia, which is very important nowadays. But nowadays we have advanced so much that even with azoospermia, we do TISA, we collect the sperms. But sometimes there is testicular condition where FSH, LH, they are resistant to the Sertoli cells, the Sertoli cell syndrome, where cannot get the sperms or a good quality, or where we will be transmitting the diseases from the X and Y chromosomes. That is, we call it as autosomal recessive, autosomal dominant conditions. Common ones in our country which we have seen is thalassemia, hemophilia, dystrophy, okay, dystrophy, and many of the condition, neurofibromatosis, okay, and metabolic disorders. We select the sperms by doing the genetic testing for the donors and for the males, and then we choose the sperms. So they play a very vital role in formulating the family. That is giving a hope for childless couple. Isn't it great?
Yes, definitely, doctor.
ಮೊದಲಿಗೆ ಫಸ್ಟ್ ನ್ಯೂಸ್ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮನ ಹಮ್ಮಿಕೊಂಡು ನನ್ನನ್ನು ಇನ್ವೈಟ್ ಮಾಡಿರ್ತಾರೆ. ಅವರಿಗೆ ಕ್ಯಾರಿ ಫರ್ಟಿಲಿಟಿ ಪ್ರೈವೇಟ್ ಲಿಮಿಟೆಡಿಂದ ಕೃತಜ್ಞತೆಗಳು. ಇದು ಒಂದು ಒಳ್ಳೆಯ ಪ್ರಯೋಗ. ಇದುವರೆಗೆ ಈ ಥರದ ಕಾರ್ಯಕ್ರಮಗಳು ನ್ಯೂಸ್ ಚಾನಲಿಂದ ಆಗಿರಲಿಲ್ಲ. ಇವತ್ತು ಫಸ್ಟ್ ನ್ಯೂಸು ಚಾನಲ್ಲು ಹಮ್ಮಿಕೊಂಡಿದೆ. ನಿಮಗೆಲ್ಲ ತಿಳಿದಿರೋ ಹಾಗೆ ಬಂಜೆತನ ಅನ್ನೋದು ಒಂದು ಸೋಷಿಯಲ್ ಸ್ಟಿಗ್ಮಾ ಅಂತ ಹೇಳ್ತೀವಿ. ಈ ಒಂದು ನಿವಾರಣೆಗೆ ಸತತವಾಗಿ 40 ವರ್ಷಗಳಿಂದ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಅಸಿಸ್ಟೆಡ್ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಟೆಕ್ನಾಲಜಿಯಿಂದ ಹಮ್ಮಿಕೊಂಡು ಬಂದಿದೆ. ಇದರಲ್ಲಿ ಹಲವಾರು ಪ್ರಯತ್ನಗಳನ್ನು ಮಾಡಿ ಸಂಶೋಧನೆಯನ್ನು ಮಾಡಿ ಇವತ್ತು ನಾವು ಬಂಜೆತನ ನಿವಾರಣೆಗೆ ಅತ್ಯಮೂಲ್ಯವಾದ ಕೆಲಸವನ್ನು ಮಾಡಿ ಒಳ್ಳೆಯ ಸಕ್ಸಸ್ ರೇಟನ್ನು ತಂದುಕೊಡ್ತಾ ಇದ್ದೀವಿ. ನಾನು ಈ ಒಂದು ಫೀಲ್ಡ್ನಲ್ಲಿ ಸುಮಾರು 30 ವರ್ಷದಿಂದ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದೇನೆ. ನಾನು ಭ್ರೂಣತಜ್ಞನಾಗಿ 30 ವರ್ಷದಿಂದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇದ್ದು, ನಾನು ಮೊದಲನೇ ದಿನದಿಂದನೂ ನಿಮಗೆ ಹೇಳಬೇಕು ಅಂತಂದರೆ ಇಷ್ಟು ಅವೇರ್ನೆಸ್ಸು ಇರ್ತಿರಲಿಲ್ಲ. ಬಂಜೆತನ ಅಂತಂದರೆ ಮದುವೆ ಆದ ಮೇಲೆ ಅವರು ಸುಮಾರು 1-2 ವರ್ಷ ಕಾಯ್ತಾಯಿದ್ರು. ತದನಂತರ ಟೆಂಪಲ್ಗೆ ಹೋಗೋದು, ಆಯುರ್ವೇದ, ಈ ಥರದ ಟ್ರೀಟ್ಮೆಂಟ್ಗಳು ನಡೀತಿದ್ವು. ಇದನ್ನೆಲ್ಲ ಆಗಿ ಅದಾದ ಮೇಲೆ ಇನ್ನೂ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲಿಲ್ಲ, ನಮಗೆ ಮಗು ಬೇಕು ಅಂದಾಗ ಮಾತ್ರ ಅವರು ಈ ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟ್ಗೆ ಸೆಂಟರ್ಗೆ ಹೋಗ್ತಾಯಿದ್ರು. ಇವತ್ತು ಆ ಥರ ಇಲ್ಲ. ಈ ನ್ಯೂಸ್ ಚಾನೆಲ್ಗಳಿಂದ ಇರೋದರಿಂದ ಅವೇರ್ನೆಸ್ಸು ತುಂಬ ಇದೆ. ನಮ್ಮ ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್ಗೆ ಅಪ್ರೋಚ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅವ್ರಿಗೆ ಬಂಜೆತನ ನಿವಾರಣೆ ಮಾಡೋದ್ರಲ್ಲಿ ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್ಗಳು ಪ್ರಯತ್ನ ಮಾಡಿ ಅವ್ರಿಗೆ ಒಳ್ಳೆಯ ಸಕ್ಸಸ್ ರೇಟ್ ಕೊಡ್ತಾಯಿದ್ದಾರೆ. ಮತ್ತು ಮೇಡಮ್ನವರು ಹೇಳ್ತಾಯಿದ್ರು, 1-2-3 ಪಾಯಿಂಟನ್ನ ನಾನು ಆ್ಯಡ್ ಮಾಡಲಿ ಇಚ್ಛೆಪಡ್ತೇನೆ. ಏನೇ ಒಂದು ನಾವು ಸಂಸ್ಥೆಯಲ್ಲಿ ಕೆಲಸ ಮಾಡಬೇಕು, ಒಂದು ಗೈಡ್ಲೈನ್ಸ್ ಅಂತ ಇರ್ತದೆ, ಒಂದು ರೂಲ್ಸ್ ಆ್ಯಂಡ್ ರೆಗ್ಯುಲೇಷನ್ ಅಂತ ಇರ್ತದೆ. ವೆದರ್ ಅದು ಹೆಲ್ತ್ ಸೆಕ್ಟ್ರಲ್ಲೇ ಇರ್ಬೋದು, ಯಾವುದೇ ನರ್ಸಿಂಗ್ ಹೋಮ್ನಲ್ಲಾರು ಇರ್ಬೋದು, ಹಾಸ್ಪಿಟಲ್ಲಾರಿದ್ರು. ಈ ಒಂದು ಸಂಸ್ಥೆ ಈ ಒಂದು ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಗೈಡ್ಲೈನ್ ಅನ್ನೋದು ಇರಲಿಲ್ಲ, ರೂಲ್ಸ್ ಆ್ಯಂಡ್ ರೆಗ್ಯುಲೇಷನ್ ಅನ್ನೂ ಇರೋದಿಲ್ಲ. ಮತ್ತು ಇದು ಏನು ಅಂತಂದರೆ ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟು ಗೌರ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನಲ್ಲಿ ಇರಲಿಲ್ಲ. ಈಗ ಕ್ರಮೇಣವಾಗಿ ಇದು ಗೌರ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನಲ್ಲಿ ಬರ್ತಾ ಇದೆ. ಹಾಗಾಗಿ ಪೂರ್ ಕಪಲ್ ಆಲ್ಸೋ ಇವತ್ತು ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟನ್ನ ತಗೋಬೋದು. ಯಾಕೆಂದರೆ ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನೋದು ತುಂಬ ಎಕ್ಸ್ಪೆನ್ಸಿವ್ ಅಂತಂದರೆ ಅದು ಖಂಡಿತ ಕಾರ್ಪೊರೇಟ್ ಸೆಕ್ಟರ್ಗೆ ಹೋಗ್ತಾರೆ. ಏಕೆಂತಂದರೆ ಅವ್ರಿಗೆ ಒಳ್ಳೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಬೇಕಾಗ್ತದೆ. ಕೆಲವು ಟೈಮು ಸ್ಟ್ಯಾಂಡಲ್ಲೊಂದು ಸೆಂಟರ್ಗೆ ಹೋಗ್ತಾರೆ. ಈ ಥರದಲ್ಲಿ ಹೋದಾಗ ಅವ್ರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕಾಸ್ಟು ವೇರಿ ಆಗ್ತದೆ. ಗೈಡ್ಲೈನ್ಗೆ ಬಂದಾಗ ಮೊದಲು ನಮ್ಮದು ಗೈಡ್ಲೈನ್ ಅಂತ ಇದ್ದು, ನಾನು ಕೂಡ ಅದರಲ್ಲಿ ಒಬ್ಬ ಎಕ್ಸ್ಪರ್ಟ್ ಕಮಿಟಿ ಮೆಂಬರ್ ಆಗಿದ್ದೆ. ತದನಂತರ ಇದು ಸೆಂಟ್ರಲ್ ಗೌರ್ಮೆಂಟ್ಗೆ ಹೋಗಿ ಅವರು ART ರೂಲ್ ಮತ್ತು ಸರಗಸಿ ಕಾನೂನು ಅಂತ ಮಾಡಿ 2022ರಲ್ಲಿ ಇದಾಯಿತು. ಇದಾದ ನಂತರ ಯಾವುದೇ ಸೆಂಟರ್ಗಳು IVF ಮಾಡಬೇಕು ಅಂತಂತಂದರೆ ಪರ್ಮಿಷನ್ ತೊಗೊಬೇಕಾಗುತ್ತೆ, ಲೈಸೆನ್ಸ್ ತೊಗೊಳ್ಬೇಕಾಗುತ್ತದೆ, ಅದರದ್ದೇ ಆದಂಥ ಕಾನೂನು ಇರ್ತದೆ. ಕಾನೂನನ್ನ ಪಾಲಿಸ್ಕೊಂಡು ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿ. ಯಾಕೆಂದರೆ ಈ ಒಂದು ಸಂಸ್ಥೆಯನ್ನು ಮಾಡಬೇಕಾದ್ರೆ ಮ್ಯಾಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಆಗ್ತದೆ, ಇದನ್ನು ರೆಗ್ಯುಲೇಟ್ ಮಾಡಬೇಕಾಗುತ್ತದೆ ಅಂತಂತ ಹೇಳ್ಬಿಟ್ಟು ಗೌರ್ಮೆಂಟು ಮುಂದೆ ಬಂದು ಇದನ್ನು ಮಾಡಿರುತ್ತೆ. ಯಾಕಂದರೆ ಇದನ್ನು ನಾವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಅಂತೀವಿ. ದಾನಿ ವೀರ್ಯಾಣು, ದಾನಿ ಅಂಡಾಶಯ ಅಂತಂದರೆ ಮೊಟ್ಟೆ ಒಂದು ಫೀಮೇಲ್ನಲ್ಲಿ ಇಲ್ಲ ಅಂತಂತಂದರೆ, ಅಥವಾ ವೀರ್ಯಾಣುಗಳು ಸರಿಯಾಗಿ ಪ್ರೊಡಕ್ಷನ್ ಆಗಲಿಲ್ಲ ಅಂತಂದರೆ ಮೇಲ್ನಲ್ಲಿ ಯಾವ ಥರದವಾಗಿ ನಾವು ಅದನ್ನು ಡಯಾಗ್ನೋಸ್ ಮಾಡಬೇಕು, ಯಾವ ಥರವಾಗಿ ಅದನ್ನು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕು ಅನ್ನೋದನ್ನು ಅದು ಅತ್ಯಾಧುನಿಕ ಟ್ರೀಟ್ಮೆಂಟಿಂದ ನಾವು ಅದನ್ನು ಸಾರ್ಟ್ಔಟ್ ಮಾಡ್ಬೋದು. ಇವತ್ತು ಟೆಸ್ಟಿಕಲ್ ಇಂದ ಸ್ಪಮ್ನ ರಿಟ್ರೀವ್ ಮಾಡ್ಬೋದು. ಎಗ್ಗು ಅಂಡಾಶಯದಲ್ಲಿ ಇಲ್ಲ ಅಂತಂದರೂ ಅಂಡಾಶಯದಲ್ಲಿ ಎಗ್ಗು ಬರೋಗೆ ಮಾಡ್ಬೋದು. ಇದೆಲ್ಲ ಆದ್ರೂ ಕೂಡ ಮುಂದೆ ಸಂಶೋಧನೆ ಆಗುತ್ತಾ ಅದೇ ಒಂದು ಫೀಮೇಲ್ ಅದೇ ಒಂದು ಮೇಲ್ನ ಸಂಬಂಧಪಟ್ಟಂತೆ ಸ್ಪರ್ಮು ಅಂದರೆ ವೀರ್ಯಾಣು, ಮೊಟ್ಟೆ, ಎಗ್ ಅನ್ನೋದನ್ನು ಮಾಡಬೇಕು ಅಂತ ಮಾಡೋ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಬಂದಿದ್ದೀವಿ. ಹೀಗಾಗಿ ಅವರಿಗೆ ನಾವು ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟಿನ ಅತಿ ಶೀಘ್ರವಾಗಿ ಅತಿ ಕಡಿಮೆ ಖರ್ಚಿನಲ್ಲಿ ಮಾಡ್ಬೋದು ಅಂತ ನಾನು ಹೇಳಲು ಇಚ್ಛೆಪಡ್ತೇನೆ.
ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್ ಫಾರ್ ದ ಎನ್ಲೈಟ್ಮೆಂಟ್. ಈಗ ನೀವು ಸೈಂಟಿಫಿಕ್ ಆಗಿ ಎಕ್ಸ್ಪ್ರೆಸ್ ಮಾಡೋದಾದರೆ ಹೇಗೆ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ತೀರಾ ಡಾಕ್ಟರ್ ಎಗ್ ಆ್ಯಂಡ್ ಸ್ಪರ್ಮ್ ಡೋನರ್ ಬಗ್ಗೆ?
ನೋಡಿ, ಯಾವುದೇ ಒಂದು ಕಪಲು, ಬಂಜೆತನ ಇರುವಂಥ ಕಪಲು ಯಾವುದೇ ಒಂದು ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟ್ರಿಗೆ ಹೋದಾಗ ನಾವು ಬೋತ್ ಮೇಲ್ ಆ್ಯಂಡ್ ಫೀಮೇಲ್ಗೆ ಡಯಾಗ್ನೋಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಡಯಾಗ್ನೋಸ್ ಮಾಡಿದಾಗ ನಮಗೆ ಗೊತ್ತಾಗ್ತದೆ. ಕ್ಲಿನಿಷಿಯನ್ಸು ಅದನ್ನು ಯಾವುದೇ ಸಿಮೆನ್ ಅನಾಲಿಸಿಸ್ ರಿಪೋರ್ಟಿಂದ ಸ್ಕ್ಯಾನಿಂಗ್ ಮಾಡಿದಾಗ ಅವ್ರಿಗೆ ಗೊತ್ತಾಗ್ತದೆ ಅವರು ಎಷ್ಟು ಏಜ್ ಇದೆ, ಏನು ಹಿಸ್ಟ್ರಿ ಇದೆ, ಯಾವ ಥರವಾದ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟರೆ ನಾವು ಅವರಿಗೆ ಬಂಜೆತನ ನಿವಾರಣೆ ಮಾಡ್ಬೋದು ಅಂತ ಹೇಳ್ತೇವೆ. ಮೊದಲಿಗೆ ಇಂಟ್ರಾಯುಟ್ರೈನ್ಸ್ ಇನ್ಸೆಮಿನೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಅಲ್ಲಿ ಫೀಮೇಲ್ಗೆ ಏನೂ ತೊಂದರೆ ಇಲ್ಲ, ಅವ್ರಿಗೆ ಮುಟ್ಟು ಸರಿಯಾಗ್ತಾ ಇದೆ, ಮೊಟ್ಟೆಗಳು ಸರಿಯಾಗಿ ಉತ್ಪತ್ತಿ ಆಗ್ತಾ ಇದೆ, ಓನ್ಲಿ ಮೇಲ್ ಫ್ಯಾಕ್ಟ್ರಿ ಇದೆ ಅಂತಂದರೆ ವೀರ್ಯಾಣುವಿನಲ್ಲಿ ಚಲನವಲನಗಳು ಸರಿಯಾಗಿಲ್ಲ, ಮೋಟಿಲಿಟಿ ಸರಿಯಾಗಿಲ್ಲ, ಅದರ ಕ್ವಾಂಟಿಟಿ ಸರಿಯಾಗಿಲ್ಲ ಅಂದಾಗ ಅದನ್ನು ಹೆಚ್ಚಿಗೆ ಮಾಡಿ ಈ ಒಂದು ಪ್ರೊಸೀಜರಿಂದ ಅವ್ರಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಹೇಗೆ ಕೊಡ್ಬೋದು ಅಂತ ಪ್ರಯತ್ನ ಒಂದು ಹಂತದಲ್ಲಿ ಮಾಡ್ತೀವಿ. 1-2 ಸೈಕಲು ಈ ಥರ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದಾಗ ಅವ್ರಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಿಲ್ಲ ಅಂದ ಮಾತ್ರಕ್ಕೆ ಪ್ರಣಾಳ ಶಿಶು ಅಂತ ಹೇಳ್ತೀವಿ ನಾವು, IVF ಅಂತ ಹೇಳ್ಬಿಟ್ಟು. ಈ ಒಂದು ಪ್ರೊಸೀಜರ್ನಲ್ಲಿ ಯಾಕಂದರೆ ಒಂದು ಋತುವಿನಲ್ಲಿ ಒಂದು ಫೀಮೇಲು ಒಂದೇ ಎಗ್ಗನ್ನ ರಿಲೀಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಮಾಡೋದು ನಾವು ಈ ಒಂದು ಪ್ರಣಾಳ ಶಿಶು ಪ್ರೊಸೀಜರ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವ್ರಿಗೆ ಹಾರ್ಮೋನ್ನ ಕೊಟ್ಟು ಅತಿ ಹೆಚ್ಚು ಮೊಟ್ಟೆಗಳನ್ನು ಬರೋಂಗೆ ಮಾಡ್ತೀವಿ. ಯಾಕಂದರೆ ಈಗ ನಮ್ಮ ಗೈಡ್ಲೈನ್ನಲ್ಲಿ 7 ಎಗ್ ಮಾತ್ರ ರಿಟ್ರೀವ್ ಮಾಡಬೇಕು ಅಂತ ಇದೆ. ಹಾಗಾಗಿ ಯಾಕೆಂತಂದರೆ ನಾವು ಏನೇ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಆ ಫೀಮೇಲ್ನ ಆರೋಗ್ಯ ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಇರ್ತದೆ. ಹಾಗಾಗಿ ಅವರು ಹೈಪರ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ಗೆ ಹೋಗಬಾರ್ದು ಅಂತೇಳಿ ಅತಿ ಮೈಲ್ಡ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ ಮಾಡಿ ಅವರಿಗೆ, ಯಾಕಂದರೆ ಈ ಹಾರ್ಮೋನ್ ಕೊಡೋದ್ರಿಂದ ಅವ್ರಿಗೆ ಆರೋಗ್ಯಕ್ಕೆ ತೊಂದರೆ ಇರುತ್ತೆ ಅಂತಲೂ ರಿಪೋರ್ಟ್ಸ್ಗಳು ಇರೋದ್ರಿಂದ ಪದೇ ಕೊಡೋದ್ರಿಂದ ನಾವು ಅವ್ರಿಗೆ ಮೈಲ್ಡ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ ಮಾಡಿ 7 ಎಗ್ಗು ಬರೋಂಗೆ ಅಥವಾ ಬಂದರೂ ಪರವಾಗಿಲ್ಲ 1-2-3 ಹೆಚ್ಚು ಆ ಒಂದು ಮೊಟ್ಟೆಗಳನ್ನು ನಾವು ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಇಲ್ಲಿ ಭ್ರೂಣತಜ್ಞ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟು ಈ ಒಂದು ART ಸೆಂಟ್ರಿಗೆ ಬ್ಯಾಕ್ ಬೋನ್ ಆಗಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ. ಈ ಭ್ರೂಣ ತಜ್ಞ ಅಂತ ಏನು ಮಾಡ್ತೀವಿ ಅಂತಂದರೆ ಮೊಟ್ಟೆ ಮತ್ತು ಸ್ಪರ್ಮ್ನು ಎರಡನ್ನೂ ಒಂದು ಇನ್ಕ್ಯುಬೇಟ್ರ್ ಅಂತ ಇರ್ತದೆ. ಅದು ಆ ಇನ್ಕ್ಯುಬೇಟ್ರು ಒಂದು ಫೀಮೇಲ್ನ ಯುಟ್ರಸ್ಗೆ ಕಂಪೇರ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಆ ಥರದ ಎನ್ವಿರಾನ್ಮೆಂಟ್ನ ಕ್ರಿಯೇಟ್ ಮಾಡಿ ಅಲ್ಲಿ ಒಂದು ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಮಾಡಿ ಭ್ರೂಣ ತಜ್ಞ ಅದನ್ನು 5 ದಿವಸದವರೆಗೂ ಕಾಪಾಡ್ಕೊಂಡು ಬರ್ತಾನೆ. ಇದನ್ನು ಮಾಡಬೇಕಾದ್ರೆ ತುಂಬ ಕ್ವಾಲಿಟಿ ಕಂಟ್ರೋಲ್ ಅಂತ ಇರ್ತದೆ. ಎಕ್ವಿಪ್ಮೆಂಟು ಏನು ಯೂಸ್ ಮಾಡ್ತೀವಿ, ಅಲ್ಲಿ ಏರ್ ಕ್ವಾಲಿಟಿ ಹೇಗಿರ್ತದೆ, ಪ್ರತಿ ದಿವಸ ನಾವು ಅದು ಹೇಗೆ ಮಾನಿಟರ್ ಮಾಡ್ತಾಯಿದ್ದೀವಿ, ಅದನ್ನು ಡಿಸ್ಟರ್ಬ್ ಮಾಡ್ಬೋದು. ಆದ್ದರಿಂದ ನಮಗೆ ಯಾವ ಥರದ ಭ್ರೂಣ ಬರುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗುತ್ತೆ. ಖಂಡಿತವಾಗಿ ಒಳ್ಳೆ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟು, ಒಳ್ಳೆ ಕ್ವಾಲಿಟಿ, ಒಳ್ಳೆ ಟೀಮ್ ಇದ್ದಾಗೆ ಒಳ್ಳೆ ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಆಗುತ್ತೆ. ಆ ಭ್ರೂಣನ ನಾವು ಇನ್ಫರ್ಟಿಲಿಟಿ ಫೀಮೇಲ್ಗೆ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿದಾಗ ಪ್ರಿಪೇರ್ ಮಾಡಿ ಅವ್ರದ್ದು ಎಂಡೋಮೆಟ್ರಿಯಮು ಖಂಡಿತವಾಗಿ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಬರೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ.
ಓಕೆ ಡಾಕ್ಟರ್ ಭಾರತಿ, ಈಗ ಈ ಎಗ್ ಇವ್ರಿಗೆ ಸೂಟ್ ಆಗುತ್ತೆ, ಈ ಸ್ಪರ್ಮ್ ಇವ್ರಿಗೆ ಸೂಟ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಗೆ ನೀವು ಸ್ಕ್ರೀನ್ ಮಾಡ್ತೀರಾ ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ ಬಂದಾಗ?
We first, before anything, okay, when the patient walks in, ask for the donor, they will be having priorities. They have to express their choices. So we keep in consideration those choices. Okay? So when we are selecting a donor, we keep certain criteria which gives a success for them. That is, the first and foremost is the age. As age advances, the fertility decreases. So the ICMR guidelines has given that when we select a woman, she should be around about 25 to 35 years of age, because they have a healthy egg and good genetic baby will be formed. Okay? To make it sure that this is so, what we do is, we personally, have a dialogue with the patient. So when we have a dialogue, we extract their history from them. Okay? The first consideration, as soon as anyone walks in, is the age. Okay? The next we see their BMI. That is the weight and the height, because even the obesity reduces the fertility, because it acts like an inflammation tissue. So keeping the age and this, and we take the physical characteristics of the woman. What are the physical characteristics? That is a woman. So the recipients who are taking the eggs or really they will be in despair to know if the baby is born, will it be resembling me? Will it have the ears like me, or will it have the eyes like me? Will it be intellectual? There won't be any problem. So all this we keep in the mind before we selecting a donor egg or the donor sperm. So when we extract the history of the family, we exclude the family history. And if the donors have got particularly genetic diseases, because if they are carriers, we offer them genetic testing too. Apart from this, we take the blood group which is into consideration. The eye, the weight, the color, the hair, the blood group are the prominent. And usually we counsel the patient when we take the donor or the sperm. See, no two brothers are alike and no two sisters are alike. Isn't it? Little bit mismatch should be there, but
twins are only not
resembling you. Yes. ನಿಮ್ಮ ಥರ ಹೋಲುತ್ತೆ ಅದು, ಆದರೆ ಎಕ್ಸಾಕ್ಟಾಗಿ ಹೋಲೋದಿಲ್ಲ. ಬಟ್ ಬ್ಲಡ್ ಗ್ರೂಪ್ನ ಅವ್ರದ್ದು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಅಪಾರ್ಟ್ ಫ್ರಮ್ ದಿಸ್, ದ ಡೋನರ್ಸ್ಗೆ ನಾವು ವಿಗರಸ್ ಆಗಿ ಎಲ್ಲ ಟೆಸ್ಟ್ಗಳು ಮಾಡ್ತೀವಿ. ಲೈಕ್ ದೇರ್ ಈಸ್ ಫಾರ್ ಅಸ್ ದೇರ್ ಈಸ್ ಎ ಪ್ರೀ ಟೆಸ್ಟಿಂಗ್ ಸ್ಕೀಮ್, ದಟ್ ಈಸ್ ದ ಮೆಡಿಕಲ್ ಸ್ಕ್ರೀನಿಂಗ್ ವಿ ಕಾಲ್. ಅವ್ರಿಗೆ ಏನು ಕ್ಲಿನಿಕಲ್ಲಾಗಿ ಏನು ಕಾಯಿಲೆ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡಿ ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್, ಕಾರ್ಡಿಯಾಕ್ ಸಿಸ್ಟಮ್ ಇವೆಲ್ಲ ನೋಡ್ಕೊಳ್ತೀವಿ. ಏನು ತೊಂದರೆ ಇಲ್ಲ ಅಂತಾದಾದ್ಮೇಲೆ ವಿ ಪ್ರೊಜೆಕ್ಟ್ ದೆಮ್ ಫಾರ್ ಆಲ್ ದ ಬಯೋಕೆಮಿಕಲ್ ಟೆಸ್ಟ್. ಅವ್ರ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಕ್ಯಾರೆಕ್ಟರ್ ಹೆಂಗಿದೆ, ಎಲ್ಲ ಚೆನ್ನಾಗಿದೆಯಾ ಅದೆಲ್ಲ ತಿಳ್ಕೊಂಡು ದೆನ್ ಓನ್ಲಿ ವಿ ರಿಕ್ರೂಟ್ ದೆಮ್ ಟು ದಿ ಡೋನರ್ ಸೈಕಲ್ ಪ್ರೋಗ್ರಾಮ್. ಇವಾಗ ಸ್ಪರ್ಮ್ಸ್ಗೆ ಹೋದರೆ ಸ್ಪರ್ಮ್ಸ್ಗೂ ನಾವು ಅದೇ ಥರ ನಾವು ನೋಡೋದು. ಓಕೆ, ದಿ ಹೈಟು, ದಿ ವೆಯ್ಟು, ದಿ ಕಲರು, ದಿ ಕಾರ್ನಿಯಾ, ದಿ ಬ್ಲಡ್ ಗ್ರೂಪ್ ಇದನ್ನೆಲ್ಲ ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಆಮೇಲೆ ದಿಸ್ ಸ್ಪರ್ಮ್ಸ್ ಯೂಶಲಿ ವಿ ಟೇಕ್ ಇಟ್ ಫ್ರಮ್ ದಿ ಸ್ಪರ್ಮ್ ಬ್ಯಾಂಕ್. ಆ್ಯಂಡ್ ಫಾರ್ ದ oocytes there are two for the eggs. We can go for the oocyte bank or we can go for the fresh collection. Fresh collection give more success than that of the oocyte freezing. ಯಾಕೆ ಅಂದರೆ ನಮಗೆ ಪರ್ಟಿಕ್ಯುಲರ್ ವಿ ಆರ್ ಬಿ ಸೀಯಿಂಗ್ ದೆಮ್ ವರ್ಚುವಲಿ ದೆನ್ ದಟ್. ಓಕೆ, ಸೊ ಆಲ್ ದ ಪೇಷಂಟ್ ಇದರಲ್ಲಿ ನಮಗೆ ಸ್ವಲ್ಪ ತೊಂದರೆ ಆಗುತ್ತೆ. ಸ್ವಲ್ಪ ಜನ ಪೇಷಂಟ್ ದಾನಿಗಳು ನಮಗೆ ಏನಪ್ಪ ಈ ರಿಲಿಜನ್ ಅವ್ರು ಬೇಕು, ವೆಜಿಟೇರಿಯನ್ ಫುಡ್ ಅವ್ರು ಬೇಕು, ಈ ಥರ ಇರಬೇಕು, ಎಜುಕೇಷನ್ ಸ್ಟೇಟಸ್ ಈ ಥರ ಇರಬೇಕು, ಆ ಥರ ಎಲ್ಲ ಇರುವಾಗ ಅವನ್ನೆಲ್ಲ ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಂಡು ಫಸ್ಟ್ ನಾವು ಅವ್ರ ಕಾನ್ಫಿಡೆನ್ಸ್ ತಗೊಳ್ತೀವಿ. ಓಕೆ, ದೆನ್ ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಎ ಡೈಲಾಗ್ ಅವ್ರ ಹತ್ರ ಎಲ್ಲ ಪ್ರಫಾರ್ಮಾ ಚೆನ್ನಾಗಾದಾಗ ದೆನ್ ವಿ ವಿಲ್ ಪೋಸ್ಟ್ ದೆಮ್. ಆದರೆ ಏನಾದರೂ ಸ್ವಲ್ಪ ತೊಂದರೆ ಇತ್ತು ಅಂದ್ರೂ ವಿ ವಿಲ್ ಬಿ ಕ್ಯಾನ್ಸಲಿಂಗ್ ದೆಮ್. ಓಕೆ, ಆ್ಯಂಡ್ ದಟ್ ಟ್ರಸ್ಟ್ ವಿ ಶುಡ್ ಹ್ಯಾವ್ ವಿತ್ ಅವರ್ ಕ್ಲೈಯಂಟ್ಸ್. ಸೊ ಇದರಲ್ಲಿ ಮೇನ್ doctor who is involved is the team is led by the doctor. It is a multidisciplinary approach. ಅಂತಂದರೆ embryologists, supportive group ಅವೆಲ್ಲ they stand behind us. So if anything happens, yes, the doctor is in forefront who will answer their questions. So we have to take personal care, first to have a trust and then to build up the further conversation. So expertise management is very much important.
ಕಿಡೋನರ್ ಸಿನಿಮಾ ನೋಡಿದ್ರೆ ಅರ್ಥ ಆಗ್ಬಿಡುತ್ತೆ ಅನ್ಸುತ್ತೆ.
ನಾನು ಒಂದು ಎರಡು ಈಗ ICMR ಗೈಡ್ಲೈನ್ ಅನ್ನೋದು ಇಟ್ ಈಸ್ ನಾಟ್ ಇನ್ ಅ ಪಿಕ್ಚರ್ ಮೇಡಮ್. ನೌ ಇಟ್ ಈಸ್ ಎ ರೂಲ್. assisted reproductive technology and surrogacy, it is in a rule. It has been passed. ICMR was in a guideline. Now we are bound to follow the rule. If we don't ನಾವು ಈ ರೂಲನ್ನು ಫಾಲೋ ಮಾಡಲಿಲ್ಲ ಅಂತಂದರೆ ಅದರಲ್ಲೇ ನಮಗೆ ಏನು ಒಂದು ಸೆಂಟ್ರಲ್ಲಿ ಯಾರು ಇನ್ವಾಲ್ವ್ ಆಗಿರ್ತಾರೆ, ಯಾರು ಮಾಡ್ತಾರೆ, ಅವ್ರಿಗೆ ಇಷ್ಟು ಪೆನಾಲ್ಟಿ ಅಂತ ಇರುತ್ತದೆ. ಮತ್ತು ಗೈಡ್ಲೈನ್ ಇಸ್ ಟು ಫಾಲೋ ಇಟ್, ರೂಲ್ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಫಾಲೋಡ್. ರೂಲ್ನ ನಾವು ಫಾಲೋ ಮಾಡಲಿಲ್ಲ ಅಂದರೆ ವಿ ವಿಲ್ ಬಿ ಪೀನಲೈಸ್ಡ್. ಬಟ್ ಇದು ಡೋನರ್ ಎಗ್ಗು ಡೋನರ್ ಸ್ಪರ್ಮ್ಗೆ ಬಂದಾಗ ಮೊದಲು ಇದು ತುಂಬ ಸರಳವಾಗಿ ಆಗ್ತಾಯಿತ್ತು. ಯಾಕೆಂದರೆ ಕ್ಲಿನಿಷಿಯನ್ನೇ ಆಗಲಿ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟೇ ಆಗಲಿ ಇದರಲ್ಲಿ ಜಾಸ್ತಿ ಎಡೆಕು ಇರಲಿಲ್ಲ. ಬಟ್ ಈಗ ರೂಲ್ಸ್ ಬಂದಾದ ಮೇಲೆ ನೀವು ಒಂದು ಡೋನರ್ನ ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವರು ಕನ್ಸೆಂಟ್ ಕೊಡಬೇಕಾಗ್ತದೆ. ಇದನ್ನು ನಾವು ಕಮರ್ಷಿಯಲೈಸ್ ಮಾಡೋಂಗಿಲ್ಲ. ಈಗ ಒಂದು ಡೋನರ್, ಫೀಮೇಲ್ ಡೋನರ್, ಅವರು ಫೈರ್ ಆಗಿದ್ದಾರೆ, ಅವರು ಚೆನ್ನಾಗಿದ್ದಾರೆ, ನನಗೆ ಇದೇ ಡೋನರ್ ಬೇಕು, ನಾನು ಎಷ್ಟು ಬೇಕಾದ್ರೂ ದುಡ್ಡು ಕೊಡ್ತೀನಿ, ಈ ಥರದ್ದು ಇಲ್ಲ. ಯಾಕೆಂದರೆ ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಅನ್ನೋದೇ ಇದಕ್ಕೆ ನಾನು ಹೇಳೋದು. ಯಾಕೆಂತಂದರೆ ನೀವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಯೂಸ್ ಮಾಡಬೇಕಾದ್ರೆ ಅದು ವಾಲಂಟಿಯರ್ಸ್. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ನಮ್ಮ ಇಂಡಿಯನ್ ಸಿನಿಯಾರಿಯೋದಲ್ಲಿ ಇದು ಆಗೋದಿಲ್ಲ. ಯಾರೇ ಮುಂದೆ ಬಂದರೂ ಅವ್ರಿಗೆ ಮಾನಿಟ್ರಿ ವೈಸು ಸ್ವಲ್ಪ ಕಾಂಪನ್ಸೇಟ್ ಮಾಡಬೇಕಾಗ್ತಾಯಿದೆ. ನಾನು ಕೂಡ ಒಂದು ART ಬ್ಯಾಂಕ್ ಅನ್ನೋದನ್ನು ರನ್ ಮಾಡ್ತಾಯಿದ್ದೀನಿ. ಇಲ್ಲಿ ವಾಲಂಟಿಯರ್ಸ್ ಆಗಿ ಸಿಮೆಂಟ್ ಡೋನರ್ಸ್ ಬರ್ತಾರೆ, ಆಮೇಲೆ ಫಿಮೇಲ್ ಡೋನರ್ ಊಸೈಟ್ ಮಾಡೋರು ಬರ್ತಾರೆ. ಅವ್ರಿಗೆ ನಾವು ಮೊದಲಾಗಿ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಸೆಕ್ಷುಲಿ ಟ್ರಾನ್ಸ್ಫರ್ ಡಿಸೀಸ್ ಇದೆಲ್ಲ ಇದೆಯಾ ಅಂತ ಫ್ಯಾಮಿಲಿ ಪಿಡಿಗ್ರಿ ಮಾಡಬೇಕಾಗ್ತದೆ. ಯಾವುದು ಬ್ಲಡ್ ಗ್ರೂಪು, ಕಂಪ್ಲೆಕ್ಷನ್ ಏನು, ಏರ್ ಕಲರು, ಐ ಕಲರು, ದೀಸ್ ಆರ್ ದ ಮೇಜರ್ ಪ್ರೊಫೈಲನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಇದನ್ನು ಮಾತ್ರ ಮ್ಯಾಚ್ ಮಾಡೋಕ್ಕೆ ಆಗೋದು. ಯಾಕೆಂತಂದರೆ ನಮ್ಮಲ್ಲಿ ಈ ಥರದ ವಾಲಂಟಿಯರ್ಸು ತುಂಬ ಕಡಿಮೆ. ಮಾನಿಟ್ರಿ ವೈಸು ಡಿಮ್ಯಾಂಡ್ ಮಾಡಿದಾಗ ಮಾತ್ರ ಈ ಥರ ಡೋನರ್ಸ್ ಬರ್ತಾರೆ ಹೊರತು ವಾಲಂಟ್ರಿಗೆ ಬಂದು ನಾನು ಐ ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಡೊನೇಟ್. ನಿಮಗೆ ಗೊತ್ತಿರಬೇಕು, ಒಂದು ಎರಡು ಸೆಲೆಬ್ರಿಟೀಸ್, ಬಾಲಿವುಡ್ ಸೆಲೆಬ್ರಿಟೀಸ್, ದೇ ಐ ವಾಂಟ್ ಟು ಗೋ ಆನ್ ಸೊರೊಗೇಸಿಸ್ ಬಿಕಾಸ್ ದೇ ಡಸಂಟ್ ವಾಂಟ್ ಟು ಬೇರ್ ದ ಚೈಲ್ಡ್. ದಿಸ್ ಈಸ್ ಬಿಫೋರ್ ದ ಆ್ಯಕ್ಟ್ ಹ್ಯಾಸ್ ಕಮ್ ಇನ್ ಟು ದ ಪಿಕ್ಚರ್. ಇದನ್ನು ನಾವು ಕಮರ್ಷಿಯಲೈಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಫೀಮೇಲ್ನ ಅಬ್ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಅಂತ ಆದಾಗ ಮಾತ್ರ ಇದು ಬಂತು. ಈಗ ಒಂದು ಸೊರೊಗೇಸಿ ಮಾಡಬೇಕು ಅಂದರೆ ಸುಮಾರು ಸ್ಟೆಪ್ಸ್ಗಳಿದೆ. ಅವ್ರಿಗೆ
ರೂಲ್ಸ್ ಏನಿದೆ ಸ್ವಲ್ಪ ಕ್ರಿಸ್ಪ್ ಆಗಿ.
ಅವ್ರಿಗೆ ಮೊದಲು ಸರ್ಟಿಫಿಕೇಷನ್ ಆಗಬೇಕಾಗ್ತದೆ. ಈಗ ಯಾವುದಾದ್ರೂ ಒಂದು ಫೀಮೇಲನ್ನ ನಾನು ಐಡೆಂಟಿಫೈ ಮಾಡಿದೆ ಅಂತಂದರೆ ರಿಸಿಪಿಯೆಂಟ್ ಕಪಲ್ಗೆ, ಗಾರ್ಡಿಯನ್ ಕಪಲ್ಗೆ ಅವರು ಮೊದಲು ನಾನು ಐ ವಿಲ್ ಟೆಲ್ ಯು ಮೈ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್. ಐ ಹ್ಯಾವ್ ಟು ಸೆಂಡ್ ಟು KC ಜನರಲ್ ಹಾಸ್ಪಿಟಲ್. ಅಲ್ಲಿ ಗೌರ್ಮೆಂಟ್ ಗೈನೆಕ್ಸ್ ನೋಡ್ತಾರೆ, ಸೈಕಾಲಜಿ ಬೇರೆ ಬೇರೆ ಡಿಪಾರ್ಟ್ಮೆಂಟಲ್ಲಿ ಅವರು ಹೋಗಬೇಕಾಗುತ್ತದೆ. ಅವರು ಸೂಟಬಲ್ಲ, ಕಮರ್ಷಿಯಲ್ ಆಗಿ ಮಾಡ್ತಾ ಇದ್ದಾರಾ, ಯಾವುದು ಮಾನಿಟ್ರಿ ವೈಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರಾ, ಇದನ್ನೆಲ್ಲ ಮಾಡ್ತಾರೆ. ತದನಂತರ ಅವರು ಕೋರ್ಟ್ಗೆ ಹೋಗಬೇಕಾಗ್ತದೆ. ರಿಸಿಪಿಯೆಂಟ್ ಕಪಲು ಕೋರ್ಟ್ಗೆ ಹೋಗಬೇಕಾಗ್ತದೆ, ಅಫಿಡೇವಿಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಕೋರ್ಟ್ನಲ್ಲಿ ಮ್ಯಾಜಿಸ್ಟ್ರೇಟರು ಓಕೆ ಈ ಕಪಲ್ಗೆ ನೀವು ಸೊರೊಗೇಟಿ ಮಾಡ್ಬೋದು. ಅದಾದ ನಂತರದ ಆರೋಗ್ಯ ಭವನಕ್ಕೆ ಹೋಗಬೇಕಾಗ್ತದೆ. ಅಲ್ಲಿ ಇದಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಂತೆ ಒಬ್ಬರು ಚೇರ್ಮನ್ ಅಂತ ಇರ್ತಾರೆ, ಮೇಯ್ನಾಗಿ ಕಮಿಷನರು. ಅವ್ರ ಕಡೆಯಿಂದ ಸರ್ಟಿಫಿಕೇಟ್ ಬಂದರೆ ಮಾತ್ರ ಆಗ ಆ ಸರ್ಟಿಫಿಕೇಟಿಗೆ 2 ವರ್ಷಗಳ ಕಾಲ ಇರ್ತದೆ. ಆ 2 ವರ್ಷ ಕಾಲದಲ್ಲಿ ಅವರು ಈ ಸೊರೊಗೇಸಿಗೆ ಹೋಗ್ಬೋದು. ಏನಕ್ಕೆಂದರೆ ನಾನು ಅಲ್ಲಿ ಒಬ್ಬ ಎಕ್ಸ್ಪರ್ಟ್ ಕಮಿಟಿ ಆಗಿ ಮೆಂಬರ್ ಆಗಿದ್ದೀನಿ. ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಇದ್ದಾರೆ, ಹೆಲ್ತ್ ಮಿನಿಸ್ಟ್ರು. ಅದ ನಂತರ PCPNDT ಆ್ಯಕ್ಟ್ರು ಡಾಕ್ಟರ್ ವಿವೇಕ್ ದೊರೆ ಅವರು ಬಂದಿದ್ದರು. ಆಮೇಲೆ ಇದು ಒಂದು ನ್ಯಾಷನಲ್ ಬೋರ್ಡ್ ಆದ ನಂತರ ಸ್ಟೇಟ್ ಬೋರ್ಡು ಈಗ ನಾವು ಒಂದು ಸಾಫ್ಟ್ವೇರ್ ಅಂತ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಯಾವುದೇ IVF ಸೆಂಟ್ರಲ್ಲಿ ಏನೇ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡಿದ್ರು 1 ವೀಕ್ ಆದಮೇಲೆ ಅವರು ಎಂಟ್ರಿ ಮಾಡಬೇಕಾಗ್ತದೆ. ಸ್ಕ್ರೂಟಿನಿಗಳಾಗ್ತದೆ, ಮ್ಯಾಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಆಗಬಾರ್ದು ಅಂತ. ಸೊ ಹೀಗಾಗಿ ನವೆಡೇಸ್ ಇಟ್ ಈಸ್ ಬಿಕಮಿಂಗ್ ವೆರಿ TDS ಫಾರ್ ಕ್ಯಾರಿಂಗ್ ಔಟ್ ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್.
ಆದರೆ ಈಗಲೂ ಅಷ್ಟೇ, ನನ್ನ ಹತ್ರನೂ ಅಷ್ಟೇ ಎಷ್ಟೋ ಜನ ಈಗ ಬರ್ತಾರೆ. ದೇರ್ ಆರ್ 2 ಟೈಪ್ ಆಫ್ ಅಪ್ರೋಚಸ್, ಆಲೋಯಿಸ್ಟಿಕ್ ಅಪ್ರೋಚ್ ಆ್ಯಂಡ್ ಕಮರ್ಷಿಯಲ್ ಅಪ್ರೋಚ್. ಹೇಳ್ತಾರೆ ನಮ್ಮ ಅಕ್ಕ, ನಮ್ಮ ತಂಗಿ, ನಮ್ಮ ಕಸಿನ್ ಸಿಸ್ಟರು ನಮಗೆ ದುಡ್ಡು ಹಾಕೋದಿಲ್ಲ, ಸೊ ಅವ್ರನ್ನ ನಾವು ಮಾಡ್ಬೋದಾ ಅಂತ. ಎಸ್, ನಾವು ಈಗ ಸ್ವಲ್ಪ ರೂಲ್ಸ್ ಸ್ವಲ್ಪ ವೇವ್ ಆಗಿರೋದ್ರಿಂದ ವಿ ಕ್ಯಾನ್ ಟೇಕ್ ದಾನಿಗಳು ಫ್ರಮ್ ಅವರ್ ರಿಲೇಟಿವ್ಸ್, ಬಟ್ ನಾಟ್ ಫ್ರಮ್ ಪೇರೆಂಟ್ಸ್ ಆರ್ ಎನಿಥಿಂಗ್. ಇಟ್ ಶುಡ್ ಬಿ ಕಸಿನ್ಸ್, ಸಿಸ್ಟರ್ಸ್ ಆರ್ ಫ್ರಮ್ ದಿ ರಿಲೇಟಿವ್ಸ್ ಹೂಮ್ ದೇ ನೋ. ಆವಾಗ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಫೈನಾನ್ಷಿಯಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ಗೆ ತುಂಬ ಈಸಿ ಆಗುತ್ತೆ. ಓಕೆ, ಸೊ ಅದೊಂದು ಸ್ವಲ್ಪ ರೂಲ್ ಸ್ವಲ್ಪ ವ್ಯತ್ಯಾಸ ಆಗ್ತಾ ಇದೆ. ಸೊರೊಗೇಸಿನೂ ಅಷ್ಟೇ ಅವ್ರ ಕಡೆಯಿಂದ ಕರ್ಕೊಂಬಂದು ಅವ್ರು ಮಾಡ್ಬೋದು ಈಗ. ಸೊ ಆದರೆ ಲಿಗ್ಯಾಲಿಟೀಸ್ ಎಲ್ಲ ಇದೆ, ವಿ ಹ್ಯಾವ್ ಟು ಗೋ ಥ್ರೂ ದ ಲಿಗ್ಯಾಲಿಟೀಸ್. ಇದಕ್ಕೆ ಕಮಿಷನಿಂಗ್ ಏಜೆಂಟ್ಸು ಇದ್ದಾರೆ, ಬಟ್ ಕಮಿಷನಿಂಗ್ ಏಜೆಂಟ್ ವಿಲ್ ಬಿ ಮೋರ್ ಎಕ್ಸ್ಪೆನ್ಸಿವ್. ಆವಾಗ ಅವರೇ ಹೋಗಿ ಅಫಿಡವಿಟ್ ಮಾಡಿಸಿ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಹೇಳ್ದಂಗೆ ಮಾಡ್ಬೋದು. ಓಕೆ, ಸೊ ಇಟ್ ವಿಲ್ ಬಿ ಯೂಸ್ಫುಲ್ ಪ್ಲ್ಯಾಟ್ಫಾರ್ಮ್ ಸೊ ದಟ್ ಯಾರಿಗೆ ಆಗಲ್ಲ, ಯಾವ ಯಂಗ್ಸರ್ಗೆ ಫಿಸಿಕಲಿ ಫಿಸಿಕಲಿ ಹ್ಯಾಂಡಿಕ್ಯಾಪ್ ಇರ್ತಾರೆ, ಅಥವಾ ಕಾರ್ಡಿಯಾಕ್ ಡಿಸೀಸಸ್, ಮೆಡಿಕಲ್ ಡಿಸೀಸಸ್, ಅಥವಾ ಅವ್ರಿಗೆ ಮಗು ಆಗಲ್ಲ ಅಂತ ಇರುತ್ತೋ ಅವರು ಸೊರೊಗೇಟರ್ನ ತಗೊಳ್ಬೋದು.
ಈಗ ಒಂದೇ ಒಂದು ಟರ್ಮ್ನ ಆ್ಯಡ್ ಮಾಡಿದ್ದಾರೆ ಮೇಡಮ್ ಹೇಳ್ದಂಗೆ, ಅಲ್ಟ್ರುಸ್ಟಿಕ್ ಅಂತಂದರೆ ಇಟ್ ಈಸ್ ವೆರಿ ಕಾಮನ್. ಯಾರು ಮುಂದೆ ಬರ್ತಾರೆ ವಾಲಂಟಿಯರಾಗಿ ಹೆಲ್ಪ್ ಮಾಡೋದಂತ. ಇಟ್ ಮೇ ನಾಟ್ ಬಿ ಓನ್ ಫ್ಯಾಮಿಲಿ, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಅದರ್ ಫ್ಯಾಮಿಲಿ ಆಲ್ಸೋ. ಅದಕ್ಕೋಸ್ಕರ ನಾವು ಯಾವಾಗಾದ್ರೂ ಕಾನೂನು ಮಾಡಬೇಕಾದ್ರೆ ನಮ್ಮ ಈ ಜಿಯೋಗ್ರಫಿಕಲ್ ಇದರಲ್ಲಿ ಯಾವ ಥರ ಪಾಪ್ಯುಲೇಷನ್ ಇದೆ, ಅವ್ರದ್ದೆಲ್ಲ ಲೈಫ್ ಸ್ಟೈಲ್ ಹೇಗಿದೆ, ಹೇಗೆ ಯುಟಿಲೈಸ್ ಆಗುತ್ತೆ, ಆ ಥರ ಮಾಡಬೇಕಾಗ್ತದೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಸಿನಾರಿಯೋ ಇಫ್ ಯು ಟೇಕ್ ಇನ್ ಎ ನಾರ್ತ್, ಸೌತ್, ವೆಸ್ಟ್, ಲೈಫ್ ಸ್ಟೈಲ್, ಜಿಯೋಗ್ರಫಿಕಲ್ ಡಿಫ್ರೆನ್ಸ್, ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ಡಿಫ್ರೆನ್ಸ್. ನಾವು ಅದನ್ನು ಮಾಡಬೇಕು. ಈಗ ಅದಕ್ಕೋಸ್ಕರ ಅಲ್ಟ್ರುಸ್ಟಿಕ್ ಅಂತ ಆದಾಗ ನಾವು ನಮ್ಮ ಫ್ಯಾಮಿಲಿಲೇ ಯಾರು ಬಂದರೆ ಇಟ್ಸ್ ಓಕೆ, ಇಲ್ಲ ಅಂತಂದರೆ ದೋಸ್ ಹು ಕಮ್ ಇನ್ ಫೇವರ್ ಆಫ್ ಹೆಲ್ಪಿಂಗ್ ಔಟ್ ಇನ್ಫರ್ಟೈಲ್ ಕಪಲ್, ದಟ್ ಈಸ್ ಅಕ್ಸೆಪ್ಟೆಡ್.
Actually, many of them are not aware of these rules.
ಇದಕ್ಕೊಂದು ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಇದೆ. ಯಾಕೆ ಅಂತಂದರೆ ಡೋನರ್ ಸ್ಪರ್ಮ್ಸು ಡೋನರ್ ಎಗ್ಸ್ಗೆ ಯಾಕೆ ಅಂದರೆ ಲೆಜಿಮಿಟ್ ಏನಪ್ಪ ಆ ಮಕ್ಕಳು ವಾರಸ್ದಾರಾಗ್ತಾರೆ ಆರ್ತಿಗೆ. ನಾನೊಂದು ಎಕ್ಸಾಂಪಲ್ ಹೇಳ್ತೀನಿ. ನಾನೊಂದಲ್ಲೇ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ ನನ್ನ ಕೆಲಸ, ಆ ಹಾಸ್ಪಿಟಲ್ ನೇಮೆಲ್ಲ ಹೇಳೋದಿಲ್ಲ. ಓಕೆ, ಈ ಮೆಟ್ ವಿತ್ ಆಕ್ಸಿಡೆಂಟ್ ಆದಾಗ ಓಕೆ ಈ ವಾಸ್ ಬ್ರೈನ್ ಡೆತ್ ಆಗಿತ್ತು. ಸೊ ಹಾಸ್ಪಿಟ್ಲಿಂದ ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ಗೆ ಹೋದರು. ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ಗೆ ಹೋದಾಗ ಲಿವರ್ ತೊಗೊಂಡ್ರು, ಕಿಡ್ನೀಸ್ ತೊಗೊಂಡ್ರು. Then they gave me immediate call. Doctor, the wife is asking for his sperms. What will you do? So I told, please wait, I will come down. Okay, because already they were in the OT. I told there is no rule to take the sperms from the dead person. Though the wife wants or though the family wants. ಯಾಕೆ ಅಂತಂದರೆ ಅವ್ರು ಆ ಮಗು ಮಾಡಿಕೊಂಡು ವಾರಸ್ದಾರಾಗಿ ಅವರು ಅವ್ರದ್ದು ಮುಂದಿನ ಇದಾಗುತ್ತೆ, ಅವ್ರದ್ದು ಪ್ರಾಪರ್ಟಿ ಎಲ್ಲ ತಗೊಳ್ಬೋದು ಅಂತ. ಸೊ ಎ ವಿಡೋ ಈಸ್ ನಾಟ್ ಅಲೌಡ್ ಟು ಟೇಕ್ ಎ ಸ್ಪರ್ಮ್ಸ್ ಫ್ರಮ್ ದಿ ಡೆಡ್ ಪರ್ಸನ್.
No madam, let me clarify. Very recently Supreme Court has reviewed it actually. Not only the female, parents also can go use that sperm sample of the husband posthumously, because parents has gotten a right. And in your case actually, if she is married, her sperm sample can be, see, their vested interest is different. That lady has a right, she is legitimately married, okay?
But
if the husband
law
is
not
dead,
allowed
husband
to take
is
the
dead,
sperms from the dead person.
No, with a consent.
No,
if
not with the
if
consent.
the brain dead,
they have to get legal immediately.
No,
they
no,
cannot
no.
take within the terms. So I had a legal advisor and I took, and they told no. Because
Actually,
a
not
woman
just you,
can
doctor,
have a
many of
child,
them are
but
not
she may
aware
leave
of
it
the
later.
rules and
She
regulations.
may leave the father-in-law and the mother-in-law and go only for the property she can have the child. So they told no, it is not allowed.
Okay.
No madam, brain dead, it is not declared. Wife can avail it because she is legitimately married. What is property, what is going to happen, it's okay.
The guidelines are not proper
single woman, even if she doesn't use her own married husband sample also, she has a right to use some other sample, second option. And as a male, I cannot use somebody's egg. In rule, it is not allowed. Single woman, it is allowed.
Yeah.
It is in the rule.
If the husband gives a consent, she can have. If she is married, if it is a single, okay? But if it is not, it comes as adultery. So these laws are still not well formed, so that it needs further depth to go into this one, to study
Actually,
and to
Bollywood
formulate
celebrities have actually glorified surrogacy so much that people are they're not aware of the rules of actually.
Pardon?
Which Bollywood celebrities and all have actually glorified surrogacy to an extent that people are not aware of the rules. They just think it's fancy to have
Yeah, it is fancy,
kids
true.
and things like
That's
that. Thanks for
exactly.
the rules, but continuing with our topic, maybe we can, doctor, if you can just tell us what are the complications you face for a successful fertilization?
Okay, this is something else. As a embryologist, ಒಬ್ಬ ಭ್ರೂಣ ತಜ್ಞ, ಒಂದು ಎಂಬ್ರಿಯಾಲಜಿ IVF ಲ್ಯಾಬ್ನಲ್ಲಿ ಮೊಟ್ಟೆ ಮತ್ತು ವೀರ್ಯಾಣು ಮತ್ತು ಮೊಟ್ಟೆನ ಹೇಗೆ ಪೋಷಿಸ್ಕೊಂಡು ಹೋಗಬೇಕಾಗ್ತದೆ ಅನ್ನೋದು, ದಿಸ್ ಈಸ್ ಸಮಥಿಂಗ್ ಎಲ್ಸ್ ಇಸ್ ವೆರಿ ಡಿಫ್ರೆಂಟ್, ಬಿಕಾಸ್ ನೋ ಇಟ್ ಈಸ್ ಕಮ್ಸ್ ಬೈ ದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್, ಎಕ್ಸ್ಪರ್ಟೈಸ್, ಲೈಕ್ ಎನಿ ಮೇಜರ್ ಸರ್ಜನ್, any major experienced clinicians does is OT work. ಅದೇ ಥರದಲ್ಲಿ ಒಂದು ವೀರ್ಯಾಣು ಒಂದು ಮೊಟ್ಟೆನ ಜೊತೆಗೆ ಸೇರಿಸಿ ಅದನ್ನು ಭ್ರೂಣ ಮಾಡಿ ಅದನ್ನು 2 ದಿವಸ 3 ದಿವಸ 4 ದಿವಸ ಒಂದು ಹಂತದವರೆಗೆ ತೆಗೆದುಕೊಂಡು ಹೋಗಿ ಅದನ್ನು ಗರ್ಭಕೋಶಕ್ಕೆ ಹಾಕ್ತೀವಿ. ಅದು ಮಾಡಬೇಕಾದರೆ ಒಂದು ಹಂತದಿಂದ ಒಂದು ಹಂತದವರೆಗೂ ಭ್ರೂಣ ಇದು ಹೇಗೆ ಡೆವಲಪ್ ಆಗ್ತದೆ, ಯಾಕೆಂದರೆ ಒಂದು ಹಂತದಿಂದ ಒಂದು ಡೆವಲಪ್ಮೆಂಟ್ ಇರ್ತದೆ. ಆ ಒಂದು ಡೆವಲಪ್ಮೆಂಟ್ ಇದ್ದಾಗ ಮಾತ್ರ ಈ ಭ್ರೂಣ ಅತಿ ಹೆಚ್ಚಾಗಿ ಚೆನ್ನಾಗಿದೆ, ಇದನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ಬೋದು. ಇದನ್ನು ಸೆಲೆಕ್ಟ್ ಮಾಡೋದ್ರಿಂದ ಇಂಪ್ಲಾಂಟೇಷನ್ ಆಗ್ಬೋದು, ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗ್ಬೋದು ಅಂತ ಇರ್ತದೆ. ಇದು ಮಧ್ಯದಲ್ಲಿ ಡಿಪೆಂಡಿಂಗ್ ಆನ್ ದ ಕೇಸ್ ಹಿಸ್ಟ್ರಿ ನಾವು ಇದು ಒಂದು ಬ್ಲಾಸೋಸಿಸ್ ಸ್ಟೇಜ್ಗೆ ತಗೊಂಡು ಹೋಗ್ಬೋದಾ, ಎಗ್ನ ಯಾವ ಥರ ಮಾನಿಟರ್ ಮಾಡಬೇಕಾಗುತ್ತೆ, ಅಥವಾ ಭ್ರೂಣನ ಯಾವ ಥರ ಮಾನಿಟರ್ ಮಾಡಬೇಕಾಗ್ತದೆ, ಒಳ್ಳೆ ಭ್ರೂಣನ ನಾವು ಹೇಗೆ ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ, ಇದಕ್ಕೆ ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿ ಎಲ್ಲ ಇರ್ತದೆ. ಈ ಒಂದು ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿನ ಯೂಸ್ ಮಾಡಿ ನಾವು ಆ ಭ್ರೂಣವನ್ನು ಸೆಲೆಕ್ಟ್ ಮಾಡೋದ್ರಿಂದ ನಾವು ಒಂದು ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟನ್ನ ಇನ್ಕ್ರೀಸ್ ಮಾಡ್ಬೋದು ಅಂತ ಹೇಳ್ಬೋದು.
ಡಾಕ್ಟರ್ ಭಾರತಿ, ಈಗ ಅನಾನಿಮಿಟಿ ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಡೋನರ್ಸಲ್ಲಿ. ಸೊ ಹೌ ಡು ಯು ಮೇಂಟೈನ್ ಕಾನ್ಫಿಡೆನ್ಷಿಯಲಿಟಿ?
Anonymity, yes. First, we should see, this is a multidisciplinary approach again. ಡಾಕ್ಟ್ರು ಒಬ್ಬರಿಂದನೇ ಆಗಲ್ಲ. ಒಬ್ಬರು ಡೋನರ್ ಬಂದರು ಅಂತ ತಿಳ್ಕೊಳ್ಳಿ, ಅವರು ಡಾಕ್ಟ್ರ್ ಅನಾನಿಮಿಟಿ ಹೇಳ್ದಿರ ಯಾರಿಗಾದರೂ ಇರಬಹುದು, ಆದರೆ ಅವ್ರ ಸ್ಟಾಫ್ಸ್ ಅವ್ರನ್ನೆಲ್ಲ ಅದಕ್ಕೇ ರೆಗ್ಯುಲರ್ ಆಗಿ ವಿ ಶುಡ್ ಹ್ಯಾವ್ ಮೀಟಿಂಗ್ಸ್, ವಿ ಶುಡ್ ಹ್ಯಾವ್ ಆಡಿಟ್, ಓಕೆ, ಆ್ಯಂಡ್ ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್ಸ್ ಅಂತ ಇರುತ್ತೆ. ಸೊ ವಿ ವಿಲ್ ಬಿ ಫಿಲ್ಲಿಂಗ್ ಅಪ್ ಆಲ್ ದೋಸ್ ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್ಸ್ ಆ್ಯಂಡ್ ಟೇಕ್ and keep the privacy for the donor ಅವ್ರು ಬಂದಾಗ. ಸೊ ಆಮೇಲೆ ಇನ್ನೊಂದು we have to foster them with respect. For sometimes we have seen the personal will feel annoyed, okay, without any proper respect or privacy or anything, okay, but we have to be transparent too, okay. We need to tell them what is necessary, what information to be given and properly recorded. So it all needs a team, and privacy and confidential is kept so that there won't be rift in the family later, okay.
Okay, Dr. Srinivas, how
anonymity is a big problem now, madam, after this ART rule has come. If ನಾನು ಒಂದು ಡೋನರ್ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ ಅಂತಂದರೆ ಅವರು ಒಂದು ಆಧಾರ್ ಕೊಡಬೇಕಾಗ್ತದೆ, ಆಧಾರ್ ಕಾರ್ಡ್ ಕೊಡಬೇಕಾಗ್ತದೆ. ಆಧಾರ್ ಕಾರ್ಡನ್ನು ನಾನು ಯಾವ ಸೆಂಟರ್ಗೆ ಡೋನರ್ ಸ್ಯಾಂಪಲ್ ಕಳಿಸ್ತೀನಿ ಅಥವಾ ಡೋನರ್ ವೆಬ್ಸೈಟ್ಗೆ ಕಳಿಸ್ತೀನಿ ಅಂದಾಗ ಆಧಾರ್ ಕಾರ್ಡು ನಾವು ಶೇರ್ ಮಾಡಿದಾಗ ಅನಾನಿಮಿಟಿ ಅನ್ನೋದು ಒಂದು ಕಾಂಪ್ರಮೈಸ್ ಆಗ್ತದೆ. ಮೊದಲು ICMR ಗೈಡ್ಲೈನ್ ಇದ್ದಾಗ ಅನಾನಿಮಿಟಿ ಅನ್ನೋದನ್ನು ನಾವು ಇಡ್ತಾ ಇದ್ದೋ. ಈಗ ಆಧಾರ್ ಕಾರ್ಡ್ ಕೊಡೋದ್ರಿಂದ ಬಿಕಾಸ್ ಅದು ಒಂದು ART ಸೆಂಟ್ರಲ್ಲಿ ಮಾತ್ರ ಇರೋದಿಲ್ಲ, ಅದನ್ನು ನಾನು ಬೇರೆ ಒಂದು ಸೆಂಟ್ರಿಗೆ ಶೇರ್ ಮಾಡಿರೋದ್ರಿಂದ ಅಲ್ಲಿ ಒಬ್ಬರ ಕೈನಲ್ಲಿ ಇರೋದಿಲ್ಲ. ಇದು ಒಂದು ರಿಸೆಪ್ಷನ್ಗೆ ಹೋಗ್ತದೆ, ಅದೊಂಥರ ಫೈಲ್ಗೆ ಹೋಗ್ತದೆ, ಬೇರೆ ಎಲ್ಲ ಹೋಗ್ತದೆ. ಹಾಗಾಗಿ ಈ ಒಂದು ಅನಾನಿಮಿಟಿ ಅನ್ನೋದು ಸ್ವಲ್ಪ ಬ್ರೇಕ್ ಆಗಿದೆ. ಇದರಿಂದ ಫ್ಯೂಚರಲ್ಲಿ ಈ ಒಂದು ಪ್ರೊಸೀಜರ್ ಮಾಡಿ ಮಗು ಆದಾಗ ಸೋಷಿಯಲ್ ಪ್ರಾಬ್ಲಮ್ ಮೇ ಅರೈಸ್. ದಿಸ್ ಇಸ್ ದ ಒನ್ ಕನ್ಸರ್ನ್ ಆ್ಯಕ್ಚುಲಿ. ದಿಸ್ ವಿ ಹ್ಯಾವ್ ಬೀನ್ ಎಕ್ಸ್ಪ್ಲೋರಿಂಗ್ ಇಟ್ ಆ್ಯಕ್ಚುಲಿ. ರಿವ್ಯೂ ಮಾಡಿದರೆ ಅನಾನಿಮಿಟಿ ಇದ್ದಾಗ ವಿ ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಬ್ರೇಕ್ ದಿಸ್ ಕೈಂಡ್ ಆಫ್ ಥಿಂಗ್.
ಸೊ ಡಾಕ್ಟರ್, ಈಗ ಸರೋಗೇಟ್ ಆಗಬೇಕಂದ್ರೆ ಅವ್ರ ಮೆಡಿಕಲ್ ಕಂಡೀಷನ್ಸ್ ಹೇಗಿರಬೇಕು?
ಮೇಡಮ್ ಹೇಳ್ತಾರೆ.
ಓಕೆ, ಫಸ್ಟ್ ಸೊರಗೇಟ್ನ ಏನಾದರೂ ಚೂಸ್ ಮಾಡಬೇಕು ಅಂದಾಗ ಫಸ್ಟ್ ನಾವು ಅದೇ ಏಜೇ ಫಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ವೇರ್ ವಿ ಗೋ ಇನ್ ಟು. ಓಕೆ, ಎನಿಬಡಿ ಬಿಟ್ವೀನ್ ದ ಏಜ್ ಆಫ್ 25 to 35. ಯಾಕೆ ಅಂತಂದರೆ ಅವ್ರಿಗೆ ಮೆಡಿಕಲ್ ಕೋಮಾಬಿಡಿಟೀಸ್ ಇರೋದಿಲ್ಲ, BP, ಶುಗರ್ ಅಂತ ಎಲ್ಲನೂ, ಹೈಟು, ವೆಯ್ಟು, BMI ಅವೆಲ್ಲ ನಾವು ಟೇಕ್ ಇನ್ ಟು ಕನ್ಸಿಡ್ರೇಷನ್. ಓಕೆ, ಅದಾದಮೇಲೆ ವಿ ಸಿ ಆರ್ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಪ್ರೊಫೈಲ್ ಟು, ಗರ್ಭಚೀಲ ಹೆಂಗಿದೆ, ಗೆಡ್ಡೆ ಏನು ಇಲ್ವಾ, ಅವ್ರು ಬೇರೆ ಇನ್ನೇನು ಲೈಕ್ ಎಂಡೋಮೆಟ್ರಿಯೋಸಿಸ್, ಫೈಬ್ರಾಯ್ಡು ಅವೆಲ್ಲ ಏನು ಇಲ್ವಾ. ಫಸ್ಟ್ ಅದಾಗಬೇಕು ಅಂತಂದರೆ ಫಸ್ಟ್ ವಿ ಹ್ಯಾವ್ ಟು ಸಿ ದಟ್ ಶಿ ಹ್ಯಾಸ್ ಗಾಟ್ ಎ ಚೈಲ್ಡ್, ಓಕೆ, ಆ್ಯಂಡ್ ದೇ ಶುಡ್ ಬಿ ನಾಟ್ ಮೋರ್ ದೆನ್ 1 C-section ಬಿಕಾಸ್ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಕಾಂಪ್ಲಿಕೇಶನ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ. ಇಟ್ ಇಸ್ ನಾಟ್ ಲೈಕ್ ದಟ್ ದೇ ಗೋ ಫಾರ್ ದಿಸ್ ಅಗೇನ್ ಟೈಮ್ ಎ C-section, ಬಟ್ ಇಟ್ ಈಸ್ ಗುಡ್ ಫಾರ್ ಇಫ್ ದೇ ಹ್ಯಾವ್ ಗಾಟ್ ಎ ನಾರ್ಮಲ್ ಡೆಲಿವರೀಸ್, ಓಕೆ, ಆ್ಯಂಡ್ ದೇ ಹ್ಯಾವ್ ಗಾಟ್ ಎ ಚೈಲ್ಡ್. Then apart from this we do all the medical screening as I have told you. They are this one, lungs, everything, and the medical testing, and especially we are very much important in the 2 parts which we do. But in this country we won't see that much more, like smoking, drug abuse, recreational drugs. Where I was working abroad, yes, we had that, and we used to take into that, and we used to put the people to task to see that they are not behind that, okay. And then apart from this we used to see the screening, normal HIV, HPV, everything. And if they are good, then we recruit them. Before recruiting, it is very important to counsel them, because there are 2 types of approaches. The commissioning agents will be there, okay, they will be telling, they will be taking care in the paying guest home, or they will be left at home. When they are at home, they should be instructed regarding the diet, regarding the work they do, and regarding the personal relationship with the husband. Everything should be, and it should be of voluntary, not by coercion or by exploitation. It should not be. So we take a group, we discuss with them, and is it of voluntary, and our psychological counseling is very much important. We study them. Then
it is better to enroll them to the surrogate program, and it's very much important that the compliance is there. If there is a breach in the compliance, then it is very difficult to further do. For example, I'll give you an example here. Okay, I had a patient. Okay, she had become pregnant, she had conceived. See, we know that the couples are so desperate to have a baby, and she had become pregnant. Okay, she had a commissioning agent who was taking care. Okay, at 12th week, okay, because they receive monthly installment of the amount. Okay, 12th week, she didn't tell anyone. She took MTP pill packet. Understood? This by
but that legally is that okay?
Illegal again. She got 2 months amount now. Monthly they are paid. So nicely she took the tablet and she got aborted. And
but she can be punished for that.
Pardon?
Can she be punished according to
law?
She
didn't reveal. She told it is my national, for me it is a threatened miscarriage. But by the history later we saw that she had taken a pill. Understood? It is so important, so delicate matter, so voluntary is important, not by by exploitation or by family. Dynamics play a very much low role, because the family members first for 1 month, 2 months they can take money and they can. So we have to track them, you know. So the family dynamics, the husband, everyone plays a critical role, and it is very difficult to manage them really. And if they go through all this track, it is really a boon.
Okay, doctor, what are the latest advancements in this technology? Success rate increase ಆಗಬೇಕಂದ್ರೆ ಏನೇನು advancements ಆಗಿದೆ ಡಾಕ್ಟರ್ ಈಗ?
ನಾನು ಆಗಲೇ ಹೇಳ್ದೆ ಇದು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ಸ್ ಮಾಡಬೇಕಾದ್ರೆ ವಿ ಆರ್ ರೀಪ್ಲೇಸಿಂಗ್ ಮೇನ್ಲಿ ದಿ ಸರೋಗೆಸಿ ಮಾಡಬೇಕಾದ್ರೆ ವಿ ಆರ್ ರೀಪ್ಲೇಸಿಂಗ್ ದ ವುಮೆನ್ ಹೂ ಈಸ್ ಕೇಪಬಲ್ ಆಫ್ ಹ್ಯಾವಿಂಗ್ ಅ ಬೆಟರ್ ಇಂಪ್ಲಾಂಟೇಷನ್. I don't think illi now advanced technology is going to really work it out. Simple technology will also work it out, because illi ನಾವು ಎಲ್ಲ replace ಮಾಡ್ತಾ ಇದ್ದೀವಿ. This is not a infertile couple. Donor egg program ನಲ್ಲಿ we take a voluntary donor, criteria is fulfilled, good quality oocyte, good quality embryo can be prepared. Surrogacy ನಲ್ಲಿ ಹೋಗಬೇಕಾದ್ರೆ she is already delivered, she has already got a child, and there is no problem with her. Because infertile couple is spending so much of time, so much of money, we are not supposed to take a surrogate who is aged, doesn't have a proper uterus, proper endometrium development, all those things. We have to screen. ಅವರು ಸೂಟಬಲ್ ಆದಾಗ ಮಾತ್ರ ಅದನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡೋದ್ರಿಂದ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋ ಚಾನ್ಸಸ್ಸು ಮೋರ್ ದೆನ್ 75 ಇರ್ತದೆ. ಅದರಲ್ಲಿ ನಾವು ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿ ಯೂಸ್ ಮಾಡಿ ಒಳ್ಳೆ ಎಂಬ್ರಿಯೋ ಯೂಸ್ ಮಾಡಿದಾಗ ಡೆಫಿನೆಟ್ಲಿ ಯುನೋ ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟ್ ಇದು. ಅಡ್ವಾನ್ಸ್ ಟೆಕ್ನಾಲಜಿ ಅಂತ ಹೇಳ್ಬೇಕಾದ್ರೆ ಒಂದು ಬ್ಲಾಸ್ಟೋಸಿಸ್ಟ್ ಕಲ್ಚರ್ ಅಂತ ಮಾಡ್ತೀವಿ, IMSI ಅಂತ ಮಾಡ್ತೀವಿ, ಅದರಲ್ಲಿ ಸ್ಪರ್ಮ್ ಯಾವುದು ಚೆನ್ನಾಗಿರ್ತದೆ, ಯಾವುದು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ಅದನ್ನು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಟೈಮ್ ಲ್ಯಾಬ್ಸ್ ವಿಡಿಯೋ ಮಾನಿಟ್ರಿಂಗ್ ಅಂತ ಇರ್ತದೆ. ಯಾವಾಗ ಅದು ಒಂದು ಸ್ಪರ್ಮು ಎಗ್ ಜೊತೆಗೆ ಸೇರಿ ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಆಗುತ್ತೆ ಅದನ್ನು ಕಂಟಿನ್ಯೂಸ್ ಮಾನಿಟ್ರ್ ಮಾಡ್ತಾ ಇರ್ತೀವಿ. ಅದು ಒಂದು ಹಂತದಿಂದ ಒಂದು ಹಂತದ ಹೇಗೆ ಡೆವಲಪ್ ಆಗ್ತದೆ ಮಾಡೋದ್ರಿಂದ ಇಲ್ಲಿ ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟೆಲಿಜೆನ್ಸು ಈಗ ಬರ್ತಾ ಇದೆ. ಬಂದಿರೋದ್ರಿಂದ ಈ ಒಂದು ತಂತ್ರದಿಂದ ನಾವು ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಸೆಲೆಕ್ಟ್ ಎ ಬೆಟರ್ ಕ್ವಾಲಿಟಿ ಎಂಬ್ರಿಯೋ. ಹೀಗಾಗಿ ಚಾನ್ಸಸ್ ಆಫ್ ಬಿಕಮಿಂಗ್ ಪ್ರೆಗ್ನೆನ್ಸಿ ಇಸ್ ಮೋರ್ ಇರ್ತದೆ. ಇದು ಇನ್ಫರ್ಟೈಲ್ ಕಪಲ್ನಲ್ಲಿ. ನಾವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ಗೆ ಹೋದಾಗ ಬಿಕಾಸ್ ವಿ ಆರ್ ರೀಪ್ಲೇಸಿಂಗ್ ದ ಎಗ್ ಆರ್ ಸ್ಪರ್ಮ್, ಈಸಿ ಚಾನ್ಸಸ್ ವಿಲ್ ಬಿ ದೇರ್. ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿ ಇದ್ದಾಗ ಡೆಫಿನೆಟ್ಲಿ ಅಲ್ಲಿ ನಮಗೆ ಒಳ್ಳೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟ್ ಸಿಕ್ಕೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ. ನಮ್ಮಲ್ಲಿ ನಾವು ಸರೋಗೆಸಿ ಮಾಡಿದ್ದೀವಿ, 1 ಅಥವಾ 2ನೇ ಸೈಕ್ನಲ್ಲಿ ಡೆಫಿನೆಟಾಗಿ ಅವರು ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲೇಬೇಕು. ಆಗಲಿಲ್ಲ ಅಂತಂದರೆ ನಮ್ಮ ಕ್ರೈಟೀರಿಯಾ ಏನು ಸೆಲೆಕ್ಟ್ ಮಾಡಿದ್ದೀವಿ ದಟ್ ಈಸ್ ನಾಟ್ ಅಪ್ ಟು ದ ಮಾರ್ಕ್ ಅಂತ.
ಹೌದು, 75% ಸಕ್ಸಸ್ ರೇಟ್ ಇದೆ ಸರೋಗೆಸಿಯಲ್ಲಿ.
ಓಕೆ, ಸೊ ಫೈನಲ್ ಆಗಿ ಬ್ರೀಫ್ ಆಗಿ ಕ್ರಿಸ್ಪ್ ಆಗಿ ಏನು ಹೇಳಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀರಾ ಸರೋಗೆಸಿ ಅಂಡರ್ಗೋ ಮಾಡ್ಕೋಬೇಕು ಅಂತಾರ ಕಪಲ್ಗೆ?
First, for the couple, I like to tell them, because they will be very happy to invite a new member to the family. But sometimes the path may not be so smooth. Though we select the surrogate, there can be ups and downs. For example, threatened miscarriage ಆಗ್ಬೋದು, ಅಥವಾ ಮಿಡ್ ಟ್ರೈಮಿಸ್ಟರ್ ಮಿಸ್ಕ್ಯಾರೇಜ್ ಆಗ್ಬೋದು, ಅಥವಾ ಏನಪ್ಪ ದ ಬೇಬಿ ಮದರ್ಗೆ ಪ್ರಾಬ್ಲಮ್ ಬರ್ಬೋದು, ಬಿ ಪಿ ಬರ್ಬೋದು, ಶುಗರ್ ಬರ್ಬೋದು, ಇಂಟೆನ್ಸಿವ್ ಕೇರ್, ಬೇಬಿ ನ್ಯೂನೇಟಲ್ ಕೇರ್ ಬೇಕಾಗ್ಬೋದು. ಇವೆಲ್ಲ ನೀವು ಫೇಸ್ ಮಾಡಬೇಕಾಗುತ್ತೆ ಅಂತ ಫಸ್ಟ್ ಕೊಡಬೇಕು. ಓಕೆ, ಅದಾದಾದ್ಮೇಲೆ ವಿ ಶುಡ್ ಬಿ ವೆರಿ ಟ್ರಾನ್ಸ್ಪರೆಂಟ್ ಆ್ಯಂಡ್ ದೇ ಶುಡ್ ಬಿ in a position to see the documents, to meet the surrogate, so that they will have the attachment of the baby. Understood? And they will be involved in the program. And they will be, psychologically they should be tuned to take up the baby soon after it is born. So this is the information which I need to give to the recipient. Okay. But for the donor, we need to give many things, because they are prone for ethical risk, legal risk, health risk, okay, and financial monetary benefits. So we have to counsel them regarding everything and how we protect them, so that we will put them into ease.
Okay. Doctor, your final piece of advice.
Definitely, third party reproduction is expensive. We can replace the sperm factor, which is not costlier. We can even replace the egg factor. It is bit costlier. When they go for surrogacy, monetary wise it is becoming expensive, because we say always altruistic. Practically no woman come forward and dedicate her life for another 9 months. She has got so many accomplishment. She has to fulfill all these things. This is a practical problem. But because it is exploited like anything, government is made it no commercial surrogacy at all, altruistic. But off the record it is done. I don't think, if it is going to be continued like this, some other day, these are the things is going to surface it. Because third party reproduction, we don't know. Patient after becoming the pregnant, she may disappear. Pregnancy, she may disappear. Though she has signed affidavit, everything, legal paper, everything. What you do it? Like Madam told, MTP she has undergone. Yes. Because of commercial interest. So this is the big headache actually, we face it. But in this thing actually, poor people are the sufferer. Donor egg program, donor sperm program, and when they go to surrogacy, it is very difficult, next to impossible for them to undergo surrogacy. That's the reason why I think in future all these government medical colleges come up with IVF center where they start doing the third party reproduction as well. And for those who are really required, third party reproduction is not going to be so expensive.
Okay, thank you so much, doctors, for
But
being on
I
the
want
panel.
to give a message. To prevent all this, early marriage is very important. Then to maintain fit. Okay?
Early marriage and early children
Early,
also.
yes. What in our olden days we are doing, 21 years, 20. But
Lifestyle
you
is
cannot
changing,
have,
madam.
and they should keep fit, and they have to plan. The women are dynamic, so women should be broad-minded and take up the family first. They can earn later.
Thank you so much, doctor. Thank you so much for being on the panel.
Thank you, everybody.
Wow. Thank you so much, Dr. M.S. Srinivas and Dr. Bharati Rajanna, for navigating these complex topics with such clarity. Can we all give them a huge round of applause for delivering such an informative panel discussion? And special thanks to Archana ma'am for driving this so well. Innonsati jorada chappale barta irli. I request Urvi Mehta, Senior Vice President, Brand First, to kindly come forward to give away mementos to our panelists and moderator. Thank you so much, ma'am. Thank you so much, sir. Let's all stay together for a group picture. Dear friends, here at the Path to Parenthood event, we've been learning a lot about how to embrace parenthood the right way when you're facing challenges. And we also learned about Hoopsters, a hybrid non-academic education platform that has a community that provides the right resources, curated programs, and continued engagement to help achieve this goal. Primarily, they focus on mental health, parenting, life skills, and sustainability. Well, we have somebody now who is coming forward to share with us her personal story. Deepika Murthy is a passionate advocate for adoption, and she herself is an adopter, a healer, wellness facilitator, a psychodramatist. She understands emotional well-being and clarity so perfectly. She is here to share with us her personal story. Deepika, the stage is all yours.
Thank you so much, Privil. Thank you, audience, for being here, taking time out on a Sunday for such a beautiful event. When Bala, our Hoopster team boss, we call him, when he told me about this event happening and if I would love to share my story as an adoptive parent here, it kind of brought back a lot of memories. Memories not just of, the technical process of adoption, but I think an emotional journey. And I'm right here to share a dream. But before I share, I would love to at least see you people raising your hand. How many of you have dreamt of something like in your sleep, the real dream? And then it just came true. You never expected that it'll happen, but it did. Can you raise your hands if it has ever happened? Oh, lovely. How about the group here? Yes, sometimes we don't even remember our dreams, but yes, very often some things just happen and we recall, oh yeah, I did dream about this. I want to start my story with this beautiful dream I had. This is back in 2009. I started having this very vivid dream. It's going to be a little graphic, quite weird, but you'll know why I dreamt. So now I am there, there's a table in front of me, just like you have a table right there. And I'm standing there, there's a table there, and something is happening, something very physiological is happening there, as if there's a surgeon there and, cutting open somebody's womb and bringing a baby out. And it was visible. And he took that baby out from an apparent womb which is out of the body, kept on a table, and he hands that little fetus in my hands. Okay, now this was very graphic and very disturbing initially when I woke up from my dream, but it didn't leave me. It's like, the more you run away from something, it follows you, and that's what happened with me. And this dream kept coming to me recurrently for almost 5-6 years. Fast forward to 2014. October 2014 is when I registered with Kara, my husband and I, because we always wanted to adopt. We had a biological son. He was already 3 years old. And because we always wanted to adopt, we decided, nahin, bas ab to karna hai, bhai. And we did that. And the moment I registered, that dream stopped. And that is what had happened. Something that was coming to me so fervently in my dreams finally came out in reality. And I think it's one of the rarest dreams that came true for me. The rest of them have died a natural death. But yes, this one stayed. Fast forwarding again to 1 year, 2015 is when if you all are aware, there are a lot of adoption rules that changed. Menka Gandhi brought in, I would say, some very practical rules of adoption where, you can't really choose an agency anymore, because most of the times that would happen. You choose an agency and then you go and get your baby home and you do a selection procedure, etc. But things change. So now you have like a username, password, you have like a login ID, very professional. And then you log in and you'll know after registration where do you fall in that entire list, the waiting list. Now these rules changed, and we had already registered in 2014 with an agency, and then suddenly it was like, nay, not this agency. Something else is going to happen. Now you just have to choose your state, and if there are babies available, we will propose the babies to you. This part was a little unnerving because it was like as if we are doing some Amazon shopping, putting the babies in cart and then choosing later what we do. But then probably it was for the bigger picture, the bigger good, because that process ensured that all babies get a chance of being adopted, which otherwise was not happening because there were so many agencies which parents would not deliberately choose, and which left so many children parentless and parents childrenless. So I was kind of happy, and then whoosh, within a month is when I brought my daughter home. She's Asavari. I named her Asavari because the name of a beautiful rag. And my son Arav, who was 4 years old when his sister came. And I think that was the most beautiful part. It's not just about being an adoptive parent, but also being a parent of a child who is seeing adoption happen, who is seeing a sister coming home, not out of his mother's womb, but a sister who is just handed over to his mother. And he was the first one, even before my husband held his baby, my son held his sister in his arms. He was there throughout the process. It was an arduous process, I agree. Emotionally very draining because you have to keep waiting, but it was worth the wait. And it was 2015 when my daughter came home. 9 years today, everything is still so fresh. But at the same time, one thing that I always felt and I would share is, I never felt anything different. Now, you know, we, unfortunately in our society, adoption is labeled as charity, or, oh wow, you're doing great. Oh, you're doing such a great thing that you're adopting a child. No, that's absolute rubbish. You know, love is what comes out from within. It should not put you on a pedestal. It should ground you. If you're ready to give and receive love, you should be ready to break your ego, break down yourself into a million pieces and renew yourself into a new human being. You cannot accept love if you feel that you're doing a favor by giving love to somebody. And I think that is where the whole mindset has to shift. It has shifted, certainly. It's very different now. The very fact that we are having a talk about it means that there has been a great shift over the past years. Otherwise, it was like, hush, don't tell. The children didn't know. The children anyway were never told. And, you know, even family members, no, you can't tell your family members that we have adopted a baby, you know. So, normalizing something, normalizing parenting, I would say. What is adoption? It is another route of parenting. Why are we attaching so many labels to it? We are choosing. Are we choosing? How many of you feel that you choose to adopt? How many of you feel? Raise your hand, like honestly, that you choose to adopt. Sorry to break your bubble, but you don't. Because I very honestly feel we don't choose. The children have chosen us. We are chosen. And that is why we were there. That is why something changed in us. So when we say adoption changed me, no, my dear. The transformation had already happened in you. That's why the change had already been, the seed of change already sprouted in you, which is why you were there, ready to accept your child. So saying that, oh, this child is my adopted child, would you say, would you label your child which has come out of your womb at, oh, meet my biological child? We don't say that, right? Meet my biological child. This is my womb child. We don't say that. So child is a child. That's my daughter, that's my son. If you are ready to remove all those adjectives, labels from your own ego self, that, oh, I'm doing this, and you know, this child is this, from yourself and from your child, oh yeah, you're ready for parenting. And I think it's not just about adoptive parents, it's about parenting itself. You know, when you become parents, you don't attach so many labels to it, so many adjectives to it. Do you say, oh, you know, I am an average parent, or you know, I am a biological parent. You don't attach adjectives, then why to adoption? And therefore, the question comes to, are you really ready? And why are you adopting? The intent. I do agree. Most of the decisions, most of the alternate routes of parenting are chosen because 90% of the times it starts with a desperation. That yes, you want to become a parent. And because a natural way is not working, or probably the IVFs have failed, maybe surrogacy is not on your list or not acceptable, okay, then shall we adopt? So somewhere, adoption has become like the last option. Arey kuch nahi ho raha hai, to chalo adopt kar lete hain. And this is where we commit a mistake. Don't do it. I always tell parents, if you're doing it because you're so desperate to become a parent, please don't do it. Because it is going to reflect. It is going to reflect on parenting. You'll always keep telling yourself that, Arey maine kiya kyunki mujhe karna tha. Sorry, I'm just using some sprinkles of Hindi if you're okay. And that is where there's a lot of self-questioning, self-introspection, which is required when you decide to adopt. For me, I always wanted to adopt, but then, back then, yeah, younger days and more vulnerable and more impressionable. Then the parents, you know, my parents were like, nay, you know, do it, why don't you try natural way and all that. So it was a bad phase for me where I somehow felt pressured into having a child naturally, although no regrets today. But even then, there was this thing, let me adopt twins. And, but, you know, under the pressure, okay, chalo, we'll have, our baby. And that's when my son, Arav, happened. But then, after that, it was like very, very clear, ki nahi. Now, it's like I'm telling my parents, now enough, huh? Now don't ask me for another one. Okay, just keep shut and let me do what I want to. And that is when all of this happened. And I would definitely also want to share a very personal incident. It's personal, it's very, very intimate. Nevertheless, I think this is the right platform to share. When my daughter was about to come home, I was prepping for her. I was very keen to breastfeed her. And everybody was like, no. How can you breastfeed your child whom you're adopting? Your body is not ready. You're biologically not ready to breastfeed a child. Trust me, 100%, including my husband. Okay, this is a bad idea. I mean, really, what all do you dream of? What's wrong with you, woman? I said, ye to karna hai. I was very keen because I am also a great advocate of breastfeeding. And she came home. I tried, so I wanted to go to the doctor. The gynecologist gave me Shatavari and this and that, and many things happened. I was not able to take any of those medications because that's what the doctor said. You take this, we are hoping that it is going to induce some milk production. And I couldn't do it because we were running around with paperwork. And then Asavri came home on 9th September. 10th September onwards, I decided whatever it is, I will have to do it. And I did it. It took me 4 days, that's it. And I think 5th day, when I started breastfeeding my girl, everyone was like, are you sure? No, are you hallucinating? Drugs liya hai kya? Ye kaise ho sakta hai? You didn't take any medication. How can that be possible? Well, why not? People do all kinds of things in love. Why can't love produce nice hormones in your body? The first relationship of a mother with a child, the personal, the contact is here. This is where love comes from. So why can't I? If there is love, oh hell yes, there is milk. And I think that is one day where I reassured myself, hey, this is something else. I didn't choose Asavri. She chose me. She chose me to be her mother. I am privileged. She did not get a home. I got a child. The second label that we need to remove is that we are giving a child a home. No. Yes, a child is getting a parent. But more than that, you are receiving that. You receive love and you'll be so full of it that it'll be so much easier. Love will flow out of you. And I think one of the many really miraculous and magical experiences I've had in my adoption journey. I mean, I can sit here and talk till cows come home, but I'm not going to do that. But this is, I think, top of the list. And after that, of course, life, okay, can I say life has been, oh wow, great, Asavri came? Nahin. Life has been what life is. I have 2 children, I am running around like a headless chicken, and I have my own share of problems. So, कुछ नहीं होता है दिमाग में कि adopt किया है या I have produced from my womb, doesn't matter. At the end of the day, it's all. But at the same time, if I find myself, there's a lot of self-work. There is a lot of emotional work and self-work which is involved in this whole process, where I have to make sure I don't treat any of them better or worse. What happens is many times parents try to be nicer to the child they have adopted, thinking, arey, no, they will feel the difference. Trust me, they will feel the difference if you try to treat them better. They will feel, arey, why is she being so nice to me? And tomorrow, later on, now since, it is recommended that let the child know where the child has come from. It's good, it's healthy. It's better that it comes from the parent and not from dadi, nani and friends and family members. Because yes, we have to be ready. There will be a moment of identity crisis that the child is going to feel once the child comes to know. But if you are, the child has to feel that you're right next to him or her. That, first of all, I know it. There is awareness. And secondly, I don't have to second guess anything because there's so much of love. So that boils down to the point, again, to the third label of, or the, I would say, the misconception of hiding things from your child. Make it a normal process. Be with the child. And this is what, every day we are trying to do. That's the least we can do. Stand by your child. Stand by what the child gives you and what you give the child. And being a practitioner, the responsibility lies even greater on me. that I make sure that my children, and before my children, I am emotionally and mentally sorted enough to make wise, informed decisions when I am parenting. Adoption is just another route of parenting, and that's all we need to know. It's not fashionable, it's not something great, it's not charitable, it doesn't make you a great human being, no. It makes you as normal, as helpless a human being as anybody else. As probably another parent who's been trying to have a child through either natural ways or IVF or anything. And this is where I would like to share a small poem I wrote a couple of years back, 4 lines. A bond beyond the bones, across the flesh and atoms apart. For only in biology books do cords connect the navel. In love, they connect only the hearts. Thank you very much. I'm Deepika Murthy, a parent, normal, running parent of 2 children. Thank you. If anybody has any questions, anything at all, I am right here. Please feel free. Thank you.
Deepika, a post-lunch session. Everybody is attentive. I'm sure the folks listening to us on YouTube as well, they were attentively listening to you. Thanks for sharing your story. Ladies and gentlemen, a huge round of applause once again. Adoption doesn't change you. That's what Deepika said. Instead, you are drawn to adoption because a transformation has already begun within you. Thank you so much once again, Deepika. And I now request Mr. Ashutosh Dwivedi, CEO of Wiley Health, to kindly come forward to give a memento, a token of appreciation to Deepika. Can we all give a huge round of applause? Thank you so much, Ashutosh sir. Path to Parenthood 2024, an initiative by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Wiley Health. Well, we have reached to the last segment of the day. We are going to have a panel discussion, but I want all of you to let your friends, family members, colleagues, your friends and people whom you meet day in and day out to watch, follow the content which has streamed live on NewsFirst. So you can search and find us on YouTube as well. Now, we dive into PCOS, PCOD, weight management for natural or assisted pregnancy success. Our panelists for this session are Dr. Madhuri Patil, fertility expert and Vice President ISAR. Can we all give a huge round of applause and welcome Dr. Madhuri Patil onto the stage, please? Ms. Swati NG, nutritionist, a warm welcome to you, ma'am. And to moderate this session, I kindly request Mrs. Archana Ravikumar, senior journalist, a warm welcome to you as well, ma'am.
Good afternoon, all of you. I think after a heavy lunch, we'll be now talking about weight management and obesity. I don't know how much that will help. Doctor, actually, as we know, any girl we talk to, 90% of them, they have this PCOD or PCOS problems. And definitely that affects fertility. What is your take on that?
I would like to say that today PCOS is overdiagnosed, and it's very important that we do not diagnose PCOS in an adolescent. We need to wait for at least 8 years post-menarche or till she is 18 years. So if you find that the features of PCOS are there in the adolescent girl, we have to label her at risk and then come to a final diagnosis only when she's 8 years post-menarche or she's 18 years. This is because there are certain features of PCOS which are present in an adolescent, which is physiological. Like a girl who's just got her menarche also will have acne, so that's one of the features. And the other feature of PCOS basically where we say that she has polycystic ovarian morphology. So that is normal physiological in an adolescent girl. And therefore, most of the diagnosis happens wherein the patient comes with obesity, because nowadays, because of the fad diets as well as eating outside and the lifestyle, obesity is very common right in the children as well as when they become adolescents. And so what happens basically is that because of that also they have irregular cycles, and usually in the first 2 to 3 years of normal puberty you have irregular cycles, and it takes that much time. So we should not label any adolescent as PCOS till she reaches reproductive maturity, because there are certain features which resemble PCOS are present normally.
Okay. Ms. Swati, are there any specific diet strategies for people suffering from PCOS or PCOD?
Yes, there are definitely diets that can help to manage PCOS and sometimes even reverse. So to an extent, first thing, it should be a realistic diet plan which can be followed over a long period of time, because PCOD or PCOS is not something just that comes and goes. So it's a management. So basically it would be a lifestyle change, the difference in the way of eating. Second would be physical activity, as doctor was also mentioning. Being active is a very important part. Maintaining your weight, because for most of them who lose weight, maintaining that weight is also very difficult. So the follow-up diet that we give should be more doable. And then of course certain supplements can definitely help. Even the doctors do suggest, as well as we do.
Doctor, actually early detection of PCOS or early weight management, how does that help with fertility and PCOS?
Usually obesity is seen in about 60% of the women who have PCOS. 40% of them are lean PCOS. Though they are lean, basically they also have visceral obesity, because most of especially the Asian population, they are sarcopenic. That is, they have less muscle mass and more fat, and it's basically the visceral obesity. So though it's a lean PCOS, they do have visceral obesity or central obesity, and that's basically related to hyperandrogenism, because we need to know that PCOS is a combination of hyperandrogenism. So when we diagnose, if we see any clinical features, especially hirsutism, more than acne or female pattern of balding, or any other signs of hyperandrogenism, then they should have irregular cycles. So if these two are present, we directly diagnose them as having PCOS. But in case she has only menstrual irregularity and she does not have any clinical features like hirsutism or acne, then we probably do blood test wherein we look at the androgen levels. And if both are there, then we diagnose them as PCOS. But only if either of them is there, then only we require today an ultrasound where we have a polycystic ovarian morphology for diagnosis of PCOS. So basically what happens is that we really don't know whether it is obesity which results in PCOS or PCOS which results in obesity. That's still very debatable, because we have evidence for both of them. But it is usually seen that usually the hormonal imbalance which is seen in women with PCOS is exaggerated in the presence of obesity, and therefore the clinical symptoms also get exaggerated. Plus, obesity is associated with insulin resistance and hyperinsulinemia, which are then the main cause of anovulation and several other metabolic dysfunction. Though insulin resistance and hyperinsulinemia is not included in the definition of PCOS, it is one of the main criteria later on which results in infertility as well as in metabolic dysfunction.
Ms. Swati, today both micro and macronutrients are posing a problem. So how important is it to balance both of them?
Yes, macronutrients, not just counting carbohydrates, proteins and fats. When it comes to micro, especially in terms of PCOS or if you're trying to get pregnant, is a very important aspect. So coming to the research, as we have come so many years researching about PCOS, a low carbohydrate diet, or even if we go to keto, that is what we recommend currently for managing PCOS, and along with that a few supplements that we want them to take, so that, as ma'am was also saying, there would be certain features which is showing up and may not necessarily be PCOS altogether. So to manage that as well, like ma'am was saying about acne. So chromium is a great agent to help with acne reduction. So such things can be added into their diet via food.
Okay. Doctor, sometimes just lifestyle changes will not help. Like some treatments like ovarian drilling and ovulation induction therapies are also there. Can you elaborate on them?
The treatment basically in a patient who has infertility will depend on several factors apart from having PCOS. One is age of the patient. So if the age of the patient is more than 35 or 36 years, it's best to go on with the treatment for infertility straight away and not wait for lifestyle interventions. Duration of fertility, if it is more than 3 years, plus if there is presence of any other infertility factors, like if the patient has associated endometriosis, she has associated adenomyosis, fibroid uterus, or she has infection because of which she has blocked tubes, and there is a male factor, then basically we should not wait for lifestyle. If she is less than 30 years, yes, we should surely give her at least 3 to 6 months for reducing her weight, because that might result in a spontaneous pregnancy also, or it might decrease the amount of drugs we give and also improve the success with the treatment what we are offering. And the best drug, the drug what we use is, we start with the oral oval agents, and what we use today is letrozole, and it is normally given for 5 days from day 3 of the cycle till day 7, and then the monitoring of the follicular growth is very, very important, because it does not make sense when you're taking the tablet and you tell the patient, oh, you have sex on alternate days, because many a times they do not respond. So we have to know whether they respond to the drug or not. So that's very, very important. So from the 9th day onwards, I think doing follicular monitoring either daily or on alternate days is important. Once the follicle is about 15 to 16 millimeters, probably you need to do it more regularly, because the follicle can rupture at any time. Because once the egg is released, basically, though it is alive for 24 hours, it's fertilizable only for about 12 hours, and therefore knowing the exact time is important. If she is resistant to letrozole or she does not conceive with letrozole, then one can go for clomiphene citrate. But with clomiphene citrate, the disadvantage is that many a times, because of its anti-estrogenic effects, it results in a thin endometrial lining. So in these cases, probably tamoxifen, which is also a estrogen receptor agonist, can be used. If the patient fails to conceive with either the oral, either clomiphene, letrozole, or with tamoxifen, then we need to go for gonadotrophins. Though initially ovarian drilling was considered as a second line of treatment, all the recent evidences are against doing ovarian drilling, because it has been seen that many a times ovarian drilling causes loss of follicles, and then the patients have premature menopause, and it can also result in adhesions if it's not done properly, and this can then prevent a natural conception, and then you have to go for basically for ART.
Ms. Swati, sometimes it happens that, from what I've heard, people with PCOS and all have these cravings for eating things. Is that true? And if yes, then how do you actually manage them?
Yes, they do have a lot of emotional eating, or I would say binge eating. So this is mainly to do with what ma'am was saying, hyperinsulinemia. So this just doesn't mess up your insulin, but also messes up your brain. So it almost shuts down your cortex, which is the main area where you will be able to make logical judgments. So this is a calling towards food when you're really not hungry. So you just satisfy your other feelings through food. So one way to overcome this situation would be have lot of variety. So the more variety available in food makes them more available for options they can snack on. Second, the options should be healthy. Mindful eating, that is what we say. And the third would be portion control.
Doctor, how does weight actually influence miscarriage and infertility? What are the complications generally for obese people?
Yeah. So basically, we can divide the effects of weight into several categories. One is it affects the hormones, so whatever hormonal abnormalities there, it is enhanced by obesity, like the insulin resistance is increased, the insulinemia, there's hyperinsulinemia is increased, the hypoandrogenemia is increased, and basically directly it can also affect the ovulation. Second is when we are treating the patient, obesity increases the amount of drug which is required. It can extend the time of ovulation, that the number of days required for ovulation. Plus, in a patient who is not taking treatment but is ovulating, like you have 4 phenotypes. So there is an ovulatory phenotype also wherein the patient ovulates, that is the phenotype C which is there. So these patients are ovulatory, but then it can delay the conception in this group of patients. Once pregnant, it increases the chances of miscarriage, and this is basically related to hypoandrogenism as well as hyperinsulinemia. And along with that, it has been seen that those patients who have basically high AMH values and who have an abnormal glucose hemostasis in the blood, hyperhomocystinemia, which is also seen in patients who have PCOS along with vitamin D deficiency. This increases the chances of preterm delivery, of miscarriage. Then there's also an increased chance of preterm delivery which is seen, and usually pregnancy associated complications like pregnancy induced or hypertensive disorders of pregnancy and gestational diabetes has a higher incidence.
Okay, Ms. Swati, about nutrition. Now, when a couple is undergoing fertility treatments, how much does diet influence and what is the success rate you have seen?
So weight loss, as ma'am rightly said, is a very important aspect, and even a 5% weight loss can account to a lot of fertility betterment, or I would say the quality of the embryo is better and her chances of ovulation also increases. So maintaining a healthy weight and having a gradual weight loss is very important. And definitely people who are trying to conceive, even naturally as well as assisted, should definitely opt for weight loss if they are in the overweight or the obese category. Otherwise, should at least adopt to a healthy lifestyle.
And doctor, what are the latest technology available to treat PCOS?
Pardon, I didn't get.
Latest emerging treatments and technology.
Yeah.
To treat PCOS.
So basically, there's nothing new which is there in ovulation induction. So it's basically use of the oral ovulants which we were using for so many years. When we talk about the gonadotrophins, we can use, though we have recombinant gonadotrophins now, but it has been shown with several RCTs as well as the Cochrane report has shown that there is no difference in the pregnancy rates as well as ovulation rates whether you use a recombinant gonadotrophins or you use urinary or ultra pure gonadotrophins. There's a new concept now which has developed that talks about the gut dysbiosis. It's said that PCOS is associated with gut dysbiosis, and therefore probably treating these patients with prebiotics and with probiotics may be helpful, and more so in obese patients because obesity definitely alters the gut microbiome. Then coming to the insulin sensitizers, basically what we are using year long for more than 100 years is metformin, and it is supposed to be very effective, though it has some gastrointestinal side effects. But in some patients who cannot tolerate metformin, probably inositols can be used, but the evidence for using inositols is not much, and basically it is a nutraceutical and it's present in the normal diet what we are having. But now we are having the GLP-1 analogs which have come into the market. In India, they've just come recently, and they include the liraglutide and the semaglutide. The liraglutide is basically injectable, but the semaglutide is an oral preparation. And this helps in reducing the insulin resistance, as well as it also helps in weight reduction. So it is more effective in reducing the weight as compared to metformin when the GLP-1 analogs are taken.
So metformin is something which is widely accepted for fertility treatments. Metformin is widely accepted for fertility treatments.
Metformin itself does not cause ovulation. Basically, when you add to oral ovulants, like if the patient has not ovulated just by giving clomiphene or letrozole and you add metformin to it, it has been seen because it reduces the insulin resistance, it increases the glucose uptake in the muscle, so the glucose hemostasis is achieved. And basically, it also has its effect on the liver, where it increases the sex hormone binding globulin, because if it is reduced, the free testosterone or the androgens are more, and the estrogens also are more, and this can affect the ovulation as well as the growth of the follicle. So it increases the SHBs in the liver, and therefore the free testosterone and the free androgens also reduce, and therefore it improves the ovulation rate.
Ms. Swati, you were mentioning about supplements. Can you precisely tell us what are the supplements to be given to PCOS people?
Sure. So mainly we concentrate on few of them. The first one would definitely be vitamin D, because research has shown that severe vitamin D deficiency is mainly associated with insulin resistance and also increased risk of cardiovascular disorders and decrease in the production of healthy eggs. And the second supplement that we would definitely recommend is omega-3 fatty acids. As we know, it's an essential fat, and essential fats are very, very good for improving the health of the embryo as well as proper ovulation. It also flushes out the bad cholesterol, keeps you healthy, keeps you active. Then third definitely is folate. So folate, as doctors also prescribe it pre-pregnancy. So this also improves the quality of embryo, and to an extent it also improves your insulin sensitivity. And there are definitely other small ones, like I was talking about chromium and inositols. These are also recommended, and to an extent even cinnamon extract.
I think folate is advised immediately when they plan for conception itself.
Yes.
Doctor,
so
what
basically when we are talking about the nutraceuticals, I would like to add that probably CoQ10, which is an antioxidant, helps in women with PCOS, because usually these women have the oocytes, because of the abnormality in the hormones, have a lot of mitochondrial dysfunction. And this mitochondrial dysfunction then can affect the fertilization rate as well as the embryo formation rate. And therefore giving CoQ10 in this group of patients would really help them in conceiving.
So doctor, what is insulin resistance in PCOS, and how does it come in the way of natural conception?
So basically what happens in PCOS is that there is a insulin receptor dysfunction, and this then is seen in the pancreas. This results in increase in the secretion of insulin. This secreted insulin has different effects on different organs in the body. So in the liver, basically it reduces the sex hormone binding globulin, and therefore there is increase in the androgen levels. It also acts on the adrenal gland, where it increases the DHEAS, and it also acts on the ovaries itself. So in the ovaries you have the egg, you have the granulosa cell which covers it, and then you have the theca cells. So it is the theca cells which produce the male hormones or the androgens. So what does insulin do is it increases the production of androgens over there, and it decreases the ability of the granulosa cells, because this androgen which is produced in the theca cells goes into the granulosa cells, and here it is aromatized into the female hormone or estrogens. So it prevents the aromatization of the hormone because there is reduction in the P450 alpha 17 alpha enzymes which are there, and therefore it again increases the androgen levels. And therefore in this, so the as it is, the PCOS women have high androgen levels, and this hyperinsulinemia in turn increases the androgen levels. Moreover, in the muscle it decreases the uptake of the glucose, and therefore what happens, there is impaired glucose tolerance, or there is also basically diabetes mellitus, and in the adipose tissue it increases lipolysis with dyslipidemia. Moreover, it also has action on the follicles. So in the follicles, because of the high androgen levels, it inhibits the meiotic changes, because all the eggs are basically arrested in 46 chromosomes, and if they have to be fertilized, they have to there has to be a reduction division to 23, which does not happen. And as it is, obesity which is there and is one of the main features of hyperinsulinemia and insulin resistance, basically results in inflammatory changes, and therefore the endometrial receptivity or the acceptance of the endometrium to the embryo is also affected.
Ms. Swati, there are so many popular diets like intermittent fasting and many other diets. Do they actually work for PCOS?
Yes, but to an extent, how much would you be able to follow? As I was saying earlier, there is ketogenic diet, there's even intermittent fasting. So intermittent fasting is actually not a type of diet, it's a way of eating. So when you follow it, if your adherence is 100%, then definitely you will be able to see the results. But mainly for PCOS, I would say intermittent fasting is a great way of eating, because you're eating according to your circadian rhythm, where your insulin is high or where the production is good, that time you're eating mostly, and where your insulin needs rest or keep up its sensitivity, that is during the night, you're not eating.
Doctor, what is your final piece of advice to our audience watching you? Your final piece of advice to the audience who are watching you?
Yeah, so basically one must know that there is an intrauterine origin of PCOS, and this is related basically to a lifestyle. And because of obesity or an altered lifestyle, or if the mother herself is having PCOS, or she smokes or she drinks, there is abnormal environment in the uterus, and this then results in several affections of the fetus, wherein there could be miscarriage, there could be decreased growth of the child, and they also could be epigenetic and genetic abnormalities. This decreased growth of the child is called as the thrifty phenomena, and when the child is born, it starts getting abundant food, and because of that they put on weight, and this then results either in early menarche, or it can result in menstrual irregularities, it can result in obesity, and today we know that obesity has become a pandemic all over the world, and I think it's because of our lifestyle. And I think most important, I feel, is that we have to improve our lifestyle. We should not eat much outside, because when we eat outside we cannot control what we are eating, and therefore healthy eating is very, very important. And once they reach their menarche, again we have to look at their weight gain, and also we have to look at their mental health. That is very, very important, because it has been seen that if you have there's a lot of competition, and there's a lot of stress, there's a lot of anxiety. This in turn then alters the hormonal imbalance, and this can trip your balance, and you can still become, develop symptoms of PCOS. Moreover, now we've seen there's a lot of, sexual, pre-promiscuity which is there. And because of that, the girls have started taking oral contraceptives. This again can affect your hormonal imbalance, and that can also lead towards your PCOS. When you come to your reproductive life, it's again weight control, lifestyle, and it's best to conceive earlier. And if not possible, because today, because of their education, because of their work, they might not be able to want to conceive early, so then we still have the option of going for social egg freezing. So your eggs are basically of younger age, and whenever you want, till the age of 40 or 45, because in India we cannot do IVF for a patient who is more than 45 years of age is one of the options which is there. But I think lifestyle is the most important, and in this, apart from your diet and exercise, sleep is very, very important. Reducing stress is important, as well as avoiding smoking as well as alcohol, because I think that's become very common.
Ms. Swati, would you like to tell anything to the couple who are looking at weight loss?
Sure. So the main thing here is knowing your food. So knowing what can cause the insulin surge. So if you know the foods that can have controlled surge of insulin and still get your energy from that, so that could help. Giving a diet plan which is very easy for them to follow and they would keep it consistent. Third, when you go out, especially as ma'am was also mentioning, don't resort to junk food. Eat mindfully. Choose the snacks very wisely. And fourth, definitely lifestyle. Keep yourself active, exercise, or at least do any physical activity that keeps you happy, because happiness is something which goes against the cortisol.
I think an anti-inflammatory diet is very, very important. And I would also, my last message would be that PCOS starts in utero, and therefore the mother-to-be has to take care, then she has to take care as a child, and the child, when it becomes big, also needs to take care. So this is a very important message, I think, which we need to know. And it is the male siblings also have PCOS. There's something called as male PCOS, wherein it has been seen that the male siblings and the male relatives of the female PCOS are having a higher incidence of metabolic disorders like diabetes mellitus. They have increased incidence of hypertension and cardiovascular disease.
So consistency is the key for weight management, I would say.
Yeah, I mean, weight management definitely reduces the incidence of cardiovascular events, and also it keeps your diabetes and hypertension under control. So as I said, lifestyle modification is the most important thing when we talk about PCOS, and one must remember that's only not in the female, but it's also in the male.
Thank you so much for being on the panel.
Thank you.
Thank you, doctors.
Thank you.
Ms. Swati, Dr. Madhuri and Mrs. Archana Ravikumar, thank you for those practical and valuable insights on the importance of weight management in fertility. Can we all give a huge round of applause for the panel, ladies and gentlemen? I kindly request Mr. Maruti S.H., Editor-in-Chief, NewsFirst, to kindly come forward to give away mementos to the guests. Let's all join for a group picture. Dear friends, since yesterday morning, we had a 2-day Path to Parenthood 2024 event, wherein a lot of you turned up here, and we also had viewers engaged on YouTube. Thank you so much for being so participative and making this event a memorable one. I also want to thank our Honorable Minister Shri Dinesh Gundu Rao Minister of Health and Family Welfare, Government of Karnataka, for inaugurating this event. I am also grateful to our organizers, team Path to Parenthood 2024, initiative by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Wiley Health, all the exhibitors, healthcare professionals, media professionals, participants, and thanks one and all for making this a memorable one for all of us. I now kindly request the organizers to kindly come upon to the stage. First and foremost, I request the team NewsFirst, Ravi Kumar sir and Maruti SH sir to kindly come onto the stage. Can we all welcome them onto the dais, please? Also, team Wiley Health, Vijay Gopal, Ashutosh Dwivedi and Pooja, I request you all to come onto the stage. Team Brand First, Urvi Mehta ma'am, Neeraj, Sheetal, Raghavendra. I request all of you to please join us here on stage. I also request Sriram sir to kindly join us here on the stage, please. Let's all join together for a group picture.
Hello.
I also request the extended teams of the organizers and exhibitors to be ready. We'll quickly capture a group picture. Yeah. Go in the center of the stage. Live stock money. Can we all give a huge round of applause for the team of organizers? I request all of you to kindly join us here on stage, all the participants, the folks behind the screen, the entire team of NewsFirst. Yes, quickly join us here on stage. Our volunteers. Okay, the photographer is trying so much, but none of you are reacting. So when I say 1, 2, 3, everybody please smile, okay? At least smile. I know all of us are tired. 1, 2, 3, smile. Okay, this is the last picture. When I say 1, 2, 3, all of you thumbs up and in the front and say 1, 2, 3. Shout out, everybody. I know there's no energy, but that's all right. Because you're the folks who work behind the scenes, and thank you so much, guys. Means a lot.